through this event alongside me. Together, we look forward to making this session engaging, insightful, and memorable for all of you. A warm, very welcome to all our esteemed speakers, dignitaries, faculty members, clinicians, researchers, students, and participants. Today is a very special day for all of us. Not only are we here for a seminar, but we are also marking the beginning of something deeply meaningful. Today, we come together for the National Seminar on Enabling Optimal Brain Development and Cognition After Childhood Heart Surgery. And alongside this, we are also inaugurating the Neurodevelopmental and Cognitive Care Unit within the Department of Pediatric Cardiology. This unit represents a significant step forward in how we approach care. And supporting this vision is Project MEDA, a CSR initiative that enables us to build structured, accessible, and long-term neurodevelopmental care for children with congenital heart disease. This is a shift in thinking, a shift from saving lives to shaping lives. Because today we recognize something very important, that healing the heart is only the beginning, and the journey of the brain, development, learning, and emotional well-being continues long after. Today is not just a seminar, it is a movement toward integrated holistic care. Over the past few decades, pediatric cardiology has transformed survival rates in children with congenital heart disease. But survival is not the destination, it is the beginning. To help us understand this shift in perspective, we have with us someone who has been at the forefront of pediatric cardiology in India and globally. Dr. Krishna Kumar, professor and head of the Department of Pediatric Cardiology, is a clinician. He is a visionary who has shaped how we think about cardiac care beyond the operation theater. Sir brings with him over 4 decades of experience in the field of pediatric cardiology. He's a widely respected clinician, scientist with an extensive body of work, having authored and co-authored numerous research publications in national and international journals. His contributions go beyond individual patient care. He has played a pivotal role in advancing pediatric cardiac services, building systems of care, and mentoring generations of clinicians. What really sets his work apart is his ability to bring together science, systems, and long-term outcomes, helping us look beyond survival toward quality of life. Sir will take us through what CHD looks like today, beyond survival, and why the next frontier is neurodevelopment. May I invite Sir to take the stage.
Thank you, Alina, and welcome everybody. I don't think we have the full audience yet. So the first talk is actually to set the stage on what congenital heart disease is all about, what has happened in India, and some interesting facts, but really it's just an introduction more than anything else. So the journey has been quite long for congenital heart care in India, but I'm going to start from some basics. I'm not able to move these slides. I think I'll try and use it. Okay, fine. So a little bit about the heart. You know, for those of you, I think there's a mixed audience here, so I'm not going to, the people who are from my department will find this too basic, but for the rest of you, this is a very simple line diagram of the heart, which tells you that there are 4 chambers, 4 valves, 2 great vessels, and they all are meant to come together and function in an extremely coordinated way. And there are just a million possibilities when it comes to defects, and these are some examples of heart defects. What you see below is a defect between the 2 lower chambers called the ventricular septal defect, but these are the simplest of defects. But before we do that, before we go to the complex defects, we have to understand the heart functions in a way where the blue blood or the blood without oxygen is very clearly separated from the blood with oxygen. And this whole circulation is beautifully, works so well in so many people. But the children who are born with heart defects, things can go wrong. So one most dramatic example is when the great vessels, the vessels that are meant to supply the lungs and the heart and the body, are switched, called the transposition, when you get blue blood into the whole body. So this is the most extreme form, and you have a whole range of possibilities which exist. And these are pictures from Dr. Balaji. Just some examples of what all can go wrong with the heart. And these are only a small fraction of what can go wrong. There's just numerous possibilities of conditions, and you don't need to get into those details. But the bottom line is that when a child is born with a congenital heart defect, we can have a whole range of conditions that can immediately threaten life versus those who can, you can live with them. So this question I ask very often. So just for everybody to know, this is based on some very good information that we have, data. So, in India, in our part, most of India, one of the commonest causes of death now is congenital heart disease in infants. So it's ranked anywhere depending on where you live, either in the top 4 or between 4 and 8. So if you're in Kerala, it's in the top 4 causes of infant mortality, because that's all changed. Over the last several years, infant mortality has come down from all the common conditions that you're familiar with, diarrhea, lung infections, pneumonias, all that has declined, but the children born with heart disease have not been addressed adequately. As a result, so in places like Kerala and other parts where infant mortality has come down, it's become very important. And that's why you have so much focus on congenital heart disease today. So if you look at the whole spectrum, you can have diseases that can kill within a month, like transposition, these are names, you don't need to worry about the specifics, but there are a number of conditions that if you're born with, you don't survive beyond a month. Or if you have less serious but equally significant conditions, you can have a serious problem if you don't fix them within a year or 2. And these are common shunts, tetralogy you might have heard of, etc. And then, of course, there are some conditions that allow you to survive into adulthood, but even then can be disabling. So this whole spectrum needs to be given attention. And there are some exceptional survivors that go through all this, but majority have lots of issues. Now, in India, I've been part of the whole story since mid-80s when I trained, and I've seen the entire evolution of care. One thing is very important. When it started, so this is a man called Walton Lillihei. He did the world's first open heart surgery. But what did he do was extraordinary. He took blood from the mother of the child and used that to circulate, and he closed a defect in a 3-year-old in 1954. Now, why is it so significant? This is one surgery where he could have had a 200% mortality. Both mother and child could have died. But he had the courage to use the mother's lungs and the heart to support the child's circulation, and he performed the first open heart surgery. That was 1954. For the next 20 years, things were not easy for congenital heart surgery. It took a long time before the heart-lung machine came into existence, because you can't operate on the heart without stopping the heart. So in order to stop the heart, you need to provide circulation. So you need to do that with the heart-lung machine. This idea of using the mother or the father to support the child is not a good one, because you can have a lot of problems. Now, this surgery took a long time before technology became acceptable. Lots of mortality used to be there. You operate on 10 children, you lose 3 or 4. And in the early 90s, when I actually started looking at heart surgery in children, we used to lose 10 out of every 100 children that we used to operate on, because it was not easy. Since then, a lot of evolution has happened within this country. And we are interested in what happened in India. That's more important. So, in the early years, facilities were largely limited to 4 institutions: All India Institute, Railway Hospital, CMC Vellore, and in Mumbai. These were institutions that were trying to do heart surgery. These were great pioneers at this time. Dr. Tandon was my guru. And then next to him is Dr. K.M. Cherian, Dr. I.M. Rao, Dr. Srivastav, Dr. Iyer, and Dr. Rajesh Sharma. These are people who actually led the way. And initially, we had very few people who had that ability. We couldn't do babies because we didn't have the technology. Then we got slightly better. We started to identify heart disease. And then we started to treat some of them in the cath lab. And then finally in 1990s, Dr. Iyer was the first person who did the open heart surgery in children. And then we started to develop the whole concept of dedicated pediatric cardiac care. So only in 90s has this specialty come into existence in the real terms in this country. From then on, it's been quite a journey. So I started the journey at AMRITA in 1998. So we were at that time at a very interesting point in India. There were only 4 centers that were attempting children under the age of 1 year. The total number of children, infants that were being operated in the whole country was 1,300. And that was about 1.5% of all the babies that were being born with congenital heart disease. So you know what was happening. They were all dying. At that time, AMRITA came into existence. And it was amazing that somebody really thought of putting this program at that in a situation where most of the country wasn't even aware of it. And there were lots of problems. This was thought to be impossible, thought to be too expensive, and no private hospital wanted to venture into it. And very few doctors actually wanted to specialize because it was very difficult. So as a result, we had lots of problems. We had babies who were not operated, babies who died, babies who had brain damage, babies who had permanent damage to the lungs. All these things were a huge issue when we started the journey. And since then, we've come a long way. Of course, the challenges were huge. And the biggest challenge, as I saw it, was to get good results consistently. And then enabling access for every child. We still have a lot of problems in the country. Entire eastern India is very poorly served. We don't have good solutions for entire east of India, large parts of central India. There are, even in AMRITA, we have challenges with sustainability of our program. It's very difficult to find personnel, train them, and retain them. And at this point, one challenge that we realized is as our patients got operated and grew older, they had some challenges that we had to address that related to their physical development, their mental development, their schooling, and their societal integration. That's why we are here today, because that part is where we have reached, at least in AMRITA, where we have sorted out the other issues to some extent, but we are now having to address this particular issue. So if you know, most of these conditions that I've listed here have very high death rates in the first year of life. And this was in the 70s when they were not operating. They used to just follow these children till they died, and the situation was very bad. So this is the kind of conditions that we are really saving today. So the question that I ask often to pediatricians, and I get wrong answers very often when I take these talks, is which of the following has the potential to save most lives amongst babies with congenital heart disease? And I've given 4 options, and they often choose the wrong option. If I put it in any forum, I get various answers. I get answers on intensive care, on fetal echo, but the real answer is that the real lifesaver is infant and newborn heart surgery. We need to establish that. Without that, you can't save lives. And nobody has internalized or expressed it enough to attract the attention to establish new centers. So our biggest challenge at AMRITA was, this is how I put forth my challenge here when I started this institution along with Dr. Suresh Rao and a few others. How can we deliver good care, affordable care, but not just deliver it, but deliver it equitably so that every child has access. You can't just say, if you are coming from a poor background, I can't take care of you. We at AMRITA sort of made this policy that we have to address no matter what their income status is. So equitably deliver affordable care. We can't make it sustainable if we start to make our care very expensive. So we had to make our model very affordable. And at the same time, we had to meet the highest standards of the world. The highest standards, the information is out there, and we had to match those global standards. That was our overarching ambition when we set up our program. And the focus was on infant and newborn heart surgery, because that's where it mattered most. There's no point operating on a 10-year-old with a small defect and say everything will be fine. So, what does it take to save a child with congenital heart disease? It takes a team. And this is the team. I just happen to represent the team, but the real fact is that every single member contributes hugely. There is pediatric cardiology, and we in our department do have some areas of focus, but largely we do everything. Then there are heart surgeons, without which nothing can happen. So you need heart surgeons, you need anesthesiologists, you need perfusion technologists, and you need other support personnel. Then the big element is intensive care. You need experts in intensive care, doctors, and in our case it's our anesthetists who take care of them. You need infection control system. The most important part of intensive care is nursing. You need very good nursing. You need to pay attention to everything else. So all these elements have to come together. But in our case, it's not just this. What I've marked in red are very important. One is medical social workers and support staff. They play critical role at all levels to work with the family and to liaise with them. And then we take a lot of help from our other pediatric specialties, and they play a big role because heart disease doesn't happen in isolation. So it's very essential to work with a number of specialties. That's how you deliver care, and that's how you can get good results. Then it's important to have an administrative engagement, and we're very lucky at AMRITA that we have an administration that understands all what I've been saying. And the nurse, the empowered nurse, is the most important person in the core of the team. Everybody has to be quality conscious. It's even from the person who cleans the ICU till the senior most surgeon. And then we, of course, make sure that we collaborate with everybody to get better and better. So even this act of creating this whole neurodevelopmental service is through collaborations. Sonam has collaborated with experts in the UK, with other experts in the country, and called everybody, because the idea is to learn from each other. So when we started in 1998, this was our mission statement, essentially what I have been saying all along, that we had to be accessible, affordable, have the best results, and of course teach, train, and do some research on our problems. These were our surgeons when we started the unit, Dr. Suresh Rao, Dr. Shiva. This was in 2005 the picture was taken, but we started the program in 1998. Important to have a team culture. So our whole department thrives on the whole notion that we are a team. There's no one boss. Nobody is at the top. Everybody contributes. Everybody is equally important. And the thing that we've focused a lot on is our quality. Dr. Rakhi has been our quality champion all along. And it's important to recognize that there are risks with heart surgery, and no matter how well you do your surgeries, you can't eliminate the prospect of a child dying from the heart surgery, because it's very difficult at times. Patients have numerous problems. So in our own case, our results have improved dramatically to the point that now we are able to get, since 2016, our results have been close to the ideal world standards. And our surgical mortality has been anywhere between 1% to 2%. So this has been an achievement that has been possible because of everybody coming together. So till recently, that was our only focus. Even today, it's an important focus. How many patients survive your heart surgery? But we've gone beyond that. Since 2015, 2016, our results have been quite good, matching international standards. But I think it's not just enough to save a child. You need to think much beyond that. And the time has come where we not looking at just a child making it past surgery, but leading a meaningful life and growing up as close to normal as possible. So the other important piece in this whole puzzle has been trying to work with the government. And the Hridayam program of Kerala has been in many ways exemplary in what it has done in terms of creating a system by which you recognize through newborn screening, through fetal screening, and improving awareness in all pediatricians, and then creating a system for referral, providing the funds for surgery, and then enabling their surgery through a number of hospitals that are a part of a public-private partnership. This has resulted in, Kerala having infant mortality reaching 5 per thousand, which is not very different from the United States. So this story has been a very powerful story, but equally important, and I have recommended to Hridayam as well, that we now turn our attention away from survival alone. And we make this sustainable. We try to do it in other states as well. So in India, we've come this far from what we started off in 1998, where only 1% of children were receiving care in a timely fashion through 5 institutions. We've reached a point where we nearly have many more institutions, about 50 or 60, but still the number of children covered is still completely unsatisfactory. We have a very long way to go. Nonetheless, it's a tremendous amount of progress that we have seen. It's about time when we do this, when we've reached a point where we are now operating on a number of children, that we become serious about looking after their future. And of course, it's important to have this philosophy of being cost effective, reaching out to every family, also not mindlessly use technology, have a definition of progress that says that, listen, it's not just important to do the most fancy surgeries, but enable access to a lot of children, and look at simple things that can improve outcomes without increasing costs. So this has been our philosophy. But we have to ensure a sustainable future. There are lots of challenges for the future, and that those things are going to affect us in terms of how this specialty grows and develops. And one of those aspects is going to be looking at follow-up. And what is going to happen today is essentially going to discuss as to what is the roadmap that we have developed and we can develop towards ensuring that every child that we operate on, every child with congenital heart disease, has a future that is not very different from a child without any problems. So that's the journey that we are embarking on, and today's session is largely to talk about that. So this is the team, and I'm very thankful to be a part of a remarkable team of people who put this all together. Thank you.
Any questions? Anybody with any questions? No.
Dr. Jayakumar, that's okay. You can say something.
It's very nice that you have started this program, and it's essentially beneficial to the entire state and also for the country. And only because of this program, this IMR has come down dramatically. You can see the difference that you have projected the slide. So congratulations, Dr. Kishore sir.
Alina, don't be so awkward. You can start off because it's moving.
Thank you, sir, for that powerful perspective. You've helped us understand how far we've come in improving survival in children with congenital heart disease. But this naturally brings us to the next question. If more children are surviving, what is happening to the developing brain? Because survival does not mean absence of risk. Many of these children continue to carry a degree of neurological vulnerability, subtle, often invisible, but deeply impactful on development, learning, and long-term outcomes. And this is exactly where we are now moving into understanding the science of vulnerability and outcomes. This part of the program focuses on what happens beneath the surface, the brain, the biology, and the early injuries that shape developmental trajectories. Before we move forward, we have 2 quick polls for all of you. Can we have the polls on the screen? You'll see a QR code displayed on the screen. Please take a moment to scan it using your mobile phones. Once you scan, you'll be redirected to the questions. We encourage everyone to participate and share your responses.
I like how the entire pie is changing dynamically. We started off with a lot of pediatric cardiology, pediatricians, but I think now the developmental professionals are taking over. Mental health professionals, excellent, I'm so happy. Okay, I think the mental health professionals and the developmental professionals, the physiotherapist, occupational therapist, audiologist. Yes, from the mental health professionals and the developmental professionals. So good to see that, we have so many people from the mental health side, from the developmental science area. We'll wait for a few more seconds, and then I think we've got the answer to how the crowd looks like today. Yeah. Yes, we've got our answers. We'll close this one. So mental health professionals and developmental professionals are the ones, maximum in the crowd today. Thank you so much for being here. We have one more mentee to go up. Yes.
Yeah.
Okay. In your opinion, what percentage of children with CHD experience some form of developmental or cognitive challenges? Let's see how much we know about the area. Less than 5%, 5 to 15%, 20 to 30%, 40 to 50%. Okay, I think the most of us think that it's 20 to 30% of the population could be at risk. All right, I think we have our answers here. So most of us think that 20 to 30% would be the percentage of children with at risk or would experience some kind of neurodevelopmental challenges. All right. Okay, so we'll move on to the next session, and we'll also see towards the end of this part of the session of how this information changes. Does it even change or not?
Now, to help us unpack this, we have with us someone who brings together clinical insight and strong research expertise. Dr. Manu Raj is a highly respected pediatrician and researcher with a distinguished academic and clinical career. He has received advanced training in research from leading global institutions, including the McMaster University, and has made significant contributions to research in child health and outcomes. He is recognized among the top 2% of Stanford scientists list globally for the last 3 years consecutively, reflecting the impact of his research work. What stands out about his work is the ability to translate complex science into meaningful clinical understanding, helping us see not just what happens, but why it happens. His areas of interest are cardiovascular health in children and adolescents and neurodevelopmental disorders in congenital heart diseases. Today, he will take us through the neurological vulnerabilities in children with CHD, helping us understand brain injuries, risks, and their implications. But before I invite him to the stage, we'll have a short poll to set the stage for this session. Now, may I invite Dr. Manu Raj to take the stage.
Good morning. Please let me know if the slides are complex because I just saw the anatomy of the crowd and I hope it's decent. do it? Slide changer. Oh, so, okay. Yeah. Okay, neurodevelopmental trajectories in congenital heart disease is relatively a recent topic. I mean, it was always there, but in a place where it was difficult to operate on children. I mean, KK sir was telling, even now we are addressing a quarter of those children who require care. I mean, now that we have these children operated, then comes the question, what happens when a child survives the first year of life? Like you know that in children with congenital heart disease, close to a quarter or maybe 30% require surgery in the very first year. So we should know that now that they are surviving, a new set of problems have reached the horizon. So we always use the word neurodevelopmental. The word simply means the acquisition, development, and execution of cognitive, academic, motor, language, neuropsychological, adaptive, social, emotional, behavioral, and psychiatric functioning during the development. I think you lose your breath by the time you finish that spectrum. That's the wider spectrum. And I can assure you, each word is important here. Everything, you look at from a child's perspective, everything defines that child's life. Every word is important. And when we say developmental delay, we're just telling you that the child has not attained motor or mental milestone for a particular age group. And when we talk about developmental disorder, it means the mental or physical impairment that results in a substantial function limitation in major life activities. So neurodevelopmental, developmental delay, and developmental disorders will come all throughout today. This is what the word means. Okay, and you should also know that congenital heart disease is something like 8 to 12 per 1,000 live births, of which a majority are simpler, and there are also complex lesions. When we say complex congenital heart disease, basically we are assuming that these infants require surgery or an intervention in the very first year of survival. I mean, very first year of life for their survival. If you do nothing in the first year, these babies are not going to see their second birthday. As simple as that. So, complex congenital heart disease is where the neurodevelopmental problems are maximum. So, I think KK sir has mentioned the epidemiology of this. I'm not going to tell you anything about that. A quarter of those children are going to be requiring an operation. And right now, we are pooling all sort of funds. I think sir is in the lead of that. Every child who requires a surgery who comes to us is getting operated. I don't know the scenario of other places, but we have never sent any child back for want of funds. I mean, that's an achievement we are always proud of. And you should know that in the developed countries, it's 90%. We have nowhere reached that place. I think one day India will also reach that 90% of survival for this kind of children. And when we talk about congenital heart disease, there is always categories of risk. Broadly, I would say category 1, 2, and 3. 1 is where the child has been operated using CPB or cardiopulmonary bypass. That's a group with the risk category 1. 2 would be there is no operation in the very first year, but they have chronic cyanosis and cyanosis related issues. 3 would be no surgery, no cyanosis, but these people have been having frequent hospitalizations or an intervention necessitated from the congenital heart disease. And in the 3, we have 3.1 and 3.2, 3.1 and 3.2. 3.2 is where these children have major factors that are going to affect their neurodevelopmental thing. I mean, that's a long list of things out there. Basically, Group 1 is surgery in the very first year using CPB. Group 2 is no surgery but chronic cyanosis. And Group 3 is none of these, 1 and 2, but they have either chronic hospitalization, interventions, or other factors that can damage the brain and result in neurodevelopmental delay. So, my question is, when is the brain injury happening in CHD? What do you think? There are youngsters out here. Where does it start? What is the critical point? If you want to have a switch off, where would you raise your hand? When is the little brain getting damaged? What do you think? Nobody is giving an answer. Anyway. Huh? Sir says it's in utero. What about others? After birth. So before birth, after birth, what happens in the period between? It's a trick question. Okay, we are always happy with tricky questions. There are 4 junctions or time points when the brain gets insulted. You are hitting the brain at 4 different time points. It's just like, you get hit 1, 2, 3, 4. It's a multi-hit kind of theory. The first is in uterus, Jayamar sir was pointing. Brain development is delayed due to altered fetal circulation, leading to reduced brain volume and increased vulnerability. You look at these brains of these infants, it's small volume. By the time it's born, the baby's brain volume is down. You know that brain volume is related to everything you do in life. And then, before the surgery, the child is born somewhere, transported in an ambulance. There are a lot of issues happening. If you're seeing a neonatal critical congenital heart disease being transported in a transport ambulance, you know the scenario. I don't have to tell you that. Vaishak, you can imagine that. By the time it reaches a place where the surgery is going to happen, it's not like it comes and operates. The baby is in the ICU. So that time, and then the child is on the table and the child is getting operated, there is the 3rd level of insult. And you think once the heart is closed, all is fine. No. The baby still gets punctured multiple. If there is perioperative seizures, post-operative seizures, if you see seizures, then there is also a problem. So if somebody asks, you can say the baby's brain get injured in utero, before surgery, during surgery, and even after surgery for the rest of their lives. Even parental thinking can damage the brain. I'll come to that. That's the way it goes. So what are the factors that contribute to brain injury? 3 major factors. The brain per se is immature in children with congenital heart disease, especially the critical ones. And there is pre-existing vulnerability, like in utero, the placental dysfunction, genetic factors, chronic hypoxia, reduced cerebral blood flow, all these things can harm the brain. And then the peroperative or post-operative complications. We stop the heart, we stop the blood supply, and we are operating on the heart. It's not like a free lunch. Some damage happens even while we are doing the good part of it. So these can also damage. So 3 factors can contribute to the damage out there. And if you're very ambitious, if you are like an enthusiastic learner, there are 15 factors that can separately damage the fetal brain. Just take a picture of this. I don't think any brain will remember these 15 things. One picture is fine. The smartphone, which makes us less smart, will help you here. That's what is happening. Just take a picture, go home, Google it. I don't have the capacity to teach you all 15 of these factors. You done? Don't sprain your neck, sir. Okay, so if you look at the interplay of this, it's like a mosaic. The baby is being tortured from all sort of scenarios, from genetic to fetal to perinatal, surgical, perioperative, early growth development, even the family. What happens in the family is also damaging the brain, and we might think a worrying mother is okay. No, I'll come to that because there are a lot of psychologists sitting here. What the mother thinks is imprinted on the brain. We'll come to that quickly. I can see through the smiling there. Okay, look at this. What we are doing is damaging a beautiful organ with all sort of cruelty. We are not cruel, but nature is cruel to children with congenital heart disease. So what happens here is a multi-pronged, deep insult to the brain. And the first category, anybody who's gone through a cardiopulmonary bypass will get 3 major problems. The brain goes into a hyperinflammatory response, and there is microscopic and macroscopic emboli. You know what emboli is, isn't it? Clots go here and there, damages, blocks, and it's like a plumbing stop. And then there is hypoperfusion. When we go on to hypoperfusion, and when we give back the perfusion, there is ischemia and something called reperfusion injury. You're reducing the blood flow, fine. You're reducing the blood flow to prevent injury, good. But when you reperfuse, there is something called reperfusion injury if you are not technically accurate. And CPB is like an art. you may not be doing it correctly in certain scenarios. So we should also know that despite the cardiopulmonary bypass issues, still there are patient-specific factors, perioperative factors, perioperative hemodynamic instability, and postoperative morbidity. Don't go home with the feeling that CPB is damaging the heart. Okay, CPB is doing some damage, but the other factors are much more important. So if you are new to this area, basically the CPB is a scenario where the heart and lung are stopped for a small period so that the heart is available for a complex repair, and the work is done by other machines. It's like a pump and an artificial lung. And basically, there's a circuit mechanism, there is myocardial protection, there is some cardioplegia, we give some drugs for the heart to be stopped, we manage the temperature, and we do some bit of anticoagulation. These are all done for the surgeon's convenience at the cost of the baby's brain being damaged a little. I mean, some benefit from some harm. And this is the entire system. You can Google and find out what is the CPB system. The problem here is the microemboli, the hyperinflammation, and the reperfusion injury. If somebody asks you, CPB has 3 problems: hyperinflation, micro and macro emboli, and the third one. Okay. So moving on to the second injury. So cardiopulmonary bypass is over. Cyanosis is a big problem. I mean, if you see a blue baby, it's just not the lung thing. Cyanosis is detrimental to everything, including the brain. And it has direct effects. You put somebody in hypoxia, the brain is immediately damaged. That's a direct effect. Indirect effects happen on the brain structure and microstructure. Along with that, even medical, social, and environmental factors are associated. And if the baby is prolonged cyanotic, there is direct and indirect effects. The third one, no CPB, no cyanosis, still the baby is getting into the hospital, requiring frequent admissions, interventions, and there is still nerve injury and neurodevelopmental damage. This is usually due to genetic, medical, surgical, perioperative, and social histories. So most commonly, what we see is children with CHD are also having certain syndromes. If you look at 100 babies with CHD, some 20 to 30% will have some kind of syndrome. They are not very visible, but if you do a genetic mapping, you could see there are syndromic associations. And there is growth abnormalities, feeding issues. Children with critical CHD, they don't feed normally like others. So there are issues with that. There are medical and surgical complications, and there is also something called parental psychological stress. So we move on to altered physiology. What happens in the injury part is there is altered physiology of the fetal circulation. So you should know the fetal circulation is an entirely different area. Basically what happens is decreased oxygen and nutrient delivery. There is less of oxygen to the brain, there is less of nutrient to the brain, and this is usually seen towards the 3rd trimester. You know what 3rd trimester is. And this is particularly true for TGA and single ventricle heart disease. So whenever we talk about neurodevelopmental issues, we say that the biggest damage happens with single ventricle type of things along with certain types of TGA. So what we see is smaller brain volumes, less organized white matter, and abnormal brain metabolism. You know, the brain consists of gray matter and white matter is where the real kind of connections happen, and white matter gets damaged in plenty. And all of these can lead to impaired neurodevelopmental outcomes. So I'm just showing a picture, don't bother. Even I cannot read it full, maybe Vaishak will read it. That just telling you that you take an MRI, there will be plenty of spots that are bothersome. Somebody will show you an MRI, you can say, yeah, go take it to a pediatric neurologist and identify the problem. That's all. We need to know that by the time the baby is born, some 30 to 40% of children with critical congenital heart disease will have findings in their brain MRI. We may not take for non-symptomatic ones, but if you take, you'll see more than you expect. The next one is prematurity. I mean, prematurity per se is a neurodevelopmental insult. Any child with extreme prematurity has brain development that's damaged. I mean, I can say this with pride because I'm an extreme preterm baby standing here at 28 weeks. I was born at 28 weeks. People said a lot of bad things, including my pediatrician who said, I won't survive. Somehow I survived to do this talk. So prematurity, the problem is that you should know that CHD prevalence is only 8 to 10 per live birth. But in premature babies, the chance of having CHD is multiplied. Approximately 10% of preterm babies have some form of CHD. So the moment you see a preterm baby, just look at the heart, because 10% are going to have some problem or the other. And the most common problems we see with babies who are premature and also have a CHD is that there is intraventricular hemorrhage and something called periventricular leukomalacia. So even in some complex conditions, even early term birth, we think after 37 weeks the brain is spared. Not in children with congenital heart disease. Even 1 week earlier birth can damage the brain if we are talking about TGA or single ventricle thing. So sometimes we try to push the delivery to as late as possible towards full term, because we know the brain is going to be damaged out there. And this is the brain of a premature baby who also had a CHD. This is what we call periventricular leukomalacia. Just forget it. And this is intracranial hemorrhage. You don't have to remember anything. Okay. So postnatal detection, my friend Balu is sitting here. Balu is going to love this slide, because if you can diagnose prenatally, you're doing a lot of good things to the fetal brain. Am I right, Balu? Absolutely. Yeah. I mean, you came exactly for that slide, right?
Yeah, I'm sorry that I missed a few of your slides. We will discuss it once your lecture is over,
Yeah.
about what it can do. Maybe at the point of discussion we can do, but you are dead right.
Yes, yes, fine. See, the thing is, you get this anomaly scans. If somebody picks up your baby's heart disease, like Dr. Balu or somebody who say, oh, there is a damage, the next thing happens, you're going to an appropriate care center, your delivery is going to be planned, and there is a facility ready when the baby is born. That's not the case with postnatal diagnosis. Your baby is born somewhere, the gynecologist would suspect something, the pediatrician would come, neonatologist would come. By the time they reach a person like Balu or KK sir, a major part of the brain is already damaged. You're talking about a week or two that changes the baby forever. So postnatal detection is a risk, and prenatal detection is a bliss. We'll come to that later. So perioperative brain injury and less robust brain development happens out there. Perioperative factors. The baby is being operated. Even at that time, damages can occur. If you see the baby getting a seizure, you can bet your money on the child's brain being damaged significantly. If you are sending a call to Vaishak saying that there is a seizure perioperatively, something wrong has happened already. I mean, he might salvage it, but that's a warning sign. I'm not saying don't call him, but I'm saying that's a warning sign. Significant brain image, brain injury. You see an MRI with a problem, that neurodevelopment is going to be different. And prolonged postoperative hospital. Sometimes the babies refuse to get out of the ICU. 30, 40, 50 days. Every day something is happening that's damaging the fetal brain. And if CPR is done, you can be sure. ECMO, ventricular assist, heart rate, all these things are telling you the baby's brain is getting damaged. This is the slide for all the psychologists sitting here. Do you think this can modify a fetal brain? I'm happy to see them. I want them to answer wrong here. What do you think, Shruti? She knows it's a trick question. Anyway, I'm not wasting any time. Mother's worry gets to the brain. You should understand that 80% of parents of children with complex congenital heart disease, they display trauma symptoms. And 25%, 50% of depression and anxiety, psychological distress is there. And these get to the fetal brain by epigenetic mechanisms. We can't tell a mother, don't worry, there is CHD. Every mother is going to be worried, but how you deliver the message is important, and how you take care of their, I don't know if anybody who's referring the mother after delivering the diagnosis for a counseling. It should ideally be done, because the mother has to be informed appropriately that this is what we can salvage, this is what we cannot do. They should be at peace. And you can also see that the fetal hippocampal and cerebellar volumes are reflective of how much worry the mother had. It's so beautiful. The mother is worrying. You take a CT scan and MRI, you're seeing the mother's worry imprint there. Okay. Emerging factors are there. This is just to frighten you, not to tell you anything. They're looking at placenta and saying there are findings here. They're looking at repeated anesthetic exposure. all anesthetic gases have their problems. I hope there is no anesthetic sitting here. I mean, that's the truth of it. Exposure to neurotoxic chemicals, you know what? Every time the child is getting bombarded with a different chemical, there is something. And fetal brain is very sensitive things. And multiple intervention complications are also another thing. So there are certain protective strategies. I don't want to end the slide on a negative thing. Okay, we are damaging the brain. There is nothing you can do. Go home, live with it. No. There are a lot of protective strategies that we can do. And that is where the opportunity is. I mean, telling the damage is one thing. Telling how much can be salvaged is much more important. Over the last decade, research has identified promising neuroprotective strategies. Like you do these kind of things, the damage can be minimized or even taken out. You look at babies now, our operative mortality is less than 2%, right, Balu? Even lesser. You know, there are parts of this country still having operative mortality of 20 to 25%. Can you imagine that taking a train from that place to here reduces the baby's mortality by 90%? I mean, that is the truth of it. Balu knows the centers, I'm not telling the centers. Even center-wise, the baby's life is changed. I mean, I'm not taking every flight to this place. I'm saying that's the scenario. There are 20% mortality versus 2% mortality in this country right now. I mean, that's a scenario. And then, prenatal detection of CHD. Balu is going to love this message, right? Because if your child is diagnosed before birth, there are a lot of things. That baby's outcome is different. Our data set is clearly saying that with early signs, but we will come up with the paper later because prenatal diagnosis makes the neurodevelopmental outcome better because injury is less. Then comes, this is especially true for duct-dependent lesions requiring a neonatal intervention. It's not that the diagnosis is made early, but when the baby is born, they are ready to act. Day one, the baby gets what is required. We have seen this live, right, Balu, all the time. And although the prenatal detection rates have improved, even in Kerala, a lot of babies are diagnosed postnatally. What is the ratio, Balu, now?
Transposition, it's about 15 to 20%
Prenatal detection. But still,
it is perhaps the best in the country, but we have a long way to go.
even in Kerala, it's only that much.
There is a very good article in BMJ Open in which prenatal detection rates vary in different countries. You know, it's as high as 80% in France. In India, the data is scarce, but I would say it's less than 25%.
And Kerala is the best.
Kerala is perhaps amongst the best because of
And
the work.
Balu is a pioneer of that. You can take a big credit for that, Balu. Okay, although prenatal detection has the improving, but it's still nowhere near that. And next is the timing of delivery. Most places, the moment a CHD is diagnosed antenatally, there is an LSCS happening. Nobody knows why. Because LSCS is not going to save any baby of any effects from CHD. I'm sorry to say this to obstetricians. The baby requires a vaginal delivery. The LSCS has to be on maternal indications, and CHD is not a maternal indication. And there are certain times when we would suggest early term delivery, but most of the time it is push the baby to as late as possible, let the baby come out normally on the time. But sometimes we go in for an early term delivery for a specific kind of conditions. And so one is antenatal diagnosis, other is timing of the delivery, and surgical and perioperative is very, very important. The timing of cardiac surgery, because some surgeons are not comfortable in operating very small babies. Right, Balu? Am I right? Yeah.
But unlike here, of course, they do, but in
Other
many other
places-
cases, they delay.
You remember the 10 kg thing, come back at 10 kg, baby never reaches 10 kg, the surgery never happens. Here, I don't know, for some reason, weight is not a major issue. We operate it.
Even transposition, we operate within the first week, first 5 days, while in many centers, they operated 2 weeks only.
Okay, so that 1 week makes a hell of a difference. So the baby's damage goes out there. So other is good technical operation. You might think surgeons are all the same. I'm sorry, it's not the same. They are also human beings. So you have to pick the center, the surgeon, and everything possible, because every selection you make, it's for the brain of the baby. And minimizing deleterious effects of the CPB. The less CPB time, the better. And monitoring cerebral perfusion oxygen. Even the way the perfusion technicians manage it, they are all sitting there, the youngsters. You guys can save or kill the brain. Sorry, just one more minute. And the next one is Yeah, this is it. Sorry, it's not moving. Why is it not moving? Is it frozen? Yeah, sorry. And in-hospital neuroprotection is very important. This is where the real application happens. Family-centered developmental care is applied here. Supporting parents. I see parents sitting here. The role of a parent is protective for the brain. If the parent is committed, the child's brain is taken care of. There are a lot of stories out there. And we have to have habilitative services, early discharge planning, assessment of post-discharge needs, and care coordination. We have a team who knows in and out of every baby we see. My team is running around. They know what the baby is going through. I think there are examples we are going to tell you. The team that takes care of this with passion is also very important. And this is how we refer. I'll skip this slide. Babies are fighters. All babies. All babies are fighters. What we have to do is just inspire them. You can do a little bit of inspiration, the brain will come back to the best possible state. We have seen wonderful stories of brain coming back from all the damages. So all we have to do is don't add to the damage, do proper care, and the baby will come back well. Thank you. Are there any questions?
If I can.
Yeah, yes, but.
So thanks, Dr. Manu, for your wonderful speech. You know that the main message of this conference, I think that yesterday is we were trying to survival of these patients. Now we have gone another step from survival to make them a normal citizen, highly competitive. So that's the aim of the message. That's the game changer, I think, because now we are not satisfied with the survival alone. So these children are going to be very useful to the community. They are not going to be a burden. They are becoming highly competitive. So that's the important message of this meeting. And I wish all the very success for your endeavor, new endeavor. Thank you. And I had a very close association with him for the last
my teacher.
40 years. Now he has grown to the level of a world-renowned researcher, professor, Dr. Mandra. Congratulations.
Thank you, Manu. I think you highlighted a lot of things which we are doing here. I think the whole, developmental rehabilitation, that process, it's a continuous process. There are opportunities at different steps. For example, if a baby is diagnosed to have a congenital heart disease prenatally, so many of them are, at least in our practice, we can actually do a lot, including working on the mother's psychological stress, maternal factors, because now new science is actually looking into this. This acts through three different ways. One is the baby's brain, the baby's heart, and the placenta. All three are interconnected. There's a lot of emphasis on the placenta these days on neurodevelopment. So we don't know. I think it's Sonam's pet project is a fetal brain and a heart, which still we have not cracked here, because we need to do something, but we haven't had an opportunity to go into this science. Second is, you said very important, the birth, the natal process. Yesterday, Arun Singh spoke about delayed cord clamping, or what is called the physiological cord clamping, where you don't rush, do a cesarean early, take out the baby, because the obstetrician will think their job is done, baby is out. No. You allow that extra couple of weeks for the brain to mature, particularly in the late pregnancy, and even the process of delivery, you put it in such a way that even processes like cord clamping is done in a physiological manner. Some extra blood can go into the brain and can potentially mitigate a lot of hypoxic damage. All the science has focused on perioperative strategies and then rehabilitation later. In my opinion, we should shift from there. That of course we should do that, but a lot of opportunities to prevent and perhaps modify a lot of neurodevelopmental factors exist before the baby is born and when the baby is born. I think this is something which I think I should say it now, because you spoke so much about prenatal detection here.
Okay, by the way, Balu was 1 year senior to me in med school. We have a long-term association also. It's nice to see you on both sides of it. Thank you. I think by want of time, is there any questions? I mean, Sonam has given me 2 signals to stop. So if there are no more questions, I'll just move on to the next speakers. Thank you.
Thank you, sir, for helping us understand the neurological vulnerabilities in children with congenital heart diseases. We've now looked at what happens at the level of the brain. So, where do we go from here? This session builds on that foundation. How do these risks translate into measurable developmental outcomes? Because the brain does not speak in scans, it speaks through development, through patterns we can observe, assess, and sometimes miss. This session moves us from understanding vulnerability to identifying developmental signatures, not just whether a child is delayed or not, but how development unfolds in these children. And importantly, what are the patterns that begin to predict outcomes? Drawing from clinical work and cohort-based research, this session will look at developmental profiles, emerging trends, and key predictors that can guide early identification and intervention. To take us through this, we have someone who has spent over a decade working closely with children and families, understanding development not just in theory, but in real-life contexts. Ms. Sonam Manoj, Assistant Professor and National Coordinator, Project Medha, with more than 15 years of experience in the field of psychology. Her work has spanned both hospital and school settings, where she has worked extensively with children with learning and developmental difficulties and needs. Her areas of deep interest include ADHD, which she defines as a superpower, something that when understood well can be a real strength. She's also been involved in designing and developing life skills and wellness curricula for schools and colleges, working closely with children, educators, and systems to support development in everyday environments. Her work lies at the intersection of clinical care and research with a strong focus on neurodevelopmental outcomes in children with congenital heart disease. She has been actively involved in longitudinal cohort work, examining developmental trajectories and identifying early predictors of delay in this population. Today, she will bring together clinical insights and research findings to help us decode developmental delays in CHD from a clinical psychologist's lens. May I invite Ms. Sonam Manoj onto the stage.
Thank you so much, Alina. That was a long and a very warm introduction. My timer doesn't start, no, with this technical problem? Okay, thank you. Maybe is it on? Present. Okay. So we've heard a lot of science since the morning, and we know what happens, inside the mother's womb. How does the fetus develop? A lot to do with brain. Now I'm going to simplify it a little bit. Now I have very, very cautiously put down the entire slides together, making sure that everybody in the audience understands what we're saying. So we've kept it very simple, very layman. Of course, there would be a lot of people here who know more than what you see in the slide today, but the aim here is to make sure that everyone is on the same page and understands it the same way. So, CHD signature, developmental delays. What has the literature told us? What has been refined? And what did we find here in India is what I would take you through. Now, before I start off, I'd like to start with a question. And I want you all to think about this, not just now, but in all the sessions to come. If a child with congenital heart disease undergoes a surgery and is doing well and is surviving, have we done enough? Every session, keep this question with you, reflect, ask yourself, question again, and then by the end of the day, hoping we have different answers. Now, for a long time, what the field believed was that the answer was yes. They said that, if the child survives, I think they're doing good. But however, this thought process started to change. In 1970s and 80s, we saw that the mortality rate was extremely high. But as time went on, success started to, redefine itself. Earlier, the success was only biological. There was a beating heart, there was stable circulation, and everything was good. What later happened is that the clinicians, the parents, and for that matter, even the schools started seeing a different pattern emerge. Some parents came back and said, my child is sensitive to sounds. My child is sensitive to textures. So there was sensitivity in sensory understanding. There was sensory deprivation. As the child grew up, they said, I don't know why, there is a miss. There could be something different happening with this child. Doesn't seem like how he is like my elder son or my daughter, or how, different he is in terms of the classroom. Some complained about attention issues. Some came back and said, my child has a lot of hyperactivity. I don't know, he doesn't tend to sit more than, 30 seconds on the chair. Some said, everything seems okay, just emotionally he's not able to regulate himself. He gets angry at every small thing. School functioning started to show out. Some parents said he's very good at, biology, English, and other subjects, but then there is some problem when it comes to maths. He's not able to understand maths. And some said, he's good at maths, he's good at physics, so which means his IQ is really good. But then what is going wrong with languages? Why doesn't he get languages? So a lot of different patterns started to emerge, which was not something that the clinicians really looked at in the beginning. So very importantly, I need to make this point here that now these are children who did not have very obvious neurological injury or did not have any deficits in IQ. In fact, their IQ was preserved and they were doing pretty okay. So then what was going wrong? And that's when we had this whole change of perspective. Now, before we get into how the world has looked at defining the data, I'd like you to understand that neurodevelopment is not about scores. Neurodevelopment is more to do with how the body is organizing, how the brain is organizing itself. Now, suppose I ask a child that, give me a chocolate. Please take this chocolate and give it to auntie's hand. Now, he needs to do a lot of processing in his brain, right? From, his motor, where he lifts it, and his sensory processing, his processing speed, planning, how am I going to take this, how am I going to, go back. So all of this development, as we know, happens, as the child is growing. Now, what happens with child with CHD? Somewhere these processing or this organizing, as the child is growing up, the development starts to, show different patterns. There is something going on in the circuit which is not the way everybody develops. Okay, before I make this sound too tragic, I want you to know it's only a percentage, it's not with everybody. Okay, I'm not going to go into the basics, but just trying to, give the point here that if you need the motor skills to develop, the language to develop, the cognition to develop, there is a lot of processes that's involved, and it could get hampered in the entire growing up of a child with CHD. So now, like I said, for a very long time, we were only looking at survival being a biological, outcome, and we saw success as biology. But in 1993, we had Dr. Jane Neuberger. When we look back into, history of pediatric cardiology, Dr. Jane's name is something that stands out. So she was the first one who said, after looking at the children who were coming to her for a very long time, she said, okay, listen, there is something not going right, and let's look at what's happening. So this was the first study which was done on children with complex heart surgeries. So what she did is that after the surgery was done, after about a year, they assessed the children on development, motor and mental development. And that's when something new came out, which was, that the children have motor deficits when compared to the controls. Okay, and she also told us two very important things. Of course, the study said a lot of things, but I've just highlighted two things. At that point, she said that developmental scores were much lower than what they expected, and two, the surgical technique that was used during the surgery definitely mattered, especially children who had gone through DHCA, which is, okay, so basically making it, in simple terms, DHCA is where we actually bring down the temperature of the child's, body during the surgery. So it goes to about 15, sometimes 15 to 18 degrees. There are surgeons here who can correct me if I'm going wrong. But now the time of this DHCA, so the time that the child was kept in the lower temperature, actually affected the way the outcomes were shown. So which now what pointed out here was that, okay, there are two things. One is the surgery could be, something that we really need to look into. Developmental scores definitely are not looking, how it looks like for the others. Also, what are the, so that means we know this, but there is a whole lot of things that we do not know. So this opened up the whole question as to, what next? What is actually happening? Is it the condition? Is it the complex heart surgery? Is it the type of surgery? Or maybe the vulnerability actually begins right from the beginning. So a lot of science was not known then. And that opened up to a lot of studies post that. So for more than a decade after that, many studies in different parts of the world happened. And then was the landmark shift in the field, which was the American Heart Association's scientific statement on neurodevelopment. At this point, we understood that there are some areas which are definitely affected. Now, if you look at the numbers here, when we started off the poll, we spoke about 20 to 30% of children, having trouble. But what we saw during the statement when it was released, there was 40 to 50% show motor impairments. Now, delays are seen in both fine and gross motor. Now, the good news here was that though there was 40 to 50% of motor impairments, as the time went by, children actually got better. So that means there was hope. There was, the hope of neuroplasticity always exists, so that was there. Now, when you look at mental development, 20 to 40% showed cognitive delay, and usually it was only mild to moderate deficits. The IQ usually remained in the lower, borderline, low average. Hardly anybody went into deficits. So which means the IQ also was preserved. So we have good news there. Now, you need to know that this statement had studies mostly to do with the primary years, that is, 2.5, 3 years. Nothing was done more than that. The following up had not happened. So this statement left us with questions as to, okay, until 2.5, 3 years old, this is what happens, but what happens next? So just looking at the statement for now, what it said was that mean IQ typically was between 85 and 100, which means preserving of IQ is a hope. 25 to 50% score below average range, which is also okay. The psychologist sitting here would say that below average also seems okay because we can be functional and we can do so much with this range. Now, there were studies that said, okay, IQ is okay, however, executive functions could be deficit. When I say executive functions, I'm talking about, working memory. I'm talking about impulsivity. So the child was doing fine, everything was good, but then, when he has to inhibit his impulses, he's not able to do it. Planning, not able to decide for himself. Processing speed. So all of that was seen as, some domains that started to emerge. Prevalence of ADHD, hyperactivity is something that we see so commonly in our clinic on daily basis. So it was seen that 2 to 3 times higher in CHT when compared to the controls. Learning disorders, 30 to 50% also required special education services. Now, if you look at these numbers, especially the crowd sitting here today, we have maximum people from mental health, profession. You know how important it is to know what CHT signature is like. So then came this entire legitimized document which said that, survival is not just the thing. We have children who are at a huge risk of neurodevelopmental disorders. So the whole concept of neurodevelopment moved from secondary outcome to the core clinical outcome in 2012, which means we're a very young field yet when we look at neurodevelopment. Post this statement, there were a lot of neuropsychologists, neuroscientists who got involved and said, okay, let's look at the areas that we don't have answers from the previous statement. So then came studies on fetal stage, like Balusa was mentioning in the morning that, just a little before, that, fetal is something that is still unmapped, though there are studies, but still there's so much. We do know that the vulnerability starts right there, so we need to work a lot on, how it goes. So we did have studies pointing out that, which means a CHT brain is vulnerable right before the surgery. It's not just the surgery which is doing, that could be doing a little bit of damage. And school performance, all of those studies started coming in that period. Now came the 2024 statement, which was more like an adaptation for the first statement. And here we moved from, okay, this is what we see in childhood. We see motor delays, we see mental delays. And as these children grow up, it starts looking into executive function. Children they're not performing well in school. They have emotional regulatory issues. So the second statement told us, okay, we have a lot of work to do as mental health professionals. Now, just to sum up where we stand today in terms of statement is, when you look at a child with CHT, we see motor development delays. And this would be sometime, say in the first 2 years of their life, the areas that affect the most is usually the posture control. Neck control is something that we see very closely. And growing up, locomotion is something that you would see deficits in. Language somewhere, of course, we see a delay in the beginning, but it starts to match. Now, there are two parts of language. We have expressive and we have receptive. So the receptive is doing okay. They are able to understand what you're saying and everything is good. But when it comes to expression, when it comes to speech, they're not able to put a lot of things together. So these were the two areas that we saw in language that were affected. And of course, cognitive abilities would be more to do with working memory, would be a lot to do with attention, planning, all of that also we saw, which started showing vulnerabilities. So the AHA statement gives us this snapshot of how a child with CHT would look like if there is a neurodevelopmental need. Now, what's very important is who are these children? Are everybody at risk? Of course, I begin with the line that, CHT does make, the vulnerability of the brain definitely increases, but the ones who are at more risk would be, morning, I think, Manu sir also was talking about cyanotic CHD. Genetic syndromes is something that we have seen. Prematurity or low birth weight. Longer ICU and complications. So these are the things we have noticed. These are the parameters that we have noticed where risk stratification can be done. Now, understanding, what the international data has told us, came a time where we said, okay, we should also look at how does India data look like. So this was a study that was done here in AMRITA. We had centers, we were the coordinating center at AMRITA, and we had centers across the country. AIMS Delhi, Wadia Hospital Mumbai, Narayana Hospital Kolkata, and Jayadeva Hospital Bangalore. So with all of us together, we've been following up this cohort for more than 5.5, 6 years right now. So let's look at what we saw in our data and does it really match with what the world had to tell us. So to give you a little bit of a snapshot of what we do, after the surgery, so all the children who have had surgery in the first 1 year of their life, they are followed up 6 months after the surgery, then 12 months after the surgery, 24 months after the surgery, 3.5 years, and 4.5, and now we are hoping to follow them up until the adulthood. So today what I'm going to show you would be the data which covers 6 months to 3.5 years. So in the beginning, the 3 assessments that you see is more to do with the development assessments, where we look at how are they developing in terms of motor development and how they're developing in terms of mental. And then we go up and, as the child grows up, we also advance the test that we are looking at. So intelligence quotient is looked at 3.5, again 4.5, and then we have other tests that looks at the adaptability of the child. So for now, let's look at the basic data that we have. I've simplified it so you understand what we are doing. Now, in the results, motor delay, we saw that at 6 months, we had 24.3% of children showing delay. The good news is this reduces. So at 12 months, it was 13.9. At 24 months, it was 8.4. So we see a decline in terms of deficits in motor. So that is one hope that we sit with. And when you look at mental delay, again, 14% showed deficits in mental, goes down to 9.8 and then 8.7. So there is hope. However, what we noticed again was that when we look at these motor domains, so there are many domains we cover in motor and mental. When we look at the motor domains, just like how the AHA statement in 2024, which I mentioned about, says that there is trouble with locomotion, there is trouble with posture. We saw the same results in our cohort as well. So body control and locomotion were the two main areas that were affected. Again, all of them, body control showed a decline. When you look at locomotion, 45.5 at 6 months, 32 at 12, and 38 at 24. Now, what happens here is, though things seem okay in the beginning, we've also seen a pattern that, domains can re-emerge with a new pattern as the child is growing up. So this was something which we have seen in our cohort, and we've also seen this in other data from the Western world. Similarly, in mental cluster, 2 areas that were affected, language 2, which we mentioned about, was the expressive. Reception is okay, expression is the one that takes a hit. Now, good news, yes, they're learning, and as they move forward, it gets better. Memory, 39.8 at 6, 25.9 at 12, and then when you look at the 24 months, there is again a raise from the second time. So somewhere when things are seeming fine, but when the child is growing up, maybe he's not able to meet the needs of the development as he grows. So this is typically what we look at as a neurodevelopment signature in CHT: motor, locomotion, and the neck control. Mental is to do with memory as well as language, and things emerge and change as the child is growing up. Intelligence quotient, even in our data, just like the West, 35 to 45% of children had scores within average to low average IQ, which is again a good news. 9.5% were in borderline range, but what was really nice, we had about 2.6% who were actually very superior IQ. So, which again means that IQ may not, be the trouble here. However, when we open up the domains of intelligence quotient, when we look at it with a magnifying glass, we see a lot of areas which could be hampered. Verbal acquisition again, and working memory. Now, let me give you a small example with working memory. Hina. Just to give you an example what working memory looks like in a child. So I'm going to give you 3 numbers. Listen to me, and I'll tell you what to do. 4, 9, 1. I'll give you another set. 3, 2, 7, 1. Now, repeat this backwards.
1, 7, 3, 2, 7. Okay.
Working memory, okay.
1, 7, 2, 3.
Okay. 3, 2, 1, 5. Separate the prime numbers.
3, 1, 5.
4, 2, 8, 5. Pick out only the even numbers.
4, 2, 8.
Okay. Now, this is exactly what working memory is, where she's holding information and she's also working with the information she holds, she manipulates it and she gives out an answer. Now, this is typically what we actually see in children when a teacher gives them, say, 3 instructions. They may follow the first one. The second, third may not happen the way we expect it to. Now, like I said in the beginning, I'm again saying this is not with everybody. This is a good portion of children who see. Now, what happens with these children is this working memory that we look at, when this child grows up, slowly becomes trouble with attention, slowly becomes trouble with hyperactivity, starts showing out in maths, starts showing out in school performances. Then relationships, because the people don't tend to understand why are they doing what they're doing. I told them this, but he did not do it. Right? So then image starts forming. And then as they grow up, we have new societal challenges that the child faces. Now, then this is what we have established. Just like all the pictures that I posted, these are my mentors, Manu sir and KK sir. So the cohort that tells us today, we have established that there is early motor vulnerability. We have language and communication risks. We have different domains that emerge later. Things might seem okay in the beginning, but it's important to keep screening them because a lot of things can change as the child is growing up. We have something hidden going on inside, and that is something we are focusing on right now. What is this hidden? Now, remember, whatever we've told you here is what we know. There's a lot of it what we do not know, and that's where our focus is now going to see how we can look at more answers and look at more ways to help children. So just to sum it up, when you look at CHT as an area, and as psychologists and therapists, when you're looking at the developmental signature, typically what you would see in the beginning would be neck control, muscle tone would be lesser. It starts to get better. However, you do see it in locomotion later. The way he's running, the way he's walking, few of them. Then comes the mental signature, which is language, working memory. Some papers also spoke about social integration because of all these areas that are affected. Cognitive, like I said, good thing, IQ is mostly preserved, but executive functions is what we need to look at. And typically, the neurodevelopmental signature emerges differently, throws up a lot of uncertain things which may not be seen in the beginning. So with that, I open up a lot of questions or reflections that all the developmental therapists and psychologists sitting here, we need more people to be aware of how CHD looks like, right from physiotherapists, occupational therapists, speech language pathologists, clinical psychologists, and we at AMRITA work very closely. We collaborate, with different areas because our children come from across, Kerala. So we collaborate with a lot of different schools, talk to teachers, talk to therapists, CDCs, etc., to see how these children are growing up. So with that, I'm opening up my request to all the seniors sitting here. We need answers, we need a framework, we need guidelines for India, where we have an early identification and then guidance as to what to do next, how do we look at longitudinal surveillance, and how do we actually embed it into the cardiac care. Thank you so much. Do we have time for discussion?
Then we should have discussion. So, I think I'll take some comments from you, and then we'll move around. Dr. Arun Singh, you need to come in front.
Thank you, sir. I am Dr. Harapriya. I'm from Chennai. I'm a pediatric cardiologist. So as a pediatric cardiologist, I'm basically a pediatrician with special interest in pediatric cardiology. I've been in the specialty for nearly 20 years now. So, this kind of a neurodevelopment and cognitive care is a very important thing in children who survive congenital heart surgery. I have seen in my own practice, and that is the wisdom which I have gained by following up my own children is what has driven me to attend this conference today. So, as discussed previously, survival is one thing, and what kind of quality citizens you're going to become is the other thing. I think the focus definitely needs to shift towards that. My only concern, sir, of course in AMRITA, institutional level, we are able to give kind of a collaborative care. If I see in my own practice, what I find a great difficulty is all these different domains are so disjointed. Each of them do their own thing. Even if, the child gets self-referred by the parents, which, if they see the first thing as a motor relay, they may go to a physiotherapist. If they see the parent's concern is speech, they go to a speech therapist. But then, when the speech therapist has achieved their milestone, and if they find other things like cognition or other thing that the child needs, that doesn't get transmitted, doesn't get attention of the other therapists. That is my biggest challenge.
So what she's talking about is fragmented care. So that is the real challenge. Can we develop models that can overcome this kind of fragmentation? Are there, I don't think we have the perfect model in AMRITA, but we do have everything under one roof. But are there ways in which this can be sort of looked into?
So I think we also had a conversation yesterday about this. So at AMRITA, because it's a multidisciplinary setup, we do have our system, and we make sure that we have very close follow-up. I completely agree that it gets difficult when you're sitting in a setup where everybody is away. But for now, before we do have frameworks and guidelines which we'll be working towards, if you could make your set of, which we do on daily basis, we've actually tracked down the entire Kerala's scape. And we've marked as to where our children are coming from. Of course, it takes a lot of work. But if you could make your network of people where at least from your side, that, okay, this child might need this speech therapist. In your little thing, I think that would be where you could start on with, hoping that we have bigger landmarks.
So one model I can suggest is that you develop a clinic and invite people over instead of sending children to various parts. So if you can develop a once a month, some such thing where you invite a speech therapist, you invite a developmental expert, and you invite a psychologist, whatever the various domains you think need to be covered. And I think this is evolving. We are not entirely sure what the components are. If you can have that, the key is that you need a sonam for that, because you need the anchor person to actually get this and run this forwards together. Nonetheless, it's something that we can consider. The model can be developed around these clinics where the specialists can be invited to contribute their time once in a month or at some frequency, and then you can get, sir is also wanting to say something.
Thank you, sir. I'm Dr. Deepa, basically a developmental pediatrician. My suggestion would be, sir, developmental follow-up, surveillance, and screening should be a part of, just like you routinely follow up a child in the post-op period, developmental surveillance should be made a part of the clinic. Only then, there are very simple screening tools which will pick up these delays, sir. So, and then the child should ultimately be seen by a person who is a developmental pediatrician who can follow them as well. You know, they go for speech therapy, even if they come back with the speech improved, it's the duty of the pediatrician to follow up and find out the other lacunae as well. It's not like you just treat one particular entity and leave the child. No, it doesn't happen. So a constant developmental surveillance and developmental evaluation of these children, if that can be done, you know, all these things can be picked up at the earliest. And
Influence policy, because people who are running the various national schemes are completely looking at not just heart surgery, every other aspect of care that is given through Ayushman Bharat or any, it's all like a one time, we've given you money, the surgery is done, the child's problem is fixed and you go. They are not looking to establish this kind of systems. So it is not translated yet or become policy makers. For all their limitations, have not internalized this concept of providing wholesome developmental care to children. That is a big hole. I'm going to come to Dr. Arun Singh after this, but this is a big problem, and we need to find a way to initiate that dialogue.
yeah, what I meant is that in the newborn care, we have a very systematic follow-up. All at-risk newborns, irrespective of whether they have a mild risk or a moderate or a severe risk.
Same thing for cardiac.
Absolutely, sir.
But that needs to happen at a national level. What problems we have is that we have heart hospitals. Hospitals that only take care of heart, period. Other systems are all gone. We have hospitals that do adult and pediatric heart surgery. They don't do pediatric comprehensive care. They are really, and the surgeons, the whole conditioning happens, I've done my job. It's not my problem. So that is where we have to make the changes. And I don't know how it can happen. So maybe none better than Dr. Arun Singh to answer that question.
I think the fault lies with the pediatricians. Right from the beginning, this age division which came from the West doesn't make a sense. See, when you say neonatology, it's first 28 days. So when I used to go to take a DM exam, I would ask them, have you examined the eye? The only thing they would mention is ROP. So, to see this division should have been in a way that you see all the organs together. You just said follow-up. Now, cortical visual impairment is 28% among preterm babies. I know only of one center which is doing it. It is far more common than ROP. But in RBSK, when I started writing a book on newborn eye screening, my first objection I met was from stalwarts of neonatology. They said, apart from ROP, we don't look. And I said, how can you look at the posterior part without looking at the anterior part? I mean, if there's a corneal clouding, how can you see? So the idea is that it is not about cardiac surgery. Any surgery, any problem in a child, it will lead to. I'll give you one example. We have vertical programs. Clubfoot was there. Very successful program. So one day I was trying to watch one of the best known person, absolutely a saint. I was talking to him, Professor Matthew Varghese. He is a person who has been doing I have not met a better person. So one day I told him, sir, you are involving orthopedicians. What about pediatricians? He said, what are they supposed to do? The plaster will be done by it. I told him, sir, you require 6 to 7 plasters. Go and see to the child, the skin is burnt. The way you cut the plaster, either through a knife or through an electrical drill, there is a heat generated, and the child doesn't have time to recover. The day his plaster is cut, he is put on the new plaster. I said, this was the job of a pediatrician to tell you that this child has never put his foot down because it is in a plaster. There is no sensation coming from the leg to the brain. Even if you cured the club foot, things will not happen. So I think any surgery, neonatal surgery, cardiac surgery, any problem with the child, development will take its toll. Since we are very divided, organ specific, I am so happy that some cardiology person has thought of it. Usually, as Dr. KK said, that we are interested, we have done my job. It is up to the parents to find it out. The problem with even pediatric developmental center is we do just simple milestones. There is a word, developmental deviation and delay are not the same. The second thing is, how do I understand cortical visual impairment? By looking at the milestones, I will not understand. At least for hearing, you have started doing Bera. If I don't have Sonam, who is going to tell me that there are shifts in the cognitive function? So, in our pediatrics department, we didn't create a post of psychologist. We never asked for it. We didn't create a post of speech therapy. 28% of the children, forget cardiac surgery, have some kind of problem in speaking, from stammering to other things. Yet, you don't find a audiologist, pediatric audiologist in your pediatric department, excepting one place in Kerala. So my short point I am trying to make is that we should ask for, all pediatrics department should ask for an early intervention. You do not touch a child because a child is not any other animal. Ultimately, the birth of a child is a dream to the mother. If he cannot achieve his cognitive development, for the mother, she is lost. Her dreams are shattered. We may be very happy. I have cured the club foot, I have cured the heart. But for the mother, unless until the child does well cognitively as a homo sapien. So I think a time has come when we require a team. We as pediatricians are not trained to take this. We require a team. We'll have to ask for it. We'll have to redefine, not copy the West. Understand that we require, for the complete development of a child, a proper team with proper equipment. This is the short term.
This is the essence of everything that had to be spoken today.
Thank you, Sonam, and everyone else for that insightful session and your insights. You've helped us move from understanding risk to recognizing patterns. What stood out clearly is that the developmental delays are not always obvious. They are often subtle, evolving, and easy to miss unless we are actively looking for them. So now we will replay the poll to see that we've previously answered, to know if we are standing at the same page of understanding or has the perspectives shifted after the sessions that we've had. Waiting for everybody else's responses.
Please answer. There are prices at the end of it. We will not tell what prices are there. So if you are short on responses, your price is gone. Answer every question. Let it be wrong. The price is for the response, not for the answer.
We're still at 20-30%. I think we've clearly not made our point yet. Okay, so we've moved from 20 to 30% to 40 to 50%. There is a shift in how we began with the knowledge of what we had about CHG to what it is right now. Let's see how it goes throughout the day. All right, thank you so much. Are we breaking for
Yes,
tea?
we
Alright.
will now be breaking for a tea, and we request everyone to be back at least in
Please.
20 minutes. As
No,
15
just have tea and
minutes
come back.
as we move into the next segment. We are cutting short the break. Yes.
The tea is only for those people who are coming back.
Welcome back, everyone. As we return from the break, we now move into the next part of our program, recognizing the hidden development story. If the earlier sessions helped us understand the signs and the patterns, this segment invites us to pause and see the journey. So we begin with a short animated video conceptualized by our team. So this piece takes us through a child's journey, capturing the subtle signs, the psychological experiences, and the often unseen challenges that unfold over time. It brings together clinical insight and storytelling, helping us understand not just what happens, but how it's lived. So let us take a moment to watch.
Arjun was just 6 months old when he underwent complex heart surgery. For his parents, the surgery meant survival. For Arjun, it was the beginning of a journey no one could see. At 6 months, a baby understands the world through one thing: attachment. Suddenly, Arjun was separated from the one person who made the world feel safe. After surgery came days in the intensive care unit. Machines replaced touch. For a baby's developing brain, separation during illness can feel like abandonment, even when love surrounds them. The surgery was long but successful. Arjun's heart was repaired. In the ICU, parents watched from a distance. But when Arjun finally returned to his mother, something unexpected happened. He did not recognize safety the way he once did. When young children experience separation during stress, their brains sometimes respond with protest, confusion, and withdrawal. This is the mind's way of protecting itself. As Arjun grew, the scar on his chest slowly faded. Early medical experiences can also affect the developing brain. Some children may take longer to regulate emotions or cope with frustration. The trauma is not only the child's. Parents who nearly lose their child often become deeply protective, a response shaped by love and fear.
As children with congenital heart disease grow, they may also face hidden challenges in attention, learning, and social confidence.
But children like Arjun also show remarkable strengths. Many grow to become deeply resilient, observant, and emotionally aware. When families, doctors, and educators work together, children with congenital heart disease can develop the skills they need to thrive.
Heart surgery saves lives, but healing the heart is only the beginning.
Thank you for that thoughtful piece. We now take this conversation forward through a panel discussion, Signs We Did Not Miss. This session brings together parents and clinicians to reflect on signs and opportunities that could be missed, and most importantly, what we can do differently moving forward. So, may I invite our parents, Dr. Jonali Chowdhury, mother of a 13-year-old, Miss Sumeya, mother of a 20-year-old, and Miss Kaniga, mother of a 10-year-old, joining us from kilometers away. And now may I also invite clinicians, Dr. Jayakumar, Professor, HOD, Department of Pediatrics, and Dr. Shine Kumar, Professor, Consultant, Department of Pediatric Cardiology, and I also invite Dr. Balu, Senior Consultant, to moderate this session. Sir.
Thank you, Sonam. So this is really a very important session because most of the time we focus on the doctors and the patients, but this is an opportunity for the parents to come forward and share their experiences. And this is very critical because the parental perception of a problem is very important. So we have actually seen the signs. So KK told about how the survival has improved. Then Manu spoke about brain injuries and what are all the possible patterns. And then Sonam beautifully described the neurodevelopmental imprint, what all things can go wrong. Most of the time what we do is we focus on the gross deficiencies, which may not be there in many patients, in fact most patients. But subtle things can be there, which can affect the cognitive domain, which can affect memory, the language, ability to adapt to difficult situations, emotional aspects, maybe their energy levels. Some of them may be a little less energetic, some of them may be a bit more energetic, many things. So we learned and we also saw that about 30 to 40% of these patients can potentially face these challenges. So how we have designed this panel is that we will first get some details from these very brave parents. And I'm extremely grateful for them to come forward on stage facing an audience and sharing openly about their concerns, what they felt about their children who have survived the surgeries for congenital heart disease. Mrs. Kanika is online. Yes.
Hello.
Yes, thank you so much for joining us remotely. And Mrs.
My pleasure.
Mrs. Sumaya and Dr. Chowdhury from three brave mothers. So perhaps I can start with Dr. Chowdhury. So your child, can you tell about what you faced and did you actually notice anything different which Rib faced, on the recovery phase from the surgery as far as some of the things which we are discussing, like learning or adapting or cognitive domains, anything? You can openly share your experience.
Dr. Bala, what was the condition, the child's condition?
She will herself.
She will tell.
Do you have? Yeah, you have a mic. So you can sit and talk, madam. I will perhaps request you to, if possible, sum up in about 2-3 minutes. If you need more time, please do let me know.
Good morning. So my name is Junali Sodhuri. I am from Guwahati, Assam. My child has a CSD. It is a cyanotic CSD. So earlier, like when she was in class 3, 4 probably, so from that time I have noticed that she has some difficulty in remembering the simplest or basic things from the books. But if I tell her something casually, that she remembers very well, like in detail she remembers it. So at that time I thought it is just a lack of her interest in books. So I am also a teacher, so I have seen it in my students also. So I was not concerned at all. Like I thought when she will understand the importance of education, she will sense her attitude and then she will work on it. I thought in that way, so I was not at all concerned. But gradually I have seen that it is affecting her scores, mark sheet, it is affecting. So I'm a little bit worried now because she is growing up, and then I started searching for what is the problem. Recently I have gone through some of the papers. One paper, it was from AMRITA itself. KK sir was one of the writers. So I have found that there are lots of works going on, and then I have gone through probably 6 or 7 papers. Then I have seen that some of the papers say that Yes, CSD affects the neurodevelopmental things, especially if it is a cyanotic CSD or complex CSD needing multiple anesthesia exposures. And because of lack of oxygen, so that affects. And then in some papers, including this AMRITA paper probably, so it is said that CSD affects the motor skills, not the mental skills or the cognitive function. The conclusion was like that, if I remember right. So now I am confused. Like, what is the fact in general? What is the fact in my child? I'm not sure, I don't know anything about this. What is the problem? So I just want to know from you experts.
So
Thank you.
what are your specific concerns? How old is your child now?
My child is now 15 plus.
So what are your specific concerns now that your child has grown into a teenager? What are the things which worry you now from a longer term perspective as she grows into an adolescent and adult? What will be your, if you want to verbalize your specific concerns from this, whatever you feel she has difficulties?
She has difficulties in remembering the things from the books, as I told earlier, not the casual talks, she remembers it. And then she has some problems with her motor skills, probably it is called, because she cannot draw a circle with free hand without the compass. She cannot draw a square properly. So those things are there, and still in that case also I am confused. Like if it is a problem in her learning or my teaching, I'm not sure.
Okay, thank you so much. So we will address these concerns as we move forward. Now, Mrs. Sumaya, I spoke to you during the break.
Yes.
And you have a 20-year-old daughter who is an engineering student now.
Yes.
So that is actually something which should be giving a lot of hope to the many parents. And I understand that your story is a bit different.
Yeah, it's different.
And so maybe you can just say how you saw your child shaping up after surgery. When did your child undergo surgery, heart surgery, what age?
At 4.5-year-old.
4.5 years. And how did you find her school performance?
Actually, she was a really brilliant child. In academic
If you wish to speak in Malayalam, it is fine.
it's okay.
Whichever language you are comfortable.
Academic, she was very well. And even well spoken. ഇവിടെ ഹോസ്പിറ്റലിൽ വന്നു കഴിഞ്ഞാലും എല്ലാവരുമായിട്ടും ഭയങ്കര സംസാരം. Even Krishnakumar sir and Mahesh sir's favorite child എന്ന് പറയാം. They know her very well. I didn't find any difficulty like academic or mental development wise. I didn't. Only physically growth വളരെ കുറവാണ്. Even now her height is just 4'6". അപ്പോൾ അതൊരു ബുദ്ധിമുട്ടുണ്ടായിട്ടുണ്ട്. ലൈക്ക് ഷീ ഈസ് ഓൾവേസ് വിത്ഡ്രോൺ. ഒരു ഇത് എല്ലാവരുടെയും മുമ്പിൽ പോകുമ്പോൾ ഏറ്റവും ചെറിയ ആൾ. അപ്പോൾ ദേ ഓൾവേസ് ആസ്ക് ഹർ.
Did you attribute that to the fact that she might have underwent heart surgery, the physical attribute?
Yeah, even I was told ഈ സർജറി കുറച്ചും കൂടി earlier if you could have done, കുറച്ചും കൂടി growth ഉണ്ടായാനേ. But I don't know how much, എത്ര true ആണ്, I don't know.
So your only concern is in the physical growth,
Yeah,
but you
physical
feel
growth.
that
because of that she had a full dental issues. So heart surgery time kore tension angane undayirunnu, because each time when we were planning for the surgery we had to undergo dental procedure.
Okay.
appo angane kore tensions undayirunnu.
But
right
none
now
from the school performance, none
I
from
am
the adaptive.
blessed actually. I'm thanking God that I got such a child. Like she's such a sweet child for me.
If I just probe one more thing, was she a blue baby before the surgery?
No,
Okay.
nothing like that.
She tetralogy of Fallot.
Tetralogy of Fallot. Yeah.
Sorry, I didn't say that.
Yeah,
tetralogy of Fallot. Right.
And
so,
even I was told multiple surgeries വേണ്ടി വരും എന്നുള്ള പറഞ്ഞിട്ടുണ്ടായിരുന്നു already. So I was prepared for
but
that.
she has undergone one surgery now, and maybe MRI and something else.
In 1 year, like doctor.
So this also tells us that look, we cannot have one size doesn't fit everyone. You know, we had Rib's mother telling some of the concerns which she has, and she even probably ended with a statement that she's a bit confused. But Mrs. Sumaya is completely clear. You know, her child had a completely uneventful schooling. She is very happy child, and like the smiling mother. Yes. Now, what about Mrs. Kanika who has joined? And maybe you can tell how old is your child now? 10 years, I understand.
Namaskar. I'm Krisha's mother. Krisha is going to be 8 next month.
Okay.
He had his first open heart surgery for tetralogy of Fallot when he was 4 days old. It was a BT shunt.
Okay.
So when he went into surgery, he was 2 kilos, but he came out at 3.5 kilos because of edema and water retention.
Mm-hmm.
And right from the beginning, like in the first 2 years of his life, he had multiple procedures, and because of that, his body was focusing on healing rather than growing. So we had a lot of challenges about growth and about development, largely physically because he was still so young. So cognitively, it was hard to understand at that time. And also, that is the period when COVID hit. So we couldn't really get therapy and early intervention for him, but we did whatever we could. And so we intervened early. We got him physical therapy, speech therapy, feeding therapy, occupational therapy. Any therapy that was there up for grabs, we went at it and we took it
So,
forward.
Mrs. Kaniga, what all were the problems which you actually saw in your child? So, you said you went for a lot of therapies early. So, what were the difficulties or challenges which you thought your child had?
So, because of heart surgery, he had a lot of dental issues. Like Mrs. Amaya said, he had entire dental surgery where we capped 18 out of 20 teeth. So he had an orchidoplexy because of one undescended testy, which was in the inguinal canal, was pushed into the abdomen. So we had to bring that down surgically. Also, there were a lot of developmental delays. So physically, he was not holding his head up independently until he was about 5 months. The social smile was delayed. Communication was delayed. Following objects with his eyes were delayed. So like that, lots of physical delays were there. He started walking only when he was 2 years old, as opposed to 1 year old for other children, other typical children. And when he was walking also, it would feel like something is not right. He's not very stable. It's like you used to get the feeling that he's just about to fall. He's just about to fall. So we went to multiple therapists until we found the right therapist. He was, I think, about 4 years old at the time. And we found the right occupational therapist. We found the right speech therapist for him, and they really helped him.
So,
he-
after you consulted this therapist, do you observe a difference in his overall developmental patterns?
Massively.
Okay, very good, very good.
I think his cardiac team and his pediatric care team is wonderful,
Okay.
and they have managed to give him life. But it's his therapy team that has managed to give him a quality of life.
Absolutely. So I will probably pause at this point. The phrase which he said was the cardiac team gave him his life, but the therapist gave him back his quality, the quality of life. So we heard from three parents. Now let us come to the doctors. I'll start with Dr. Jayakumar. Sir, you are one of the senior most pediatricians in this country. When a child who has undergone heart surgery comes to you for, let us say, some issue, maybe a pediatric issue, do we in our practice actively trying to probe into the developmental issues? Do we ask questions, or is it like only on demand? Some parents say that this problem is there. Do we try to elicit any, is there a protocol which we are following in our practice now?
Honestly say no. Because from this meeting is an eye-opener for me also, in the sense that we have to address this issue also here afterwards. So when a child is not doing well, there are two reasons for that. One, for each and every problem like this, two things are there. One, the seed may be abnormal or the soil may be abnormal. So we cannot solve the problems of the seed. So can address the soil. If you are able to fertilize the soil, then we will get good development. For example, I don't know whether your child had a basic genetic abnormality when a child is having heart disease. In the absence of that, let us see why he is not improving properly, why he is not attaining motor milestones. You said the child is 15 years. So what we expect for a 15-year-old child, he should be able to swim, he should be able to ride a bicycle, he should be able to play cricket, like that. But this child is having motor delay. Why it's like that? Is it because of the heart disease? We don't know. Whether he has any other any paralysis or weakness, mild weakness is there, whether she has any thyroid problem, any micronutrient deficiency, all this has to be addressed. And before that, we have to see whether why this child is not developing properly. So you said this child, your child is having delay in motor and also intelligent wise, fine motor, that you said this child is not able to draw a circle, but that we are expecting for a child of 3 years. 3 years child is supposed to draw a circle. So your child is not able to hop on one foot. So that means all parameters are delayed. We have to address this issue. For that, a proper clinical examination, as we just now we are doing, developmental assessment is very important. And after that, we can try to solve the problem. Any other issues are there? As I said earlier, any endocrine problem, any micronutrient deficiency, all this has to be addressed.
Right. So coming to you, Shine. Now, why are we not doing it routinely? Is it because we don't have time, or we feel that, okay, I have fixed the heart, that's my job? We'll do an echo, we'll do an ECG, we'll just spend a couple of minutes with them. We see 50 patients in a day in the OPD. Or is it because of the fact that we don't want to tell them that, okay, such a problem also could be there, which could potentially spark another series of stress for the parents? What is the reason why we don't go into these depths of neurodevelopmental sequelae in our routine practice?
So that could be multifactorial is what I think. Definitely for a clinician who is taking care of, especially after a congenital heart surgery, it's not an excuse to say that we are busy in the clinical practice and we can't look into those aspects. Since we have something like a development program running in our department, it's always back in our conscious of our mind that that aspect would be there. But to be truth, when you see this much patients a day, you just ask them, how is your child doing well or not? We are not probing deep. That's not there. Whether he's going to school, whether he's learning, jumping, activity is good, we are satisfied with that. We are not concerned the fine aspects of the development and the adjustment issues or the psychological issues the child can have. And obviously, if the child is syndromic, for example, like a Digeorge syndrome, you know that the child is going to have some developmental disorders or intellectual disabilities in future. So those patients we may tend to probe a little more, but for a normal child otherwise, I don't think we are not in the true line of eliciting these illnesses early.
So I think, what about KK sir is sitting there? I may just want a comment from him on this.
No, Shine actually put this issue very nicely, and I agree that I think we subconsciously become partner to the parents' denial. Parents are in denial, you join that denial, it's so convenient. We don't address the elephant in the room, which is we don't probe deeper and don't ask uncomfortable questions for the fear of consumption of our time, and that needs to change. One solution is that we have partners. Because we are busy, you need somebody else to look into it, which is one of the reasons why we've set up what we've set up in this. But I'll tell you, there's a little bit, we've got enlightened parents here, and I think we need to thank them for coming here. The parents can completely change the paradigm. I'm going to take Kanika's example. She's here, I brought her online because I haven't seen any parent who has understood the disease, the process, and the treatment in the manner that she has done. And she's been so proactive that she's changed the developmental trajectory of her child. Something that was so inspiring that I said, okay, let's bring somebody like that. So it takes partnership, both parents as well as doctors. And once through this partnership becomes really symbiotic, it really results in a transformation.
Thank you, KK. So I'll go, yes, Samaya. Yes, please, you can add.
Like he said, it's actually the നമ്മുടെ പാരൻസിൻ്റെ റെസ്പോൺസിബിലിറ്റിയും കൂടിയാണ്. Because when I found my daughter had this physical growth problem, I asked him, like, what should I do? And then he suggested I went to endocrinologist. I did all the fish test and all the tests. അപ്പോൾ നമ്മളും കൂടി കുറച്ചൊന്ന് because they have many patients. But we should be aware of our child's എന്താന്നുള്ള.
Okay, so I am coming back to the parents for the next round of discussion. Maybe I'll start with you, Kanika. Now, did any doctor tell you that you need to do all these things? Or did someone else tell you? What made you pursue this early interventions? I am talking about, let us leave the non-cardiac surgeries beside for the time being, but mostly the developmental aspect. What made you actually pursue this? Who told you? Was it your own research? Was it your own, feelings about your child? What was your inspiration or motivation to pursue this early?
So thank you for asking me this, because this has been a point of contention, an internal point of contention for me for the longest time. Unfortunately, I feel nobody really focused on anything but the heart at that moment because it was so important. And because my son had a blood transfusion during surgery, doing any tests was not possible for another 6 weeks. But everyone says that you should not Google, parents should not Google. But that is where I learned that congenital heart disease might actually be related to some syndrome or some other issue, and that it might just be a symptom and not the issue itself. And so that's how I started to research and research. I was very lucky that I had an amazing team of doctors who were indulging me and who were willing to answer my questions, who were willing to work with me. But there was no real format as to how we should handle the syndrome. Like Dr. Shine said, DiGeorge syndrome. There's no management guideline for it in India. So we had to find a management guideline for it from the West. And I connected with hospitals in the West and doctors in the West, found a management guideline, and that is what we followed. But luckily, my cardiac team, my pediatric team was so open-minded that they were actually willing to follow the guidelines laid out by the international team. And besides that, I spoke to parents, I just gathered as much information as I could from anywhere that I could. And I realized what the problems might be. And instead of solving the problems when they come up, I decided to preempt them. So, for example, I knew learning disabilities might be an issue, reading might be an issue. So, I started my son off on phonics. I took him to an institution in the West called Linda Mood Bell, and they help with early intervention of reading and math. So, sorry, my son's with me right
It's
now.
really good. If you don't mind, perhaps he can also join you in the video link.
Of course.
Yes.
Can you say hi?
Hi, how are you?
Good.
You're good,
KK
doing
uncle.
good?
Yeah.
Very
KK
good.
uncle's around. He's
Yeah.
watching you. You can say
Yes,
hi
all
to
of us are watching you, and we are really pleased to see you. I wanted to ask you this question. Did you ever think or want your doctors to tell you that, okay, we need to do the testing, genetic testing, and maybe even before he had problems? Did you really want this to be done before you identified? Did you really
Yes, sir.
wish at some point that your doctors told you all the possible challenges which he is facing now, for which you are doing rehabilitation? Upfront,
Yes,
did you
sir.
want this information?
Sir, because if I had that information, it would have made one
Maybe
step
I'll
less
need
for
10
me.
more minutes. Is it okay, KK?
I would have had one more less step to do, because then I wouldn't have had to find the information on my own and I wouldn't have to second guess.
Yeah. So what about you, Sumaya? Like, suppose if you come to me, and I am the pediatric cardiologist, maybe I have time. I have less patience on that day, and I have a chat with you and say tetralogy can have these things. And how will you sort of, അതെങ്ങനെ എടുക്കും ആ ന്യൂസ്? ഇതുപോലെ ന്യൂറോളജി കോഗ്നിറ്റീവ് ഡിഫിക്കൽട്ടീസ് വരാം, അതിന് ടെസ്റ്റ് ചെയ്യണം, ചെയ്യുന്നത് നല്ലതായിരിക്കും എന്ന് ഞാൻ പറയുന്നു. We will do, അല്ലേ?
അതാ നമ്മൾ ചെയ്യാം. ബിക്കോസ് ഫസ്റ്റ് തിങ് വി ഷുഡ് ഹാവ് ഇസ് ട്രസ്റ്റ് അവർ ഡോക്ടേഴ്സ്.
Okay.
എന്നാലേ ഇറ്റ്സ് എ കമ്പൈൻഡ് പ്രോസസ്സ്. നമ്മൾ ഒരാൾ കൊണ്ടിട്ട് ഡോക്ടറിൻ്റെ മാത്രം സൈഡ് ഓക്കെ ഈ ഡിൻ ഡു ദിസ് വി ഓൾസോ ഷുഡ്, ഇപ്പോൾ സാർ പറഞ്ഞ പോലെ ഒരു ഇതിൽ തന്നെ പോകണം. അപ്പം വി ഷുഡ് ഡു എന്നാ എൻ്റെ ഒരു ഒപ്പീനിയനിൽ.
So, Dr. Chowdhury, do you think that we need to integrate all these things which Mrs. Kanika said? She has done a lot of things. And do you think that right from the beginning, your child has gone through more than one surgery, cyanotic congenital heart disease? Do you think this process should begin early, before even you notice these things? Do you think it should be a part of the protocol and follow-up? What is your opinion?
Yes, it should be inside that the whole system should be like together. So that would help all the parents, because we parents, sometimes for us, whatever is seen in our baby, that feels normal. Even I can remember the color. I had no knowledge about the color, but it was, yes, it was bluish. But I thought this is the normal color. For a baby, when she cries, this is the normal color. Because I don't observe others' children properly. So it is always better if it is told by the doctors, because we follow the doctors like religiously. Whatever they say, we follow. We try to follow.
So if the doctor says that, okay, the heart surgery is done with, but then potentially there could be additional some areas which we need to look into, and we need to go into such details as parents. Like I'm asking you, all three of you, how will you be your response? Will you be okay for it, or will you be more concerned that why are you talking about all these things? We feel that our child is good. Why are you telling that, you know, there could be a neurological, neurodevelopmental issue? Will you be worried about it, or will you be actually for it? Kanika?
Sir, I might have a really sad response initially, but I would appreciate that information because, like in Krishav's case, his pediatrician, Dr. Verma, started him on occupational therapy when he was in the NICU post operation. And I think that really, really helped him because we did not lose those 3 months of hospitalization without therapy. And instantly, like from, if it's a good therapist, I have realized that from the first session, every session, you see some minor benefit.
Thank you. What about you, Sumaya? You were lucky, but if somebody told that ingana cheydal koda adu acceptable ആയിരിക്കുമായിരുന്നു?
Because at that time നമ്മുടെ കൊച്ചിന് എന്താ നല്ലതെന്ന് വെച്ചാൽ we were running about എത്ര ഡോക്ടേഴ്സിൻ്റെ അടുത്തോ, even I went to ചെറിയാൻ
So one more doctor added.
Yeah, ചെറിയാൻ doctor, ഹൃദയാലയ, and what he said was, you have the best option near your house, AMRITA hospital, you opt for it. അങ്ങനെയാണ് I came back and
surgery പോരാതെ, not just the cardiac care, but this neurodevelopmental care, അതും കൂടെ ആഡ് ചെയ്യുമ്പം, will that statement, that advice cause you more concern or more sort of relief?
Of course concern ഉണ്ടാവും, like you'll be thinking, oh, ഉണ്ടോ problem, double thought വരും. But anyway, if doctor, because we have trusted our doctors, അതാണ് first. So if doctor is suggesting, we'll surely go for it.
We'll go for it. And do you agree with this, Dr. Chowdhury, what the other two ladies said? Will
Yes,
you?
sir, exactly.
Right. So will you be willing, like suppose if there is an opportunity to sort of communicate to the other parents, like will you be okay if somebody comes and asks you, like, you know, is neurodevelopment a concern? Another parent, will you be open to tell them that yes, it is a concern and perhaps you should go for an early intervention?
Yes, sir. I think we have a such type of platform where whatever we face personally, we all share in the group so that the other parents get aware.
Right.
So we are already doing this kind of things.
You are already, I think you are very active in these forums, and you are sharing a lot of your experiences, which is extraordinarily brave from your part. Shaheen wants to say something?
So one concern or a different line of thought in this aspect would be, I think the counseling regarding the neurodevelopmental issues should be
individualized, yes.
Because for a baby who is Daijo syndrome, we will know by seeing the baby itself, the baby is going to have trouble. So when you talk about open heart surgery to a parent, they are already stressed to the core. On top of that, on the same breath, if you give the information that your child is not going to be mentally normal, even if the surgery is 100% successful, it can create havoc.
Right.
So I have willfully withheld that information from a lot of my patients. I have made them recover properly from the surgery, and when they come for follow-up, you slowly sink in that information.
So at some point of time, we would definitely want to tell them, right?
But in the post-op course, if you feel that the child has some neurological issues from the heart disease which he has sustained, his brain function may not be normal completely when he grows up, you can tell the information by the time of discharge. You can just give a clue that you need to follow up regularly neurodevelopmental outcomes.
Yes. So
that would be one way to go ahead with it.
Sorry, can I interrupt for a second? Sorry, Dr. KK.
Yes.
Dr. Shine, I have a question for you. Wouldn't that be lulling the parents into a sense of complacency that now everything is okay, and then making their world break all over again?
I think.
Yeah, that's
so
So I'll tell you how I handle it. So one of the ways is what Shine is suggesting, but one other way, what I suggest is that we do counseling in stages. We don't counsel everything on day one. It becomes too overwhelming and breaks parents down. So what I do, what I think we should be doing, and I try to do it whenever possible, is that I don't tell everything at that point of time. We have a second sitting after the parents have understood and internalized the first sitting. I call them again. I have to tell you a few more things. So then it becomes easier. So in fact, I have found this staged counseling far more effective, because it's the amount of, if you can't take more than one bad news at one go, it just breaks people down. So if you can stage it and do it, and also, you can balance optimism with the communication, with caution. So what I say is cautious optimism. So you do it in a way that you don't break that optimism, but at the same time, don't lull them into complacence. That's a fine art. It comes with time.
I agree. I've experienced that with you, sir.
Right. So I think the overwhelming mandate from this discussions is that many parents are actually aware that these things are there in some way or other. So Jayamar, quickly.
Yeah, pediatrician's point of view, I think we have to address two more things. Nutrition has to be addressed, and one more, immunization. So any infection can cause temporary regression of the milestones. So you have to give vaccines that's available. For example, these children should be vaccinated against flu, influenza, hepatitis A, chicken pox, typhoid. All these vaccination also has to be taken. The reason being that any infection can cause temporary regression. That also has to be addressed. If you give the good nutrition, good quality of protein, what the recommended calorie, that's good for them. But to improve them physically and also mentally.
Thank
and
you,
also
sir.
when they come for follow-up for clinic, we can refer them to a developmental therapist also. They
Which
can
is what
assess.
we are going to discuss now. So I think the discussion has been really very, very vibrant. And the parents were very forthcoming, and they were not scared to actually come up and say what their children faced, what the families faced. And we also then discuss how much should be said. Should we counsel them in the first go? I agree. I also follow a very similar approach to what Dr. KK said. In fact, my counseling begins well before the baby is born. In fact, we do prenatal diagnosis, and in such situations, most of the tests are done because parents demand it. It is very important that the parents are well informed. It is very critical. In some of them may be highly educated and motivated, like the three of you. Others may be less educated, but nevertheless, irrespective of whatever is their status, educational status and understanding capabilities, some amount of information has to be told. We have to balance optimism with realism, and then which will help them after surgery. And I think we all completely agree that people like Sonam Manoj and her colleagues in neurodevelopment have a very important role to play in present-day pediatric cardiology. I think the purpose of this panel discussion was to get this from the parents, and I hope we succeeded in that mission. Thank you very much. And I would like to thank Dr. Jayakumar, Dr. Shine, Sumaya, Kaniga, and Dr. Chowdhury for joining this panel. You were exceptional. Thank you very much.
Thank you for having us.
Sorry to interrupt such a lively session because unfortunately my close friend Dr. Kirsten Verity has been waiting at 6 a.m. in the morning from Edinburgh. Hi Kirsten, can you hear me? Is she there? Yeah. I mean, it's sleeping time, but she's up and running to deliver her lecture. And that will be a recorded one. And after that, Kirsten will be answering your questions. She's a highly respected consultant pediatric neuropsychologist. It's NHS Lothian, Edinburgh, where she's been leading the pediatric neuropsychology services and development follow-up for children. She has played a significant role in developing and strengthening neuropsychological services for children, particularly those with complex medical and development conditions. I had the opportunity to interact early days of this thing. I think, in fact, this idea when came, I visited her in Edinburgh and we had a long discussion, and now she's on stage to talk about her experiences. So, Kirsten, we're going to show you a video first. Hi, good morning. Is it
Hi,
morning
good
there?
morning.
Is it night
Thank
or morning?
you.
Okay. Yeah. So we will play your video. and then you can answer the questions. Okay, Aarti.
Hello, everybody. My name is Dr. Kirsten Verity, and I'm a paediatric neuropsychologist. I'm the service lead in Edinburgh's Royal Hospital for Children and Young People in Scotland, and I have been practicing as a paediatric neuropsychologist for 22 years now, and I teach on the Doctorate in Clinical Psychology course and the MSc in Human Cognitive Neuropsychology courses at the University of Edinburgh. And I've contributed to teaching on cognitive assessment for national training with the British Psychological Society. So I was very excited to be invited to talk at this event, and I was delighted to have visited your wonderful hospital, AMRITA Hospital, just last year. So I'm going to share my screen now. Unfortunately, I have not cracked the technology, so I cannot put a cameo on, but you know what I look like, and I will see you again at the end of this. So I'm just going to share my PowerPoint. So my talk is about IQ, and also about why IQ is not the full story when we think about outcomes for children and young people following CHD interventions or with CHD, with congenital heart defects. So when we've been thinking previously and looking at the research outcomes for this cohort, we've maybe concentrated on mortality and morbidity, so survival and gross disability. But as the above have improved for these children and young people, we are focusing more on an outcome that will reflect a wider view of impact. So thinking about the neurological impact in particular and the developmental impact. So with the preschool children, perhaps the research had moved in the direction of developmental assessments, and from a neuropsychological perspective, assessing IQ would be our way of looking broadly at neurological impact following CHD. So, given that IQ often features heavily in research, I wanted to talk about how relevant IQ is when we think about outcomes for our children who have had CHD management and treatment. So today I'm going to cover what IQ is, very briefly obviously, what IQ is and how we found it, broadly what we might mean by outcomes, what the correlations between IQ and these wider outcomes look like, why the brain might be vulnerable in CHD from a neuropsych point of view, and thinking beyond IQ, in particular about this system that we call executive functioning, and what that is, and how executive functioning might manifest or might be viewed from a different perspective as a neurodevelopmental presentation. So what is IQ and how do we find it? So IQ stands for Intelligence Quotient. This is a numerical score that represents a person's overall cognitive proficiency, comparing their performance to others of the same age and gender. And the way that we find this number is essentially, usually a psychologist will sit with an individual in a distraction-free environment and administer a selection of tasks and questions according to quite a strict protocol and script. And then we score this up, we score performance up, and then we can compare those scores with a normative curve of performance on exactly the same sampled tasks. So broadly speaking, an IQ normal distribution would have 100, an IQ of 100 being at the 50th centile, right in the middle of the average range with average actually ranging from between an IQ of 90 and 110, which is 25th to 75th centile. And if you extend slightly to a low average and a high average IQ, that takes us actually from an IQ of between 80 and 120. At the very extent of the furthest margins of the IQ normative curve, we have the top 2% and the bottom 2% of the population on these tasks. Bottom 2% would have an IQ of less than 70, which falls within the intellectual disabilities or learning disabilities range. And the top 2% would have a performance of 130, an IQ of 130 and above. And that takes us into the extremely superior range in terms of cognitive proficiency or cognitive function. And that's what we would also, it would also take you into the Mensa range if you're familiar with that organisation for people with very high IQ. And broadly speaking, the usual tasks that we use in Edinburgh, and I know that these assessments are being used here as well, are from the Wechsler Corporation, when we want to look at IQ. And this divides core cognitive abilities that make up the overall IQ. It divides it into 5: verbal abilities, visuospatial abilities, working memory, which is the ability to hold and manipulate information in mind for short periods, processing speed, and abstract or fluid reasoning. Okay, so this is what makes up IQ. But let's just first give you a little bit of a behavioral, we psychologists, we like these behavioral experiments. Okay, so if you're interested, here are 3 Mensa style questions that you might want to pose to yourself. And you can read them out quickly for you. Find the number that best completes the following sequence: 1, 2, 4, 11, question mark, 22. Then there's a kind of logic puzzle. Jane went to visit Jill. Jill is Jane's only husband's. Mother-in-law's only husband's only daughter's only daughter. What relation is Jill to Jane? You might want to take a photo of that. There is, and the final question, there is at least one 9-letter word in English that contains only one vowel. Do you know what it is? Now, if you want to do those tasks, that's fine, but I would ask you to also try and attend to this chat that we're having, and I'll tell you the answers later. Going back to IQ, okay, what can it tell us? IQ can tell us what someone's cognitive potential is. It doesn't reflect their actual real-world performance. Remember, I said to you, this is completed by psychologists according to a script, sitting in a distraction-free environment, one-to-one, and it looks at verbal, visuospatial, processing speed. You know, it's a very specific areas of cognitive function that make up this IQ construct, and the situation in which we assess this is fairly alien. It's not really real world. So it reflects potential, but not necessarily real world performance. And IQ is not the same as academic attainment. Those are learnt skills like how to deal with numbers, how to write, how to read. So not the same as academic attainment, but there is a relationship. IQ is predictive of performance in structured academic environments, but it does not reliably predict social functioning, emotional well-being, quality of life outcomes, mental well-being, resilience, etc. So it doesn't do everything. And actually, many of those functions are quite important. Success is more than just academic performance, isn't it? So IQ, and I think we can probably all think of people that we know, especially if you work in the university, for example. We know people who are incredibly intelligent, but they may not be so good at connecting with other people, or they may not be so good at managing their own emotions. So it is possible to have very high IQ, but not necessarily have emotional intelligence or high social functioning. And these are also important when we think about outcomes in the real world. So basically, we need to think about what real world functioning actually needs in terms of cognitive processes, because it's more than just what we capture with these IQ tests. So we need to be able to solve problems. We need to be able to adapt to situations flexibly. We need to be able to regulate our emotions. We need to be able to interact with people. We need to be able to look after ourselves and plan and organise ourselves. So a good outcome in the real world is about more than IQ. So these skills that I'm talking about, what am I talking about when I'm talking about organising and regulating? These are executive functions. Now, the great Russian neuropsychologist Alexander Luria, earlier on last century actually, really was groundbreaking in terms of understanding how cognitive functions worked and what was required to be able to use them effectively in the real world. And he said, the frontal lobes do everything in general and nothing in particular. Now, executive functioning sits within the frontal lobes, and that is the function he's describing. It's that set of skills that orchestrate or coordinate and the individual parts of cognition that you assess in formal IQ assessment in order to deal with situations as they arise or problems. And it includes a lot of regulatory functions cognitively. And if you think broadly, cognition is your kind of thinking, it's memory, it's visuospatial ability, it's verbal ability, and cognitive regulation is using those skills in the real world. So being able to plan and organize, being able to think what you want to achieve and how you're going to do that, put that into words in order to achieve that, being able to switch from one task to another in order to achieve your goal, being able to dual task. So that's cognitive regulation. It's a big part of executive functioning. Emotional control, which is being able to manage your feelings. It's managing to contain your emotion rather than it bubbling out and creating difficulties for you in the real world with other people. It's choosing and deciding on your emotional response. And behavioral regulation is everything from starting and stopping a task to transitioning from one task to another, or moving between tasks, or inhibiting behavior that you might want to show, or starting and initiating behavior. So executive functioning is critical in how we apply our cognitive skills that we find on IQ testing in the real world, and it is probably also the most vulnerable cognitive function. There's a picture of your executive function that I use with kids. So executive functioning is the most vulnerable cognitive function from a neuropsychological point of view. We see it, we view it as having multiple different aspects to it and multiple reasons why it's vulnerable. It is the function that develops the most slowly. For example, if we think about motor functions like walking, essentially that develops in the first 5 years of life, if not before. We think about talking, that usually has developed fairly fully by the age of 6 or 7. Executive functioning, it starts quite late in developing. We don't expect a young child to be able to regulate their emotions or regulate their behaviour. So it starts later and it develops slowly from early childhood into adulthood, all the way through into mid-20s. So there's a lot of continuing executive function development. It's functionally located in the frontal parts of the brain, as we said. Now, these parts are the last parts of the brain to myelinate, last parts to develop generally. Now, due to their location, they're extremely vulnerable to many things, including changes in blood supply, or blood quality, or little thrombosis, or ischemia, or hypoxia. And they are also the most likely part of cognition to be affected by environmental influences, including attachment. So that's the primary caregiver and infant relationship that we often see disrupted in children who are hospitalized early, very early in their lives. And when the primary caregiver can't stay with them, that relationship is actually critical in terms of executive function. We also see disruptions in executive function following traumatic events or repeated trauma. Again, I think of the children that I see coming into the hospital who are really traumatized by their treatment, and it's treatment that is saving their lives, but is also having an impact on their experience and actually on their brain development at particular times. And the younger the child, the more vulnerable the systems are to being impacted. So obviously we'd expect CHD infants to be at high risk of executive functioning issues, but because of the way it develops so slowly, you often won't see the full impact until much later in life. So the difficulties kind of become more evident over time. And it's a very important predictor of long-term outcomes. It predicts emotional, social, behavioural, academic outcomes more strongly than IQ. And it moderates the effects of adverse socioeconomic influences. It predicts well-being, resilience. It allows someone to be more adaptable to deal with stress. And it's essential, essentially, for day-to-day functioning and also for quality of life. So when we think about outcomes, we cannot neglect executive functioning. So executive functioning difficulties impact, obviously, on all aspects of life, but most obviously behavioural, emotional and social. And sometimes that can impact on academic underachievement as well. So someone not being able to meet their full potential because their behavioural and emotional challenges interfere with their ability to cope with being in school, to make advances in their learning. And we see poor outcomes in relationships, in community. We see increased forensic involvement of crime because of behaviour or poor decision making. We see increased risks of acquired brain injury, head injury, because of risk-taking behaviour, which is part of making poor decisions and dealing badly with emotions and not being able to regulate your behaviour. We see poorer mental health and reduced quality of life. So even with a normal or high IQ, executive functioning weaknesses are going to significantly impact on day-to-day functioning and long-term outcomes. And executive functioning underpins a lot of the presentations that we would see and make a diagnosis of a neurodevelopmental condition such as ADHD, autism spectrum disorder, ASD. So these are basically behavioural outcomes that we can fit diagnostic criteria, or fit against diagnostic criteria to come to the conclusion about these diagnoses. Essentially, they are underpinned by executive functioning deficits, different patterns of deficit, but actually there is a lot of comorbidity between ADHD and ASD. We see up to between 40 and 60% comorbidity. So it's heading towards being the norm, not the exception. And ADHD and ASD, they do not invariably correlate with low IQ, but they are underpinned by executive functioning deficits. And we know with these populations that if we don't recognise their difficulties, if we don't meet their needs, then we know that they have a poor outcome. So it's the same as executive functioning. So executive functioning versus IQ in terms of predicting ND outcomes, essentially executive functioning is at the core of a lot of these difficulties that we see in social difficulties, emotional well-being, mental health difficulties, ability to look after yourself independently. Executive functioning is central when we look at these outcomes. We know it's most vulnerable cognitive function. We've said that medical conditions and treatments that impact on blood flow or blood quality in a developing brain could result in these problems. We might not see them till later. IQ might be normal, but it may present as an ND issue like ADHD or ASD. Ultimately, it's the important predictor for long-term outcome rather than IQ. I know I'm running out of time, but this is a case study. 10-year-old boy, early surgical repair of CHD. He did catch up on his development, quote unquote. His IQ was 90. Academically, he was a bit poor at writing, but his maths was fine. If you stop there, you miss the fact that he's going to have more and more trouble as he goes through school. He's impulsive, he's inappropriate, he gets a bit hyper, he gets in trouble. His friends, he doesn't have any friends. His peers don't like him, he's isolated, he's low self-esteem. He's unlikable, he's bullied. He's a Coke can kid. At the end of the day, he's been shaken up and he just has an outburst. He's very difficult. He's difficult for the family. So in the real world, we need to think about this vulnerable group. We need to think about predicting their risk and identifying them as early as possible. I need to really, really quickly go on to this. Sonam is going to kill me. Answers to the Mensa questions and their executive functioning significance. Did you do the task? Did you get 3 out of 3? And if you did you then not follow what I was saying for some of the time while you were doing this? If you managed to do it all, excellent executive functioning, obviously high IQ, could well join Mensa. If you did the 3 tasks that were fun, you weren't able to pay attention to what I was saying, potentially a bit more of an ADHD type profile, bit of a fun side quest. If you did maybe one of the questions or you decided not to do the questions because you thought, well, you know, it's a good example, but I'm not going to do it, excellent executive functioning, because actually that is inhibiting the fun task and deciding to, you know, manage your behavior and stay on task. And with that, I will stop immediately. I will also stop sharing my screen and I will pass you back. Thank you so much for your attention, and I will no doubt see you.
Thank you so much, Kirsten. I'd like to take the stage to mention that she's also my international guide for my PhD. And I'm so glad that she's always been there with us, also guiding the neurodevelopmental and cognitive care unit. She takes us through every step. Literally any doubts, we first reach out and ask her, how do you think we do this? How do you think we should actually, you know, bring about quality, standard, and things like that to the department? So she's always been there for us. So thank you so much, Kirsten.
Thank you. Thank you so much, Sonam. I really appreciate being asked. Can you hear me okay?
Kirsten, thank you, and apologies for having got you out of bed so early and made you wait. So sorry for that. But I think this talk was extraordinarily insightful, and we enjoyed it tremendously because I think it just broadened our thinking completely, because we still are very much IQ focused. And it's important to recognize that there's so much more than IQ, and this talk brought that out very beautifully. Thank you for that.
We're open for questions. Anybody who wants to ask anything?
Executive function. Yes. How do we actually assess the executive function as a psychologist? Is there a way, structured way to assess?
Yes, I think this is something that we've talked about a lot, haven't we, Sonam? It is a bit, it's complicated because it's a very slow burn cognitive kind of set of abilities, and there's numerous different ways to assess cognitive function, executive function, and none of them, I think, are perfect. The 2 main tests that are available are the behavioural assessment of dysexecutive syndrome for children, and this, I feel, has a lot of ecological validity. The age ranges from 8+, which again is difficult, isn't it, when we're talking about infants? It's about that follow-up. And the other one that we would have over here is the Dellis-Kaplan executive functioning, the DKEFS system. And that, I think, is normed from 8 all the way through to 80, but it's essentially a compendium of old school executive functioning tests. I don't think it's great as an assessment. What I prefer to use when I'm assessing executive functioning, I prefer to use the BRIEF, which is the behavioural rating inventory for executive functioning. And this has a parent version, it's a questionnaire, has a parent version, a school version, and for the older child, I think that's the high school child, so 12+, I think, it has a self-report. And that, I think, does start to tap into executive functioning, because that's the plan. And it also allows you to, I mean, I talk about 360-degree assessments, so I like the face-to-face work that I do, or that we do as a team with children in the room, because you get a lot of quality interactional off-task information. So it's qualitative as well as quantitative. But when that is only one part of the story. And I think we have to understand that this is a very abnormal environment. It's an abnormal relationship, and then that the child probably doesn't know you particularly well. I'm always interested in the experts on the ground, the parents and the teachers, and the child's own experience. So the brief questionnaires allow you to tap into that. So you get a much more rounded assessment of functioning from and information from various sources. So that's how I would tap into executive functioning myself. The bad C, for a high school child who has reasonable IQ and reasonable other cognitive function, I think that the BADS C, particularly the final part of that, which is called the 5-part test, is very, very useful assessment of executive functioning. It's very real world. Basically, the child has to do 6 elements of a task, but they have to plan and organize it according to a set of rules, and then they have to undertake it. And then, so they're organizing, planning, switching set, doing one task, another task, going back to something else, making sure they've completed the whole task all within a time limit. This is much more like real life. So I think if you have a subtle executive dysfunction, this can really tap into that. But Sonam and I are talking a lot about how do we assess it in younger children, and there are protocols out there, but it isn't ideal trying to do that in a one-off, because at the end of the day, when we are doing a cognitive assessment, we are sampling a child's behaviour in a very unusual environment. As a psychologist, you're sitting in a room with a child, you're not that familiar to them, there's no distractions, it's not very real world, and that always concerns me if we're making too many conclusions about that. So I like to have information from lots of different sources, and that would be my approach, basically. I also think that we're missing a trick if we don't make the link between the neurodevelopmental presentations and executive functioning, because they're essentially a red flag or a marker. So if a child has ADHD type symptoms or autistic type features, the chances are that we're picking up on, like, if that's what the systems around the child are saying, I think we're probably picking up on some executive dysfunction within that child when we're saying those words. So that to me is a bit of a red flag.
Thank you, Kirsten. Just adding on to what ma'am was mentioning, in the Indian context, we use brief that she spoke about, which is more like a screening tool. And if we pick deficits there, we also go, we do a deep dive. So we have NIMHANS Neuropsych Battery for Children, where we actually look at every area, like say working memory, and then we look at inhibitory control. We look at flexibility, how flexible is the child, cognitively. So these are the areas that we have started to track now in the unit as well. Yes. Yes. All right. So because we're running short of time, is it okay if we can, move on to the next part of our program? Thank you so much, Kirsten, for being there. This makes, world of a difference to us.
Thank you so much for inviting me. I'm delighted to be there, even though it is quite early in the morning for me. But it's lovely to see everybody again.
All right. Now we move on, and we come to the moment that we've all been looking forward to. It is a time that we formally inaugurate the Neurodevelopmental and the Cognitive Care Unit within the Department of Pediatric Cardiology. This initiative began with a very simple but important shift in how we were looking at our children. As we followed them after cardiac surgery, we realized that survival was just one part of the story. There were questions around how children learn, how they pay attention, how they adapt and function in everyday environment. And very naturally, this work began to grow. It started with an ICMR project, and today we are more of a structured unit. Families are very well connected with us. They come back for follow-ups. Something that I should have mentioned during my presentation was that we sit at a 92+% of follow-up rate, which is excellent. So yes, that is who we are, and time for me to call upon the dignitaries on the stage. First, and always the first one in our list, Dr. Vasudevan, Dean of Research and PG Programs. Please come in for the lamp lighting. We will have a small lamp lighting followed by prayer. And I welcome Swamiji.
Swami Jayadamrita is here?
I think he is here, is what I understand.
I think we'll get him after that, and then we can start.
Okay.
First puja and then the lamp lighting.
Okay, all right. So we're waiting for Swamiji to come in. Meanwhile, may I please invite Dr. Vasudevan, Dean of Research and PG Programs, to come up on the stage. Dr. Anand, Professor and Head, Department of Neurology. Is it going to take a little longer? A warm welcome to Dr. Pratapan Nair, Senior Medical Superintendent, Dr. Rehnaji, GM Patient Services, Dr. Jayashankara Reddy, Dean of School of Social Sciences, Christ University. He's joined us from Bangalore. Dr. Krishna Kumar, Professor, Head of Pediatric Cardiology, our very beloved KK sir. We'll wait for Swamiji to come in and soon after have our prayer and lamp lighting. Okay, we have a request. There were a few people who asked for the animated video which they missed. They'd like to see it again. So if we can have that played. So we'll just fill in the gap as well before we have our lamp lighting.
Arjun was just 6 months old when he underwent complex heart surgery. For his parents, the surgery meant survival. For Arjun, it was the beginning of a journey no one could see. At 6 months, a baby understands the world through one thing: attachment. Suddenly, Arjun was separated from the one person who made the world feel safe. After surgery came days in the intensive care unit. Machines replaced touch. For a baby's developing brain, separation during illness can feel like abandonment, even when love surrounds them. The surgery was long but successful. Arjun's heart was repaired. In the ICU, parents watched from a distance. But when Arjun finally returned to his mother, something unexpected happened. He did not recognize safety the way he once did. When young children experience separation during stress, their brains sometimes respond with protest, confusion, and withdrawal. This is the mind's way of protecting itself. As Arjun grew, the scar on his chest slowly faded. Early medical experiences can also affect the developing brain. Some children may take longer to regulate emotions or cope with frustration. The trauma is not only the child's. Parents who nearly lose their child often become deeply protective, a response shaped by love and fear.
As children with congenital heart disease grow, they may also face hidden challenges in attention, learning, and social confidence.
But children like Arjun also show remarkable strengths. many grow to become deeply resilient, observant, and emotionally aware. When families, doctors, and educators work together, children with congenital heart disease can develop the skills they need to thrive.
Heart surgery saves lives, but healing the heart is only the beginning.
Om Amriteshwari Namaha. My humble pranams at the lotus feet of our beloved Amma. Now I request Swamiji to have the puja, following which we will have our lamp lighting. Now, I invite Please be seated. I invite the following dignitaries to the dais to have the lamp lighting. Dr. D.M. Vasudevan, Dean of Research and PG Programs, my mentor. Sir, please be on the stage. Dr. Arun Singh, sir, please. And Dr. Krishnamurthy, sir, please on stage. Now, Vasudevan sir, now I request our dignitaries to give their blessings, starting with Vasudevan sir.
Om Amareshwari Namaha. Dr. Manuraj, Dr. Krishnamurthy, and other eminent persons present here, faculty members, participants of the certificate program and the seminar. Today we are in the middle of the national seminar on enabling optimal brain development after childhood heart surgery. We have also conducted a certificate program on neurodevelopmental assessment related to Bailey scale of infant development, the India version. I understand that the hands-on training to assess the developmental milestones are also provided. My presence here is mainly ornamental, and therefore I shall make it very brief. Several factors cause the defect in the neurodevelopment, such as the genetic factors, including the CHD, fetal facts, the environmental facts, as well as the parental influence. The incidence of congenital heart disease is about 9 per 1,000 live births. That is very high actually. 25% of those born with CHD require some sort of surgical or other interventions during their infancy. And they are therefore at risk of neurodevelopmental defects. And that is an important cause, being the chronic hypoxia in the whole body, including the brain. The early diagnosis and the prompt intervention will give a great help for the development of the children, and they finally become a normal citizen later. This training will be of great help, and this national symposium, I think, will go a great forward to this to these concepts. And all those interested in brain development or the developmental pediatrics will have some, they will be of great use here. I'm glad to point out that at AMRITA Institute of Medical Sciences, we have started research on this particular program about 6 or 7 years back. And therefore, we have identified this problem perhaps more, maybe more than 10 years back. And we have also emphasized the patient and the doctor relationship that is very important in this area. And these discussions today that should move forward towards the policy statement that this should come forward to the national level policies. And that is an important task we have to take it up. And I am very much fascinated with that slogan, that is, healing of heart is only the beginning. And I do hope that we will march forward. And wishing all the best for this program. Thank you very much. Namaste.
Now we would like to play the introductory video. Actually, it was supposed to be before the message. Sorry, sir. I skipped it a bit. Can we play the video and then we'll continue with the messages? Thank you.
The field of pediatric cardiology has evolved considerably in the last 3 decades. We at AMRITA Institute have been extremely fortunate to have been a part of this remarkable evolution in this country. It was considered really difficult to take care and fix deformed hearts from congenital heart disease, but over the decades, the results have improved considerably. So much so that the focus has now completely shifted from just survival to improving quality of life. Over the last 27 years, we have accumulated tens of thousands of patients who have been treated successfully here and are growing up. And this has given us several insights that has led to us considering the development, the establishment of a comprehensive service for not just the overall follow-up and quality of life, but specific aspects of development such as neurodevelopment, school integration, societal integration, learning, etc. This has required us to think through carefully and establish a unique program, which perhaps is the first of its kind in the country. We now have a multidisciplinary group of individuals who are focusing on much more beyond just survival after congenital heart surgery. We are looking at child's motor development, mental development, and then school-based skills such as learning, and then life skills in terms of integrating with society and the other emotional and psychosocial challenges that some of these children typically face.
When we started working with children who have undergone heart surgery, one thing became very clear to us. The medical part of their journey was only one part of the actual story. The other part was still masked. These children grew up, they started doing things like any other. However, some set of parents came back to us with concerns they were not at all ready for. And these concerns were more to do with sometimes just that the child was not like the other children of their age. Some children were not adjusting well in the school. Some had troubles with learning. And some parents would just come and say that, we don't know what is really going on, but we feel there is a miss. So we started working very closely with these parents, and not just with the parents, we worked very closely with schools. We worked with the special educators, with the counselors, with the teachers. And one thing that we saw was the schools that understood the medical history of the child and made just very small adjustments actually made a huge world of difference to these children. We got academic accommodations, we got learning support, and just the awareness of teachers started going up, and that made the children adjust very well in their class system. There were parents who actually came back and told us something very simple but very powerful. They said, only if we knew this earlier, our life would have been so much easier. And this statement stayed with us. With the knowledge that we have of neuroscience today, we know that a young child's brain has an incredible power to adapt. And if there is right intervention given at the right time, there's so much more that we can do. Keeping this in mind, we knew that there was time to make something more structured, and that is when Neurodevelopmental and Cognitive Care Unit, NDCCU, within the Department of Pediatric Cardiology was born. This unit has three important pillars. One is very close to our heart, the first one, the clinical care. In this pillar, what we do is we follow this child right from the heart surgery throughout the developmental span, and we test them to see how they're actually growing up. All of this is assessed, and in case there is a need for intervention, then we either refer, and we also have support in our unit. The second pillar is capacity building. It becomes very important to us that there are more people in this space who know about CHD, and they're available for our children when they need them. We capacity building programs, we have observership and internship programs so that we are more equipped to see these children growing up. The third pillar is research, because if we truly want to improve the outcomes of these children nationally and globally, we need evidence. And through the data that we collect, help make more informed guidelines for children who are growing up with congenital heart diseases. But something that hit us was that many families who really needed this support were not able to financially support themselves throughout the neurodevelopmental care. Because for a parent, it is definitely more important to spend the money on an echo than on an IQ test, and which is quite understandable. So that's when we had this discussion to understand how can we support every child who deserves and who needs this help. And that's when the concept of Project Medha was born. Medha in Sanskrit means potential of the mind, and our aim is that every child whom we see is able to reach the maximum potential of their mind.
As part of our daily clinical work, we see children with congenital heart disease from various parts of this country. For the vast majority of these children, proper neurodevelopmental care after congenital heart surgery is beyond affordable. And exactly this is the same set of children who require early identification and appropriate intervention in terms of neurodevelopmental assessment. This is exactly where Project Medha comes into relevance. Project Medha is a CSR initiative set up by AMRITA Institute of Medical Sciences in collaboration with various CSR sponsors. As part of this novel initiative, we examine children for neurodevelopmental functioning as well as cognitive functioning across various stages of their life from 6 months to 18 years. But Project Medha goes beyond these simple assessments. The long-term goal of Project Medha is to ensure that these children who already undergo turbulent period as well as who encounter big fight for their life as part of congenital heart disease surgery and the related care are not subjected to another challenge or obstacle during the rest of their life. What we want in Project Medha is that these children normally develop, learn, go to school, interact with their colleagues, go through their scholastic performances and follow up their aspirations just like any other normal child. Because survival is only the first milestone in the fight against congenital heart disease. The long-term goal of Project Medha is to ensure that these children attain every milestone that is approachable and attainable for every other child in this country. Now I invite Anand Kumar sir to say his message.
First of all, I thank Dr. Krishna Kumar and Dr. Maniraj for giving me this opportunity to address this very light gathering. And I congratulate Dr. Krishna Kumar and Dr. Maniraj's team for setting up this program. Before I start, I have to check with Dr. RKK how much time do I have. Okay, thank you. So, today morning I woke up, or I woke up in the morning. So let me correct it, we all woke up in the morning, That means we were awake. Then what happened? We were aware of our inner self and about the surroundings. That is awareness. Awareness is a big topic because according to the conjunctural Big Bang theory, the first to happen at zero time was space or Akasham. But according to ethics, even before that there was awareness. And after you became aware, then what happened? You started responding to the stimuli in the external world as well as from your inner self. That is perception. And what does perception give rise to? It will give rise to thoughts. So thoughts are coming from the mind. You can ask me where is the mind, but this 10 minutes is not enough for me to tell you what is mind and where is mind. So we start analyzing, we start looking at the thoughts, we analyze the thoughts, we sort of dissect it, perpetuate it, and then thoughts give rise to actions. So we are acting now. And a group of orchestrated actions define what we call as behavior. And to behavior we add emotions. Then again we go back to sleep. So you are aware, you are awake, you are aware, then you are cognizant, then you act, then you behave, then you emote. And then again you go to sleep. So in this stream, today I will just talk to you about the mind. That too in very shortly. So if you look at the mind, the most acceptable, or which I accept the most model of brain functioning is that given by Daniel Kahneman, who is a Nobel laureate. He has told that brain has two streams of functioning. One is what we call as a conscious mind or the Bodha Manas. The other is what we call as a non-conscious mind. So the conscious mind is available for introspection. You know what is happening in your conscious mind and you can control it. It's within your control. But if you look, this is in the manual pilot mode. But if you look at the non-conscious mind, which is the intuitive mind, or otherwise called as the Ridham Parabuddhi, or it's called the Andarjnanam, Andhakaranam, Manasakshi, whatever you call it, it's a non-conscious mind. So the non-conscious mind is not available for introspection. We have no idea what is happening there. It's a black box. And it was a great revelation for me to know that some 80% of the time you function in the non-conscious intuitive mode. As I am speaking to you, the words that spill out of my mouth, my gestures, everything is coming from the automatic pilot mode or from my intuitive mind. Here I will quote from Albert Einstein. Albert Einstein told that the intuitive mind is a sacred gift, but the conscious mind is a faithful servant. Unfortunately, we have created a society that respects the faithful servant and neglects the sacred gift. So that is what has happened to the society now. Now let us look at the constituents of the intuitive mind. The basal layer is formed by life values like compassion, empathy, gratitude, sharing. And above that is your domain-specific knowledge. And above that is the contextual knowledge. This is an oversimplification, but it's very good for understanding. So what we have to concentrate is at the basal layer. Then we have been hearing talks about the IQ, EQ, emotional resilience, and all those things. We have tools to sort of train children to be high in EQ as well as IQ. But we should have programs to nurture the basal layer of the intuitive mind. So I told that it's a black box. Then how to get into the intuitive mind? That's a big challenge. So now I have to talk about the habits. What's a habit? Habit has a cue. It has got a routine which will end up in a reward or a punishment. So let me quote an example. Suppose around 10 o'clock, you feel like having coffee. That is the cue. Then you walk up to the coffee shop. That is a routine. And there you sit with your friends and you sip your coffee, chatting. That is a reward. And we are all a bundle of habits. So if you want to instill a good habit, then you have to do it in the critical period of brain development. So there you have to have intuitive mind development tools, which is my interest now. And I have two students doing PhD on this project. But it is not that easy to develop a tool by which you can enter the intuitive mind. It is more difficult to assess the intuitive mind. But once it is done, it is going to stay for life. So whatever you put in the intuitive mind will stay for life. So that is why you have to start this process during the critical period of brain development. So I have got some tools by which we may be able to do this, but I feel that it is a neuro-divine process by which you can culture or nurture a new generation who has good life values. Amma always says that education should be for life. And I think because RKK and his team has an up and running machinery to look at the neurodevelopmental aspects of children who have undergone cardiac surgery, I suggest that you extend this to other children also. And you concentrate on the intuitive mind, because that is what makes you as a person. It is not the cognitive or the conscious mind. The entire problem in the world is because of the conscious mind. Because God has left some 15 or 20% of your mind functioning to yourself, and we make a mess out of that. Look at the autonomic nervous system, which is controlling your vitals. It is not at your decision level. It is a divine software. So if you leave your control of the heart rate and the oxygen saturation to yourself, you will totally collapse it. So that is why I call it a divine software. So I just suggest that we are in the process of developing tools to develop the intuitive mind with the concept that you can instill these good life values. And we are also working on aspects of how to assess this black box. So I think we should join hands and go forward so that this will complement your work on developing the emotional quotient, emotional resilience, and all those things in children, but it will also help you to nurture a clean, serene, accepting, divine, intuitive mind. Thank you.
As always, Anand Kumar sir speaks and some things go above our head, but we understood half of that, sir. Okay, message from Molly ma'am.
A warm good afternoon to all of you, especially Dr. Krishna Kumar, Dr. Mandraj, the resource persons, I understand, national level, international level, as well as at the institutional level. Much has been said about the neurodevelopmental care. I just want to say only one point, especially to the nursing and other healthcare professional community. What I understand, the surgery is done, heart surgery is done. There are so many environmental factors which may really affect the cognitive functioning of the child later. And of course, the nurses and other people involved, we are very busy there in the intensive care unit. But how many of us really look into the noise part of it in the ICU? The light part of it, because all these can affect maybe later, because we are very busy with other functions, maybe busy with ventilator functions, so we just forget those things. So I wish that, these type of seminars definitely should include more of nurses, especially who are involved in this type of, care, post-operative care. And even the parents, they said, the 91% of the parents, they come back. That's something really good, but I don't think this is the situation in all the hospitals. So transition from discharge as such home, even from home to school, all these are, certain checkpoints we need to be definitely taken care of. So my earnest request to my all nursing people and other professionals is to see to maybe minor things, but it has got, so much impact on the cognitive functioning. So that's all I have to say. Thank you for inviting me for this inaugurative function. Namah Shivaya.
Message from Rehna ji.
Om Amriteshwari Namaha. I take this opportunity to thank and congratulate Dr. Anraj and Dr. RKK, sir. We had been working with Dr. RKK from the last 28 years. And, I was just thinking how we have begun in 1998, just with a pediatric cardiac program. Now, where we have reached, I was just analyzing, sitting there. And it was a highly emotional moment when those parents were talking. I know that all of us became emotional. And, may Amma bless this program to go ahead very well. All the very best. Namah Shivaya.
We are sorry for the lunch being delayed, but all of you please have the lunch and come back because we have slightly delayed, but I think we can have a quick lunch and come back. Please be back in 30 minutes. Thank you. 40 minutes. 40 minutes. I mean, that will happen, but we'll see. Thank you.
and ready for the next part of our session. So we now move into a very important phase of the child's journey, one that most families navigate every single day. This next session focuses on the child in school, learning, inclusion, and educational pathways. Because development does not happen in isolation. It unfolds in classrooms, in interactions with teachers and peers, and in the expectations that the world begins to place in the build. And for children with congenital heart disease, this phase often comes with its own unique set of challenges. This session will be presented as a continuous discussion across 2 sessions. We will first understand the challenges which children with CHD face in school, and then move on to how we can support them through structured academic planning and accommodations. We will take questions and interactions after both sessions are completed so that we can have a more integrated discussion, okay? So to begin with, we have with us Dr. Deepa Bhaskaran. Dr. Deepa Bhaskaran is the Director in charge of the Child Development Center, Trivandrum, one of the pioneering centers in India for child development and early intervention. She is a developmental pediatrician with extensive experience in the field of child development, working closely with children and a wide range of neurodevelopmental conditions. Her work spans clinical care, research, and large-scale developmental programs, and she has been actively involved in areas such as autism, early identification, developmental assess, and early intervention. She has contributed to several research publications and has been part of important work in developing and validating tools and approaches for early developmental screening and intervention, which are widely used in clinical and community settings. Being part of the Child Developmental Center, she has also been closely associated with building structured, scalable models of development care, bridging hospital-based services with community and school systems. Today, she will help us understand school and CHD, educational pathways and challenges, bringing together developmental science and real-world educational needs. Following this, we will have Ms. Bindu Nair. Ms. Bindu Nair is an assistant professor and clinical psychologist, Department of Clinical Psychology, AMRITA Hospital, Kochi, with over a decade of experience working with children, particularly in the area of pediatric psychology and learning needs. She has completed her training at NIMHANS and brings with her strong expertise in psychological assessments, especially in understanding learning profiles and identifying specific learning difficulties. Over the years, she has worked closely with children, families, and schools, helping translate assessment findings into meaningful academic planning and support. Her work also involves guiding families through educational provisions, exemptions, and accommodations within the academic system. Today, she will help us understand how to move from identifying challenges to building structured and supporting academic pathways. I welcome.
ഏതാണ് സ്ലൈഡ് മാറ്റണമെങ്കിലോ പോയിന്റ്
Good afternoon, everybody. At the outset, thank you for letting CDC be a part of this conference. And I have to say that it is extremely heartwarming to see cardiologists as a group wanting to go beyond just the survival of a child into an area of quality survival, and where they are really and truly keen as to ensure a quality survival to the child in terms of neurodevelopment. It's extremely heartwarming to see the endeavor that is being taken by AMRITA. So with that, I'll go on to the first slide. Now, why are we, actually there is an interconnection between the brain and the heart development. We know that during the fetal period, structurally the brain and the heart develop almost at the same time, but we know that synaptogenesis, synaptic myelination, all those things are ongoing process. Even though structurally they may form at the same time, why I'm saying is that if an insult occurs, it could be a genetic insult or an antenatal insult, structural anomalies can be there because they both kind of develop at the same time. But the brain is actually refining, the continuous process of refinement of brain development, actually it goes on. And as the previous speaker has mentioned, even in adolescence, actually the prefrontal cortex is still in a phase of developing. And we have all heard about the concept of synaptic pruning, synaptogenesis. As age advances, more pruning happens. But in these young children, we have always heard that tracks which are fired continuously will become very, very strong. That is the basic principle of neuroplasticity, which you are all kind of trying to work on. This has all been discussed, the impact of congenital heart disease and all that, so I won't dwell there. Now, there are studies which show that certain heart cardiac defects, even in a term baby, their brain development may be that of a late preterm. The brain development may be only as much as even a 36-week preterm baby. And this also has been said in the previous slides. Up to 50% of survivors can experience some kind of an impaired neurodevelopmental outcome, can develop. It's not that all of them can, but up to 50% of them may have subtle differences in neurodevelopment. Now, what I was asked to talk about is why do they give the impression of presenting late? It is not actually presenting late. If we really look into it, in a very small child, a child who is only 2 or 3 years, what is he actually learning to do first? He actually identifies the symbols. When he sees A, he just learns to identify, this is A. D, he learns to identify it as D. That's all he's doing there. So the cognitive load is not too much over there. Then what happens? As he goes on to the 6th or the 7th, when he becomes 6 or 7 years, he's in the first standard, what does he have to do? He has to put together these letters. There he is actually learning to read. വായിക്കാൻ പഠിക്കുകയാണ് അല്ലാണ്ട് മനസ്സിലാക്കാൻ വേണ്ടി പഠിക്കുന്നത്. He is just mechanically reading. He is just putting together words, putting together letters and forming words. But he does not understand, or he may not be understanding what he is reading. I'm just trying to put across to you the complexity of the cognitive complexity that comes as the child grows older. What happens when he becomes around 8 to 10 years of age? There, he not only has to read, but he has to decode what he is reading. He has to understand what he is reading. So many complex processes are happening there. What happens when he becomes 11 to 14 or 15 to 18 years? Maths becomes extremely complex there. Simple addition, subtraction, beyond that, multiplication, division, fractions. So the cognitive load actually increases as the child grows older. That is why the poor school performance or the intellectual challenges appear as the child grows older. Even though his potential is the same, it becomes more apparent as the child grows older. Now, previously, it was mentioned about you can see the IQ. Look at the range of IQ. Anything less than 7 we call as intellectual disability. But above that also, as the previous speaker spoke about, very superior, high average. With our curriculum, children have to have at least an average or a high average intelligence really to cope up with the syllabus that we have. So most of our children who have chronic illnesses have IQs which are between 70 and 85. Do they fall in the normal range? Yes, it is the normal range. But they are called as slow learners. They have to put in more effort than a child with a normal average IQ to perform. But the saddest part of it is that only if the child has an IQ less than 70 is he fit for getting a disability certificate. So do these children have any advantage or additional benefit from school? The answer is no. But most of our children with poor school performance fall in the range of 70 to 85 IQ, for whom actually, as of now, there are no additional concessions that we can give them, like we would give for a child who has an IQ below 70. So even though we say that the IQ is within normal range, this IQ could be in the lower range of normal, which would again put the child into academic difficulties. Now, this is a major area called neurocognition. As the previous speaker had mentioned, it is not IQ alone, it is neurocognition that is very, very important in these children. And neurocognition is actually defined as, it is a multi-dimensional process ensuring effective response to the environmental stimuli. And childhood is a very, very important period for neurocognitive development. And maximal development, it is developing very swiftly before 9 or 10 years of age. And actually, initially, as we all know, our motor cortex and the sensory cortex develop. Then the temporal area develops. Temporal area is where we learn to speak. Then we have the parietal area which is developing. Parietal area is which gives us a spatial orientation. Spatial orientation meaning, for things which we take for granted. The phone is on the table, the phone is under the table, the phone is behind the table, in front, which all comes very easily to us. But in a child, Sir was previously mentioning about cerebral visual impairment. In a child who has a cerebral visual impairment, this parietal development is actually affected. So he has no orientation about where an object is. He may know what the object is, but he doesn't know where the object is. So these are all very, very important when you come to academics, right? So this is a crowded slide, but I just want you to know, the previous speaker spoke about executive function, which is the very, very most important neurocognitive function is executive function. Then we have attention. Attention is the ability to focus on the specific stimulus. Even if it is in a crowded or a noisy class, the child should be able to focus his attention on the teacher. Then visuospatial perception, that is eye-hand coordination. He's seeing the board, whatever the teacher is writing, he has to see. At the same time, he has to write. That is something which we take for granted, but a lot of coordination is going there. Whatever he's seeing visually, he has to process and he has to write. So most of the children who have poor school performance, their parents come and tell us, he doesn't complete the notes. It's not because he is lazy. He has poor visual coordination. He is not able to coordinate. Processing speed. Processing speed is where I say something, you immediately catch it. But a child who has got a poor processing speed will take time to process the information. So when he is being bombarded with information in the class, even before he has processed one information, the next information is being fed to him. So the other thing is memory. As we all know, working memory was talked about. Then social perception, understanding and interpreting social cues. These are all actually higher order neurocognitive functions. Language processing. Previous speaker said, receptive. Which speech do you think develops early? Receptive or expressive? Children learn to understand first, right? And then they start to speak. So all these areas are actually neurocognitive functions which can be affected in our children with congenital heart disease. Now, I would just go a little bit into the detail of executive function. There are 3 executive functions are actually activity, it's a goal-oriented action. If I want to throw a ball from here to a person over there, I need to understand what is the force that I should use, what is the trajectory that I use. I have to throw it like this, right? I cannot just throw it like this. So all that planning is actually being carried out by the executive functions of the brain, which is actually impaired in these children. There are 3 main components of executive function: your working memory, your inhibitory control, and your cognitive flexibility. What exactly is working memory? Now, I am presuming that all of you would be remembering the previous sentence that I said, right? I hope none of you are sleeping. But if you have a good working memory, you will recall what I said in the previous slide as well. For that, we have to have a good working memory. Working memory, supposing he is reading a passage, unless and until he remembers the first line, he is not going to remember the last line. Okay? So working memory is very, very important. Cognitive flexibility. There will be different ways in which the same problem can be solved. But children who do not have cognitive flexibility will not be able to shift their mind from one thing to another. The last is inhibitory control. Inhibitory control meaning what I said, even if we are in a crowded room, if you carefully observe, there are multiple noises that are going around. But if we have good inhibitory control, we'll be able to filter out all that and listen to what is relevant. Okay, so these 3 are the very, very important things of executive function. Now, as previously said, the primary area is the prefrontal cortex, the area here, but it has got a lot of connection with the sensory motor cortex, the amygdala. It is an extremely complex network that is happening there. And these are the areas, these are the pathways that can be affected in the children with executive function defects. Now, it is a short-term capacity to hold and manipulate information, we said. When does it mature? It actually matures through childhood into adolescence. It peaks in early 30s, and it actually after 35, the working memory actually comes down. Now, inhibitory control, as I've said earlier, is the ability to inhibit his impulses and concentrate on what is very, very important. It begins in infancy, it peaks in early childhood, and it actually declines around the age of 60 years. These are all executive function. Cognitive flexibility, also I said, learning grammar exceptions. Like most of the past tense you say, just add an E, right? Like would be liked. But what about say? Said. So it's a different rule. So only if he has cognitive flexibility can he shift from write. Write would be what? Wrote. It's not righted, right? So there are exceptions to every rule which will be very difficult for a child who does not have good cognitive flexibility. So it starts at age 3. Some experts say it's completed by age 12. Some say it actually continues till around 29 years of age. Now, how do these children who have poor executive function, how do they actually present? They present with problems of paying attention, emotional regulation, completing tasks, communicating their wants and needs verbally. So if you can look at it, these are all features of ADHD. So the children with poor executive function will actually present to us as cases of ADHD. They will be unable to control their impulses, they cannot wait for their turn, they cannot focus on their task, they cannot remember instructions. Can executive function be trained? Yes, it can be trained. How do we train them? Having a very good language, giving them the ability to communicate what is happening with them or what is their issue, being able to put it across to another person. Most of the behavioral issues happen because they are not able to verbalize their distress. So they throw a tantrum. So making sure that the child has got a very good language base can help a lot in establishing good executive functions. The next is emotional regulation, as was spoken earlier. Structured play. Play is the most important activity of any child, right? Play is their natural habit. Unstructured play is where they just create their own, but they become very, very imaginative when they are allowed to play in an unstructured way, right? Structured play is where they have to follow rules. It would be like putting together jigsaw puzzle or looking at a picture and making Lego constructions. Lego, their toys are there, right? So those are all examples of structured play. So as helping them to have a good language, helping them to emotionally regulate. Emotional regulation is a very complex topic where even you may even have to teach the child how to recognize emotions. Showing him an angry face. When you are like this, what do you feel? Showing him a smiley face and telling him, what is this? What do you feel when you are like this? So you may have to start from a point of actually learning to recognize their own emotions. And the third one is through structured play. You can actually improve the executive functions of the child. The second important neurocognitive function is attention. There are different types of attention. Sustained attention is where you have to sustain your attention at a particular thing for some time. Selective, as I said earlier, removing all the distractions and concentrating on what you need to concentrate. Alternating is shifting attention from one thing to another. Divided attention is supposedly what most women do, multitasking, right? You will be dividing your attention to multiple tasks at the same time. Now, this is roughly, what is the attention span of a child? Roughly, it's around 2 to 3 minutes per year. This is just what should I say? It's not like it is a strict hard and fast rule, but roughly, if you have a 2-year-old child, the attention span may be a maximum around 6 minutes. What I'm trying to say is that if you have an ADHD child who's around 6 years of age, his maximum attention span or sitting tolerance would be around 12 minutes or 15 minutes at the most. So if you try to make him sit in the first session itself for half an hour, he's not going to be able to sit. So we need to know what is the limit of attention span at each age. Now, these are some of the key strategies to improve attention. What can you do? Environmental adjustments. What do we say? In a child with poor attention, what do we tell the mother to do? Put his study table in a corner. Not near the window, away from the window, so there are no distractions. Don't put any calendar or anything on the wall. ask him, if he is coming to study, ask him to bring only the math book first or the English book first. Don't ask him to bring all the books together because he gets distracted. So by changing the environment, you can improve the attention span of the child. Task management, breaking the task into smaller bits. Instead of giving him a big task to do, if you tell him, break it down into smaller tasks, he'll complete it faster. Nutritional support, as was mentioned earlier, a hungry child is not going to have attention. A tired child is not going to have attention. So make sure that the child is happy, he has had his food, and he's not tired. Then active learning movement. Give him movement breaks in between. Teachers are not amenable to this, but after 10 minutes, as I said earlier, his sitting tolerance is done. You give him a break. At least creative ways of doing it is go rub the board. He gets up from his seat and he moves around. Go distribute the books. He gets a chance to move around. So give him a movement break. He'll come back fresh. So give him movement breaks in between. Routine. A routine is very, very important. If you give him, some others do come and say, for everything he has to be pushed. If you try to give him a visual schedule, you get up in the morning. The first thing that you do is there's a picture of brushing his teeth. The next thing would be taking a bath. The next picture would be putting on his uniform. Fourth would be putting his books together. Give him a visual structure which he can follow. That might help. Instruction clarity. Instead of saying, go clean your room, that is a very broad statement. First you arrange your books. Then you fold your clothes. Then you make your bed. So always give very clear instructions with minimum jargon. With minimum sentences, give your instruction because he will not be able to understand if you put in a lot of words. Long-term methods would be mindfulness, music, especially Carnatic music is supposed to be very good because it really and truly enhances neuronal connections. So learning music or learning a musical instrument, chess, all those things are very, very helpful in sustaining his attention. Positive reinforcement. Always. When the child behaves well, take a minute to appreciate him. It might be a little thing, whatever it is, just give him a hug. Tell him that he has been a good boy. That really, really and truly makes a huge lot of difference. Don't take anything for granted. Even if it is a little improvement, always praise the child. Visual construction is a very, like I said, for reading, writing, spatial reasoning, you need visual construction. Visual perception is, if I show him a picture of an apple, he should be able to say that it is an apple. He has to understand it is an apple. How does he say it is an apple? He should be able to recall from his memory that it is an apple. Spatial, like I said earlier, under, in, behind, in front. Figure ground is very, very important. That is, if you have a cluttered picture, from that picture, you ask him, you have seen pictures for, activity books for children, right? It would be a maze. There will be bunnies or something hidden in between. And from that crowd of images, he has to pick out the bunnies. So that is actually figure ground discrimination. From the mess, he has to pick out items from there. Then visual motor integration, we said, like writing. Visual closure is, if I show a picture of an elephant, if I just show him the trunk alone, or the tusk alone, he should be able to say it is an elephant, even without seeing the entire picture. Okay, so these are all some of the things which come in visual construction and perception. Now, as we all know, as it's very, very clear, if the child has a very poor visual performance, he will not do very good in studies. So how can we actually, what are the features? Like our LD, he will have BD reversal, PQ reversal, 6 and 9 would be reversed. He will leave huge gaps between the lines, or he will not be able to write within that 4 line. They have 4 lines, right? They'll be either writing it very huge or they'll be writing it very small. They don't know how to leave a margin. So these are all features which should make you understand that the child could be having visual perception problems. Some children read, they have to keep their hand there, their finger there. The minute they take the hand off, if you ask him to read again, he has lost the line. So those are all things, cues that actually tell you that the visual perception is at fault there. How can you improve? Again, jigsaw puzzles, pattern making, Memory games. Previously and all, they have, fun school and all used to have cards where you have the name of the object and the picture. So you put them all down, he picks up a card, and then he has to remember where the picture is. So simple games like that will help a long way in improving his visual perception and memory. The last one would be the processing speed, which I said earlier. In autistic children, if you ask them a question, they tend to repeat the question back. One of the reasons they say is he has got very poor processing speed, so he's actually repeating the question to himself so that he can process what is being asked. And we tend to label it as echolalia. There he's actually using his echolalia to buy him some time to process whatever you are saying. This processing speed becomes very important as the child goes into adolescence. What happens in adolescence? Not only does the language become very complex, there is a lot of sarcasm, lot of picking on each other. So by the time he has processed one thing, the next comment has already been made. So will he fit into that group? He will not, because he will be labeled as a duller, because he's not able to pick the nuances very fast. So this I have said earlier. What are the signs of slow processing speed? Getting overwhelmed by too much information, needing more time, frequently missing social cues. These are all some features which may show that the child has poor processing speed. Now, my last, this would be, how can we help these children? That, of course, the next speaker would be talking about. Giving them more time, which our schools are unfortunately not willing to give them more time, but that's the only way we can do it. Instead of teaching them the entire lesson, give them a summary. Instead of essays, permit them to write short questions or bullet points. Repeat instructions. And keep on, the teacher has to repeat the instruction again and again for him to really understand and focus on it. Give grades for knowledge, not for writing. If he's verbally able to answer questions, give him credit for that. Don't insist that he has to write. Encourage overlearning. Overlearning is where you make it as concise and short as possible. You make him learn it again and again and again. Repeated memory will help it go into, repeated reading will help it go into the long-term memory. Assignments, if he is finding it difficult to write, let him complete his assignment on a computer. Shorten the assignments, one question at a time. Minimize background noise at school. But all this is easier said than done. We need a lot of cooperation from the schools to make this happen. These are my references. And thank you all of you from CDC. And one request to you would be, why do we have to wait for a child to come to us with a learning problem or scholastic problems? Would it be possible for AMRITA to create an early stimulation project or an early stimulation program for all your children following congenital heart disease? You don't have to wait for the child to come back to you with a, we know there are multiple studies showing that these are the problems in these children. What more evidence do we need? So we can always start, we are not going to do more harm by giving the child early stimulation, absolutely not. From the beginning toddler itself, teach them how to have good executive functions, teach them how to have memory, teach them how to have good visual perception. If your manpower resources limited, try to have group sessions. That's what we are trying everywhere. Children with the same functional level or same chronological age can be put together. All these tasks can be taught to them, and the mother is the primary caregiver. The mother or the caretaker is taught all these things, and they can be very, very creative. You'd give them one activity, like the bunny thing that I said earlier. Next time she comes to you, she would have 5 papers with her in which she has created a collage for the boy to pick out the things. So use the mother as the primary instructor and teach them, and that would go a long way in helping these children. Thank you once again.
Thank you so much, ma'am. A lot of it that you mentioned today, we're actually working on this in our unit as well. Also psychoeducating parents on doing so much. Thank you so much. Before we have Bindu ma'am on the stage, we'll have one small mentee poll. Learning difficulties usually in CHT are usually seen in, a little bit of grammar gone wrong there. Learning difficulties in CHT are usually seen in only severe or complex CHT, only mild CHT, both complex and mild CHT, not related to CHT. I think by now we have this answer. Our knowledge is getting more accurate as the day goes by. Excellent. Without doubt, we know that both complex and mild CHD could be at the risk of neurodevelopmental disorders. So I think we are on point with our seminar. Let's move on. We'll have Bindu ma'am on the stage.
Good afternoon all. First of all, I would like to express my gratitude to Department of Pediatric Cardiology for inviting me for such an enriching program. And my part of the seminar is like learning disorders and school accommodation of these children who is having CHD. So, as we know, congenital heart disease affects up to 1.3 million of newborn each year globally. So we can understand how important it is. So what happens as the survival rate increases, the neurodevelopmental outcome is also becoming more apparent. And it is also associated with the quality of life in the survivors, because they'll be having this kind of cognitive deficits and physical ailments also. So these impairments, neurocognitive impairments, persist throughout the lifespan and have the most significant long-term impact on the quality of life. Now, how a person is having all these problems, the patient outcome, how it is developed, like from the genetic factors along with placental pathology, which contributes to MRI brain abnormalities. Also, the hypoxia and ischemia, along with that, maternal stress. All these are contributory factors in developing impairments in working memory, social functioning, language, attention, executive function. So the deficits in motor functioning, then cognition, and the behavior also. So there is an increased likelihood of autism, ADHD in this children. And also a long-term effect is like reduced employment rates, and also educational attainment and quality of life. Also, there is a need for increased social support for these children. So what can we do for them to support them? So these are the neurodevelopmental disorders are the major complication of a child who is having CHD. So during school age, they may be exhibiting cognitive deficits, motor, linguistic, social, and psychological impairments that significantly affects the academic performance, self-care abilities, and quality of life. Also, their adaptation to the social situation. So, these difficulties may not be directly linked to the intelligence of the children. It could be also due to attention difficulties or executive function difficulty, reduced stamina or fatigue. We know that this surgery, it's a long process. After that, they'll be having their physical fatigueness and reduced stamina. Also, the interrupted visits to schools due to hospital visit. So they'll be losing classes due to constant follow-up in the hospital setting. So as the previous speaker have mentioned, executive functions have been affected first. The vulnerabilities will be in planning, organizing, working memory, sustained attention, and task completion. They won't be able to complete a task. So what are the classroom manifestation of these children? How they behave in the classroom? They'll be having a very slow work space. So he'll be slow compared to other children. And also easily fatigued. So researchers have shown that these children who's having CHD will be more fatigued during the academic tasks. And also, when you give them a multi-step task, they'll be having difficulty in completing that also. So this will end up in an inconsistent academic performance. Now, the child will be taken to the hospital frequently, and how it affects us, what is the impact of this to the child. Children often miss school due to medical checkups, surgeries, hospitalization, fatigue-related rest and all. So they can't follow up what the teacher have taught in the previous classes and all. They miss examinations, they miss projects and all. So that could be another reason for the academic failure. Then there will be a gap in foundational learning. So we know that in the early stage when this is diagnosed, so in the foundation period when learning happens, the child will be having a gap in his knowledge. Also, the child will have difficulty in catching up the class space. The class will move fast, but the child can't reach that point, like to acquire knowledge. Okay. Then this results in anxiety regarding about school performance. So he'll be avoiding classes. He hesitates to go to class because there will be a lot of missed classes, which in turn reduces their self-confidence. Okay. Now, there are some red flags in school which teachers can easily find out. These children tend to have poor writing speed and poor organizing capacity, frequent incomplete work, poor concentration, and academic decline. Then now, as I told you, the academic decline could not be due to the intellectual disability or any other concerns. How can we differentiate it from a learning problem? Okay, so there is a neurodevelopmental condition called specific learning disability, which is characterized by the child will not be able to follow the grade that he is in. Suppose the child is in 3rd standard. He won't be able to do or perform well in the 3rd standard level. Also, 2 grades below that. Okay? So 2 grades below that means 1st standard. The child won't be even able to perform well at the 1st standard level. Then we can diagnose the child as having specific learning disorder. So this we can diagnose only when the child is having an average intellectual ability. So first of all, we need to rule out the learning problem is not due to intellectual disability. So we used to do IQ evaluation first, then we will assess the child for specific learning disability. Okay? And the child should have an equal opportunity to go to school. Despite that fact, the child is having still the problem, then only we can diagnose it as specific learning disability. So there are different types of learning disability: dyslexia, dysgraphia, and dyscalculia. Dyslexia means inability to read. Okay, so the child won't be able to read the study materials. Then dysgraphia is the inability to write or draw things. Then dyscalculia. Dyscalculia means inability to do mathematical operations up to his grade level. Okay, so in short, there will be discrepancy between the ability of the child and the achievement of the child. So that is the learning disability. Now, there are executive function deficits, as we discussed earlier. There will be, working memory deficits, cognitive flexibility, then inhibitory control, then planning and organization deficits in majority of these areas. Okay. Then another condition is academic decline due to medical condition. So there will be a serious medical or neurological condition. This particular condition will happen only when there is an onset of an illness. The problem will start only after the onset of illness, and prior to that, the child will be performing well. So now we'll move on to the evaluation. How can we evaluate a child for specific learning disability and intellectual disability? Usually, for young children, we use Vineland Social Maturity Scale, Bailey test and all. So from 3 years and above, we use Binet-Kamath test of intelligence and Wechsler intelligence scale for children and Malin's intelligence scale for children. So these are the commonly used IQ tests that we used to do to rule out intellectual disability for the children who is having academic decline. Then comes the learning disability assessment. Learning disability assessment we used to do only after evaluating his IQ. Only when IQ is above 90, we'll do learning disability evaluation for the child. For that, we use the tools like GLAD and NIMHANS index for specific learning disability. So now, if you have a child, CHD child having this kind of disabilities, what we can do for them? So we'll discuss about the academic accommodation, what we can do. So the instruction should be modified according to the need of the child. So first thing is instructional modification, then breaking the task into smaller and manageable steps. So the child cannot be bombarded with a lot of informations. So the information should be given in a simplest form, small steps. Then we can always provide written instruction to the child if there is any difficulty in comprehending verbal instructions. Then use repetition and reinforcement, which is very important. Earlier, ma'am was discussing about the importance of reinforcement. When the child does anything which is desirable, you have to appreciate that. You have to reward that particular behavior so that that behavior get repeated. Okay? Then use of visual aids. Help the child to see the abstractness of the concept that you are giving. So use visual aids, then provide extra time during examinations, because as we mentioned, these children will have slowness in writing. So for that, the child need more time. So that can be provided. Then reduce workload. Like the school authorities will give lot of homework, classwork, projects, seminars and all. So for these children, the workload can be reduced. Now, some health-based accommodation can also be considered for these children, like scheduled rest breaks. So continuously sitting for 8 or 6 hours in the classroom, they can be shifted to a room where they can take a rest for a while. Also, the timetable should be flexible for them. Okay, so some children may have difficulty in math or science. So the timetable should be flexible for them. Then seating near the ventilation or near the teacher, which help them, feel more relaxed in the classroom, because they know that they have a deficit and they are not able to perform or achieve well in the classroom. So that stress should be managed appropriately. Then avoid physically exhausting tasks. Then relaxed attendance requirements. So some schools will be very strenuous in or very strict in the attendance of the children. So these children will have medical complication. They have to visit the doctors. So they have to given relaxation in the attendance. Then homework flexibility. As I mentioned, the homework should be given lightly for these children. The next is psychosocial support, as and when it is needed, because these children will be having, anxious in nature or any other conflicts in them. So we can always provide counseling support in the school and encourage peer inclusion, because most of the school, what happens if a child is sick, he'll be isolated. He'll be seated separately and he'll be isolated in a corner. So what happens, this will in turn decreases the self-confidence of the child. So peer inclusion is very important. He has to mingle with other children also. Then address the anxiety. If the child is having any anxiousness about his health or academic related or any other psychosocial aspect, to provide that. Then also avoid overprotection from the part of school teachers and parents. Now, certification. Will these children get any benefits or any certificates from the government? So these certification has been done by Rights of Person with Disability Act. It's a government body which issues this certificate for intellectual disability, then specific learning disability. So unfortunately for CHD alone, there is no benchmark disability. The RPWD Act has 14 disabilities mentioned in their gazette, but CHD is not included yet. So what can be done is, these children can be certified under chronic neurological or medical condition. If they have any other, say, physically handicapped, or if they have specific learning disorder, or if they have intellectual disability, or if they have multiple disabilities, definitely they will get a certificate from the government and they will get benefits also. Now we'll move on to the documentation. The importance of documentation we'll discuss now. So the documentation has to be done in 3 major areas: psychological, medical, and educational. Because when a child is diagnosed as having CHD, as the previous sessions, Madam has mentioned, you are walking with the child throughout his life. So all the files and assessment, evaluation, everything is very important. We have to keep it safe throughout the treatment process. So for that, the psychological document, it acts as a bridge between the assessment and action. Okay? It clarifies the nature of the problem. If the child is having specific learning disability or executive function difficulty, so the evaluation report will explain what is the nature of the problem and identified what exactly is affected, which area is affected. Then it also provides objective evidence based on standardized tests and clinical observation. What all assessment the psychologists have done, like the intellectual ability test or SLD test, or any other interpersonal relationship or anxiety assessment, or whatever assessment have been done, it has to be documented properly with a proper report. Okay? Then it guides to the individualized intervention of the child. So, and also it plays a key role in certification. It is, depending upon the psychologist's report, the certification has to be done, like the IQ. If there is intellectual disability, it has to be presented in the disability board. So the other faculty members in the disability board will sign that certificate. Then medical documentation. This is the foundation that legitimizes the child's health condition, and it's of functional impact. So it establishes the diagnosis, we know that, then explain functional limitation of the child, support also school accommodation, then help in academic planning of the child. Then educational documentation from the class teachers. This could be in the form of report cards and grades of the child, then teachers' observation, attendance, classwork, homework notebooks, exam paper, individualized education plan, if any. If the child is having any individualized education plan, that also has to be kept properly. Then prepare for possible complication after surgery. Track the progress over time, then support differential diagnosis like SLD. Okay, now we'll move on to the other psychosocial aspects which help the children with CHD, that is empowering the parents, teachers and significant others. For this, parents and teachers plays an important role for the total well-being of the child. So empowering the parents, we need to give them basic education about the diagnosis and the treatment options. They should be aware of what is happening to their child. Then preparation for hospital admission and surgical course. Then communicate that balances seriousness and hope. Prepare for possible complication after surgery. Then information about peer-to-peer and other social supports. Then information about financial support. Then preparation for long-term day-to-day challenges. Then a tailored education and support have to be provided. Then guidance towards reputable online resources for educational needs. Preparation for emotional impact of CHD. So by giving all these information, the parents could effectively handle the child who's having CHD. Then empowering teachers, they are the frontline implementers to support the child. Then educate them about the condition, provide ready-to-use classroom strategies, help the teachers to recognize the red flag signs in this classroom, encourage flexible classroom practices, strengthen the teacher-parent communication, and provide institutional support for the teachers who is handling these children. So to conclude, children with CHD present with unique profile of academic difficulty, vulnerability. So comprehensive assessment, integrated documentation, and collaborative intervention help the children to navigate their difficulties in their lifetime. So the main stakeholders are the cardiologists, psychologists, teachers, parents, and also the significant others in the society. With that, I'll wind up. Thank you.
Quick questions, anyone? We are running short of time. Quick. Make it quick.
Hello, ma'am. I'm Deepika. My question to you is, since we are talking about the integration of children in schools, so with regards to children who are younger, who are just diagnosed above 6, how can we build resilience in them? Because the peers' environment is not as sensitive in younger children as it is in the older children. So how can we plan resilience, to build resilience in the children?
Yeah, see, resilience is a long-standing process. We cannot inculcate resilience as such in a 6-year-old child. It should be adapted over the period of life. So we provide them, play materials, information regarding, handling things, positive way of doing things, and adaptive behavior modification, and also through that only we can build up. Gradually, we'll build up resilience.
Won't they have self-esteem issues if the resilience issues are going on for a long time? Since the personality is just building at
Yeah,
6.
definitely they will have. But the thing is, in the sessions, we have to focus more on the positiveness aspects of the child. So for the young children, play sessions will work. Okay.
Thank you.
Yeah.
Good afternoon, ma'am. My name is Hina. Ma'am, what suggestions do you have for education professionals and teachers, especially in terms of raising these children in school? Because the children are coming to psychologists and doctors in a way after some time for follow-up, but they are spending more time in school. So, any recommendations or suggestions you have for them?
Yeah, definitely. There should be, in schools, we have started already, this is in case of other disabilities, some what they call resource classes they undergo. So awareness programs like all kind of disabilities and vulnerabilities of children have been discussed in the sessions.
Thanks.
It's already started.
Okay, thank you, ma'am.
The questions are also directed towards Deepa ma'am. So if anybody has questions for her as well, you could.
So my name is Radhika. I am working as audiologist here. So ma'am, we talked about learning disability over here. Okay. Learning disability and auditory processing deficits, they coexist. And it is difficult to differentially diagnose children with central auditory processing disorder and learning disability. There are children who have no dyscalculia, but because they are unable to understand, for example, if I say I bought 5 apples, I gave 2 to my friend, what is the remaining? Because they are just not able to understand the language and they have auditory processing disorders, they won't be able to solve these mathematical problems. So here what we face is, till now in Kerala situation, we don't have a specific test for central auditory. Of course, we have hearing screening, etc. But there are children where there are normal hearing level, but they are having difficulty in processing this. And in ma'am's presentation also, there is no policy for children who are having congenital heart disease. Yeah. Similarly, for children with central auditory processing disorder also, there is no facilities given. Like they can perform poor academically, but there is no specific policy for like mark on basis of marks or special attention being given to them. So what can we, it must be made a part of the screening process itself. And
can I answer? What you correctly said is, a lot of children whom we label as specific learning disability, we are not actually specifically concentrating on auditory sensory processing disorder or even cerebral visual impairment. These are all things which we should actually look into, because are we really looking into, unless somebody has a research-oriented thing in mind, these children actually get missed, to be very frank. So they will be, are we including all these in our disability certificate? The answer is no. They get labeled as a child with a specific learning disability. But in them, unless and until the person who is giving intervention, maybe the special educator, when the conventional intervention that they give for a child with specific learning disability does not work in them, then maybe they may think of auditory processing disorder or a cerebral visual impairment in those children.
Thank you.
Yeah. And there is a part in this NIMHANS SLD index for evaluating auditory processing deficit. Okay. So auditory discrimination test is there. So from that we evaluate them for auditory processing deficits.
Does it have language aspects also? Like
no, not specifically for auditory
the
processing.
phonics thing is not
no,
there.
No.
Fine. Thank you.
All right, thank you so much. We don't have Any time left, isn't it? Okay, so we'll move on. Thank you so much, ma'am.
Thank you, Dr. Deepa Bhaskaran and Ms. Bindu Nair for those insightful sessions. Together, you've helped us understand not just the challenges children face in school, but also how we can support them through structured planning, accommodations, and informed educational pathways. What becomes clear is that development does not stop at diagnosis, and support cannot stop at identification. It has to continue consistently and meaningfully across stages. Because for children with neurodevelopmental challenges, especially in the context of congenital heart disease, care cannot be one-time effort. It has to evolve with the child, from early identification to intervention, to follow-up and into long-term developmental and functional outcomes. And this is where the idea of a care continuum becomes essential. Dr. Jagmeet Kaur Chawla is a developmental and adolescent pediatrician with extensive experience working at the intersection of child health, development, and long-term care. She holds qualifications in pediatrics, including MD Pediatrics and DCH, along with a postgraduate diploma in guidance and counseling, reflecting her strong integration of medical and developmental perspectives. She is also the founder and director of the Aadhaar Center for Counseling and Therapy, where she has been actively involved in building multidisciplinary services for children with developmental and neurodevelopmental conditions. Her clinical work spans a wide range of developmental needs, including autism, ADHD, learning difficulties, and other neurodevelopmental conditions, working closely with children and families across age groups. What stands out about her work is her focus on structured long-term developmental care, including school readiness programs, therapy integration, and supporting children into mainstream and educational environments. She brings a deeply practical perspective on how care must extend beyond diagnosis into sustained support across developmental stages. She is joining us from Mumbai today. She'll be speaking on care continuum in children with neurodevelopmental deficiencies, the CHD perspective, helping us understand how to build connected long-term care pathways for these children.
So my topic is care continuum in children with neurodevelopmental deficiencies, from survival to thriving. Before we start understanding what is a care continuum, let us understand what exactly is the brain and the heart connection. The brain and the heart connection starts very early. It starts prenatally. It does not start at the time of birth. It starts much before that. It is because in a compromised heart, you have chronic low oxygen. In a compromised heart, you will have, research shows you have delayed brain maturity. And this is not related to the prematurity part. The prematurity is about 1 month behind. MRI studies show cerebral dysmaturity. They show reduced brain volume, and white matter abnormalities. Add that to the genetic problems. So you have trisomy 21, you have Williams syndrome, you have a host of other syndromic problems or genetic problems which affect both the heart and the brain. Add on to that the natal part, the birth part, the perioperative stress, the acute hypoxia that the brain the child undergoes. And this increases metabolic demands on a compromised cardiovascular system. So all these add up. Then we come to the surgical part. These are hearts, these are problems which would have been absolutely non-survivable. But today we are seeing them do so very well. What are they? Tetralogy of Fallot, single ventricular physiology, a TGA, transposition of the great arteries, hypoplastic left heart, truncus arteriosus, total anomalous pulmonary venous return. These are surviving today. Why? Because of the surgical interventions that way. But these surgical interventions have a flip side. They also cause brain insults. So you have brain insults from cardiac surgery, which is cardiopulmonary bypass. You will have microemboli. You will have altered cerebral perfusion. Deep hypothermic circulatory arrest will give rise to an ischemic injury or a metabolic stress. White matter injury could give rise to a periventricular leukomalacia, the gliosis in the brain. Microhemorrhages, petechial bleeding, inflammatory response, the cytokine activation, perioperative hypoxia, and ischemia. To the developing brain, to the newborn brain, these are very, very big insults. A few of them may be visible on CT scan, MRI later on. A lot of them are not visible. But the problem, the insult has happened. So something or the other will happen. Now, what happens is you have a cumulative effect. Research shows that 25 to 50% of the CHD survivors that we have neurodevelopmental challenges. You have motor developments, fine motor skills, gross motor skills, language delays in both expressive and receptive language. You have cognitive changes like attention, executive functioning, learning, memory. 4.6 times autism is higher, 1.6 times ADHD is higher. 65% need support by adolescents. But there is a very flip side also. It is not inevitable. It is not necessary that this has to happen because we have a fantastic opportunity. And this opportunity is the neuroplasticity of the brain. A beautiful, beautiful regenerative possibility and the critical bit. So, what is this neuroplasticity? The brain's extraordinary ability to reorganize, to compensate, to learn, to adapt. The human brain is increasing at a phenomenal level. The synapses that are forming, the brain's volume is increasing. Everything in the brain is increasing fantastically. And what is this period? This period is the golden window, 0 to 3 years. Peak brain plasticity. By 3 years, 80% of the human brain, adult human brain is formed. And what is the early intervention which leads to giving us this period into the golden window? You intervene in the 0 to 3 years in the golden window, 70 to 80% reach age appropriate levels. Isn't this wonderful? Beautiful. I mean, just see the opportunity that we are getting. And late intervention after 5 years, only 30 to 40% catch up. Now, why is this very important? Because of what we are seeing in our clinic. Heartbreaking issues. Why? We see parents who have come out of absolute, I don't know what kind of a hell, the early periods, and the moment the surgery happened, they felt everything is good, all is well. All is well. Heart-wise, all is well. Physically, all is well. But brain-wise, we needed to intervene. So we see early arrivals and we see late arrivals. Early arrivals, outcomes are very good because cardiac team told us to watch. They connected us right away to the neurodevelopmental team. Late arrivals, no one told us. We thought it was just a small delay. We were so relieved after the surgery. We thought everything is fine. So by school, we were so behind. What is the outcome? Window is already closing. Both had excellent cardiac surgery. One conversation was the difference. One referral at the right time. So what is the care continuum? What exactly do we mean by the care continuum? This is the solution that we are proposing. This is the solution which you are already doing. AMRITA Hospital is already a leader in this care continuum going on. And I would just like to add on to it. It is integrated, it is systematic, it is seamless, but it needs to be absolutely automatic. It needs to be like part of the continuum of the cardiac surgery. Every child, no gaps. Absolutely no child missing out. So you don't have any child falling through the gaps. There are 3 pillars to this continuum. Number 1, early awareness and education. So immediate post-surgery conversation. Believe me, dear cardiosurgeons, parents after a successful surgery, the kind of trust that they have is awe-inspiring. We know it, we all as clinicians know it. And this is the time the parents are at that complete vulnerability. So one conversation post-surgery. Normalize screening. It needs to be done. It's a part of the continuum. Provide handouts at that time. Then, second part, the second pillar is systematic surveillance. At 12 months, at 18 months, at 24 months, at 36 months. You have simple checklists. You have absolutely simple checklists which the parents can do and know when to be referred, when not to be referred. And clear red flags. These red flags indicate whether a complete neurodevelopmental assessment is needed, just reassurance is needed, just meeting the neurodevelopmental pediatrician is needed, or neurodevelopmental team is needed. So we are not missing out this golden window. Seamless referrals, direct pathways, priority scheduling. You've gone in from the cardiovascular department, you will have priority scheduling. You will not have to wait. The feedback loop is also complete. The cardiac surgeon knows what is happening at the neurodevelopmental level. The neurodevelopmental level knows that the cardiac surgeon knows that. So it helps form a fantastic feedback loop. Let me give you an example. Arjun had a TOF repair at 6 months. Handout was given, education was given. At 12 months, there were a few concerns which were flagged. At 14 months, he was assessed, given an intensive intervention at 18 months. He has global delay, but he's thriving in school. He's doing well. No one dropped the ball. No gaps, just seamless integrated care. Arjun doing well, parents happy, surgeons more than happy, neurodevelopmental team more than happy. I think this is what we all want. So absolutely every child thriving. Let's build this together. What do you bring? Access to families. Trust that they have. One question, one checklist. You've done the major part. Now it's just the managing part of the neurodevelopment. And what do we bring? Our developmental expertise, our simple screening tools and clear pathways. This could be a model where CHD care extends into lifelong thriving, and the happiness is boundless. Like I said, when we were residents, the neonatal intensive care unit program was just developing, the NICU follow-up. So I was very fortunate to be mentored by Dr. AMRITA Fernandez, who has recently got the Padma Shri, for her pioneering work for breast milk, newborn thriving, and we were her students, so we know the kind of work she took out from us, and I'm so, so grateful to her. But NICU follow-up, the model that was built, and all over India, the model that is being followed, it has made a world of a difference to our NICU graduates. Similarly, our CHD graduates could do absolutely wonderful. So let us all build this together. From survival to thriving, these children deserve much, much more than survival. They deserve wholeness, and together we can give them that. Thank you so very much for giving me such a patient hearing. And I will be open to question answers. Thank you. Good morning, all.
Do we have any questions?
Jagmeet ma'am, I think the presentation was probably extremely clear. They don't have any questions right now.
Thank you so much. Or I think the seminar is going so wonderfully that all the questions have been answered. So that's absolutely wonderful. And thank you for giving me an opportunity. Absolutely honored and delighted.
Thank you so much. Thank you so much for taking out time for this. Thank you, ma'am.
Thank you.
Thank you for that insightful session. What clearly emerges is that care for these children cannot be fragmented. It has to be continuous, evolving, and responsive to their developmental needs over time. And we think about continuity of care. We now move on into An equally important question, how do we actively intervene to improve outcomes? What are the emerging approaches that go beyond traditional models? Because understanding is only the first step. The real impact comes from what we do next. This next session focuses on emerging neurodevelopmental interventions in CHD, neurofeedback, and beyond. To take us through this, we have with us Dr. K. Jayashankara Reddy. Dr. Reddy is a professor of neuropsychology and cognitive neuroscience and currently serves as the Dean of School of Social Sciences at Christ University, Bangalore. He brings with him over 2 decades of experience in teaching, research, and clinical neuropsychology. He has made significant contributions to the field with over 150 to 200 research publications, books, and edited volumes, and has been widely recognized for his work in cognitive neuroscience and neuropsychology. Dr. Reddy has also mentored numerous doctoral and postgraduate scholars and has presented his work at international conferences across the world, reflecting the global impact of his research. His work strongly focuses on cognitive functioning, brain behavior, relationships, and neurocognitive rehabilitation, including areas such as neurofeedback and brain-based interventions. What makes his work particularly relevant today is his ability to bridge advanced neuroscience with practical clinical applications, helping us understand how emerging interventions can be used to improve real-world outcomes. Today, he will be taking us through innovative approaches, including neurofeedback and beyond, and how these can shape the future of neurodevelopmental care. May I invite Dr. K. Jayashankara Reddy to take the stage.
I think most of you now, your brain is cognitively overloaded. I think we'll start a simple exercise. Yeah. So if you tell 1, you need to clap once. If you tell 2, 2 claps. If you tell 3, you need to turn towards the right. Yeah. 4 towards the left. 5, clap together. Yeah, 1. Louder, 1. 1. 2. 2. 1, 2. 2, 1. 3. 4. 4. What I said? You're not using your working memory. Yeah. 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 3. Towards right. Yeah. 4. 5. Yeah. 1. 1. 2, 1. 5, 1. 5, 1. 1, 2. 2, 1. Thank you. Thank you. Thank you. It's a great honor and privilege to be here for this noble mission. So since morning we are hearing about, the success of surgery is based on the heart function. Now we are talking about how we can provide the holistic approach where we can take care of both heart as well as the brain. We are very clear now. I'm very happy to see we are talking here. Otherwise, most of the time we end up telling that we succeed, based on certain parameters. We are not focusing much about, how the child life is going to be. Now we are talking about don't limit only that point where we can make a change in the child, the meaningfully their life and their academic life, the next, level of their life. That is the whole approach. I'm very happy to see here. Otherwise, sometimes what happens, we use the very thick boundaries between the specialization. That's good for, their profession, but it's not good for the patient. When I started my career in Sri Satya Sai Institute of Higher Medical Sciences as a young neurophysiologist and neuropsychologist,
I've seen this differences when they're providing the care for the epilepsy. The neurologists, they're more bothered about, how to reduce the number of attacks. Their outcome, their success is always they think about it. They won't think much about how the dose, what they're going to give, how it's going to affect their cognitive functions. When you ask the psychiatrists, they're more bothered about, something related to psychiatric symptoms. Then the surgeon, if you see in epilepsy surgery, they're more about, the surgical outcome. When you see this is a very difficult to see this, understanding in a different lenses, working together. That the joy I can see here, today I'm experiencing. Thanks to Dr. Krishna Kumar and Dr. Manu, Sonam and Arati, we can see that the joyness, togetherness, that collegiality. This main focus is the child. The main focus is the family. We can see when the family members were talking, we can see that joy and the happiness, from the team. That's a very, very, very important for all of us when we're working together for finally this need to translate it to the patient, the child, and the family members. So with that lens, now I'm going to speak a little differently. Now, whenever the cardiologist, when they're working, the outcome, the function of the heart, they use the very sophisticated tools like EKG and TMT. There are sophisticated now. The tools are coming up now. In the same way, how the EEG can be used to understand the brain function. When God designed this body, it's taken care very well, the protection of the brain, very sophisticated skull. Below that, very sophisticated layers. There is a water cushion. They're taken care very well. At the same time, you remember, all of you, and also the God also is given a tool. Whenever there is a change, whenever there is a dysfunction on that, there is a tool inbuilt. That is the reason psychologists, we strongly believe that there is a self-control, self-regulation. When there is something going wrong, the brain also can be able to correct it. That's what on and off we're talking about, plasticity and all those things. Now, this is a new dimension you can think over if you're providing service to that. Now we've seen there is a clinical challenges. One thing we need to remember, all CHD patients not going to be, NDD. There is certain percentage. Who they are, how to predict it. Is there a markers? Now we know that all the deficit we can see after certain age. We are seeing on ASD and the ADHD, it's not possible to see in the age of first year and the second year. Is there a way we can able to predict that percentage of the children who's going to develop the neurodevelopmental? That's one. At the same time, we have to remember, don't see the children all the time only on the deficit lens. There is a possibility, as a clinician, we see that what is wrong with the children, what is the deficit in the children, we ignore it. There is a specific unique strength of the child. As a psychologist also, on and off, I talk to my colleagues, don't see all the time the children only in the clinical and the deficit lens. There is a uniqueness of the child. I'm very happy to see that video, what you showed that, they're talking about the resilience or something uniqueness. I'm very happy to see that, there is a narrated in that video. What I'm trying to say here, how that EEG as a tool, as a lens, we can able to use it here to predict it after the CHD. If you do an EEG, what type of the changes can able to predict who's a vulnerable is going to develop the NDD. That is a major task on and off. We are talking about it, who they are. That's one thing. And also second things, we are talking about the deficit, the changes what we are going to see is not going to be uniform. Every child is different. Every child, that cognitive profile, what neurocognitive functions are going to be different. Is there a way where we can able to individualize, where we can able to customize it. That is the one thing we need to keep in mind when we're working with the children. So with this lens, if you see that, I'm not going to talk in detail because many things we covered it here. I'm covering it as a, how the EEG can be used as a markers to predict who's going to develop, certain cognitive deficit. That's one thing. The which part of the brain, that also is very important to understand that you cannot uniform. You need to understand that which part of the brain, is the left hemisphere, right hemisphere, is it a frontal lobe or a parietal lobe, how we can able to predict it. If we can able to predict it, because the age, if the brain is very flexible, if you can able to come up very customized rehabilitation, the certain things we can able to reduce it. That is the whole approach. That is one approach. And the second approach is, if you know that every behavior, whatever you see, the part of the assessment, definitely this need to come from the brain. I'm very clear on that. The brain, it need to come from the brain. Now, if you use the EEG as a tool to understand that in neuronal level, if you can able to mark it, if you can able to come up a certain, the biomarkers, that will help us to predict, that will help us to customize the rehabilitation with the holistic approach. That is the whole thing. Then with this, what type of, the new intervention based on the neurofeedback. Now, if you know that, if you can able to see your brain activity in front of you, then I mentioned that you have that capacity to change. You have a capacity to train your brain. That is the whole approach here. So that is the second approach, how this can be used as a intervention. This is the whole approach. So as I mentioned that, the next, the few minutes, I'm not going to discuss in details here. We already discussed here what is the vulnerability this because of all this, the reasons, what is the clinical challenges. I mentioned that we are not able to predict who's going to develop and what type of neurocognitive deficit. Is there a possibility, is there a way based on the EEG markers we can able to predict? This is the whole, the purpose in the first stage. And the second stage, as I mentioned, that why EEG is a tool to understand the brain function. The EEG is a safe method. As you know, this MRI, it's a very complex, and also if you see that affordability, it gives only the structural, it not much on the functional aspect. If you use the EEG, if you can able to understand the brain function, this surgery, maybe during surgery itself, still I can remember in early career when I'm working with Dr. Shekhar Rao. He's one of the well-known pediatric surgeon. He's in Satya Sai Institute of Higher Medical Sciences. During the time, I used to be in operation theater with them to know that now you're telling that when you're correcting in the heart, there is a change on the blood volume to the brain. How this is going to be affected? So we used to give the feedback. We used to give based on the EEG signal. Then the same way, we started helping in the intensive care. Intensive care. There is a part of intensive monitoring. If you have this certain EEG minimum channels, you can able to monitor how is the brain function, how the brain is responding to the treatment. So we can able to detect hidden issues. It can be the attention, or it can be some of the emotional and the anxiety, or this. All it reveals the noisy brain activity affecting the learning. So how we can able to understand this? Now, those who know the EEG, how many of you know the basics of EEG? At least the waveforms. Like the cardiologists, the way they interpret based on the QRS complex. In the EKG, in a EEG, based on the tiny waves, sinusoidal waves, there are different waves. There is a beta, alpha, theta, and delta. The frequencies 1 to 4 is a delta, 4 to 8 is a theta, 8 to 13 is alpha, above 13 is the beta. Now, when you see this, all this, the tiny waves, what I showed you on the right side of the picture, that it gives a lot of information. If there is a delta, that means the brain processing is slow. If somebody can see the beta activity, that means the brain is active. That means, if you see this waveforms, you can able to understand that how the brain is functioning. That is one thing. And also another important thing is how both the hemispheres are communicating each other. When you're given a particular task, or when you tell the child to open your eyes or to close your eyes, how the brains are responding. So I'm telling you a tip of the interpretation, generally how we use to understand the brain functions. Like this here, there is a clear-cut understanding now. Those who have high theta and low beta ratio, there is a clear-cut understanding now. There is a close connection with the distractibility. We understood well in ADHD children. Now most of you know that the neurofeedback is a very effective treatment for the ADHD. We succeed very well, excellent results. In the same way, for example, alpha. If somebody having a good percentage of alpha, it's indication that person is in a very relaxed state. Those who have less alpha, it's indicating that his cognitive abilities towards the thinking, some of the cognitive, psychomotor speeds are slower. Like this, frontal asymmetry. It's a good marker, to understand that emotional imbalance or impulsivity. Like this, coherence issue, then the persistent slow waves are delayed in the maturity. All those things can able to understand that. What I'm trying to tell you, when you're working as an holistic approach, the EEG is going to help you in a great way to understand these are the aspect. This will help us to predict who has the highest vulnerability to develop a neurodevelopmental disorder. And also severity, or which side, left or right. All those things is not possible based on the behavioral checklist or maybe some of the other checklist. This is a new things now. It's giving a lot of promise now. Because of the technology, AI, and the machine learning, if you can able to give the data, that data can able to map it and give you. But this can able to help you to understand the vulnerability. Now, in the same way, how this can be used as a intervention. As I mentioned that, if somebody have high theta level on the frontal, that itself is indication this person is going to develop executive function or maybe some impulsivity. Now, that is maybe not reflecting on a behavioral level. If you assess a neuropsychological assessment, but initially you may see there is a high theta level in the brain, on the neuronal level, maybe it's not reflecting on a behavioral level. If we can able to, before that turning into as a problem, if we can able to correct it, this is a good approach. Because the brain is very flexible, we can train them well here. That is the whole approach here. So here we are helping, we are encouraging the child to control a self-regulation mechanism. Non-drug approach here. As I mentioned that any drug, even though no one can say 100% side effect free. So now here, this is a very safe method. We can able to help the child in a simple, initially it's difficult to connect the child. Once you connect the child itself can able to, control, can able to improve this, all the activity, whatever it mentioned. Child actively learns to control the focus. We've seen great result when it comes on the attention, deficit, impulsive control. All those things, these techniques helps very well. So physical therapy for the brain, like the way we take care of the body, here this is a good intervention for the brain exercise. So as I mentioned, this is the reason the brain rewires with the practice easily, and also brains transfer to a real life. Whatever we seen in the lab, we can able to translate this result in the school performance. School. Even the certain whatever we mentioned, that the social and the emotional, the functions. I'm not going details here, the lack of time. So this is what I mentioned, that using the QEs is a new technique now. We can able to come up a markers, that markers can able to help you to predict the severity, to predict what type of deficit they're going to develop. Even it can able to give some clue how is the synchrony between the two hemispheres. So here, these are the details on 2004 and 2006. If you see that, there is excellent results on the neurofeedback, the result. So in evidence-wise, there is no doubt on it. Now, it's the only thing is, so how well you customize this for the child, then how well you integrate the holistic approach of what I mentioned that. So integrating the care in the multidisciplinary team, it will boost, it will help you adding to all this, the disciplines, whatever I mentioned, speech and the occupational therapy, and also it can reduce the need for the higher medication doses. Here sometimes is a good approach using together both, the medication as well as the neurofeedback. It supports the families and reduces the caregiver stress. And also this early intervention, if you can able to identify this in early, if you can able to start this, the results are very good. The team approach for the heart as well as the brain. This is a typical way to integrate the holistic approach for these children. This is the best way to integrate this. This is the best way to take care of both heart as well as the brain. So it's a summary. One thing, as I mentioned, that behavior is a symptoms, what you seen that in a emotionally or a socially or a cognitively, whatever. This is because of the brain changes and the neuronal activity changes. So the focus on helping the children, this is not only for the survival, it is your approach is towards the improve the child performance, their quality of life, the meaning of life. That's how it need to be reflected in the holistic approach. EEG help us to understand the brain as well as to train the brain. The neurofeedback helps improve the brain function, add brain care in the heart, use the technology initially, then follow up with this sort of techniques, this sort of the support will help you to take care of both heart as well as the brain. So healthy heart needs a healthy brain. Otherwise, it won't mean the success of the surgery. Until this is the best way to translate the success of the surgery into the holistic approach. So I'm very happy to help you. If anybody want to integrate the EEG and the neurofeedback is a part of your care, I'm very happy to help you. What type of protocol, what type of even the training also, I'm happy to help you. Thank you. If you have any queries, I'm happy to take.
So it's interesting, and obviously lots of opportunities. So will you help us set up a program by which, let's say, a child comes back following surgery and we want to monitor and scan for deficits that would concern us for the future, and then proactively start neurofeedback. I'm just not sure how that can be established. I think you need dedicated programs individualized to a child, and it's fairly resource intensive from what I can foresee.
Yeah, you're right, sir. Initially, when I part of this team with the cardiology, when you see that when you go to the intensive care or the post staff, I need to work closely with the anesthetist. See, when I'm monitoring certain functions of the brain, that changes may be due to some anesthesia, what are the drugs they give. So initially, I spent some time to understand that, what type of the drugs they're giving, what is the effect of the drug on that electrical. Yeah. So that is the one thing, that is the initial part. In the second part, after the post-op, every child need to go to the EEG. That EEG, again in outpatient basis, if, as I mentioned that, if the child have the percentage of the alpha or maybe the level of theta, we can able to guess what type of support the child need. At least that percentage, what you're telling that 20 to 30% have the chances of developing NDD. So we can monitor closely. We'll ask the child to come every time we need a support group, and whenever there is a follow-up, at least if we can able to do that, repeat EEG, if you can able to follow up, you can able to understand that how is the progress. That is one thing. Another thing, definitely you need a dedicated person for this, because the person need to be dedicated to understand this, on this context. Otherwise, what happened, the waveform changes what you see in here, we don't have a data to compare with the adult. We already have any data to compare adult. So we need to have that data, and also the person need to be exclusively focused on this. If we can able to do, if we can integrate as a part of the team, definitely this will help you in a great way. And also we've seen there is a clear-cut correlation. For example, if somebody have an attention deficit, now we have a behavioral level intervention. Now, if you see that, it's very difficult to predict how the effect of that intervention is going to be. Now there are some studies also giving that indication, even this, the EEG can able to help you how the prognosis is going to be. Yeah.
Thank you, sir. Very wonderful talk. You mentioned about that being in the operative room and trying to monitor. Right now, neurophysiological monitoring is very much for adult cardiac surgery. My question to Dr. KK also, are we doing neuromonitoring in children, have you seen, in the intra-op?
Yeah, so that's what I mentioned. How it happens, I will tell you. See, when I'm a student, when I started my early career, there is a HP intensive monitoring unit. There is a 4-channel of an EEG, but the department don't know what is the purpose, how to use it. That's what they dragged me. Then when I went in intensive care unit, then you know that anything to monitoring intensive care unit, it's not an ideal place, because there is a lot of other machines are connected. There's a lot of, the noise and the artifact, but the person need to be competent to understand, the changes is due to what. Otherwise, instead of the person is helping to the team, it may go on the other way. So you need a dedicated person, the competent person who trained on this interdisciplinary team. Then only you can able to use this tool as effectively.
So it has to be essentially done by a neurophysiologist.
Yes. Yeah.
To Dr. KK, sir, I have a question to you. Intra-op neuromonitoring in adults is actually proven to a great extent. Intra-op neuromonitoring in children, how far are we?
So I believe in simplicity, and I didn't fall for NERS and all those things. You see, the thing is that the way we approached our children who have been operated is to minimize injury. Reduce your bypass time, do your case selection well, get them out of the ICU quickly, minimize the use of opiates, go for myofascial blocks. A whole lot of interventions we brought in. We brought on our ventilation time to 10 hours now, post-op. And we get them out of the ICU. I took that approach rather than getting into more and more intense monitoring and trying to answer questions based on that and complicating and making our care. See, we can't afford to make our care more expensive than already it is. So I have taken the approach of not falling, and there is no proof that NERS makes a difference other than select surgeries, especially hypoplastic left heart. We don't do much of that.
EEG also is kind of getting into the way, but it's very difficult to monitor.
I saw the Boston circulatory arrest study, which is the mother of all this, what we're doing today. I was in Boston. I was training when this Boston circulatory arrest study happened. And the amount of disruption it caused in the post-operative care and the complication, the level of resources that was required, made me think this is not something we can do. So I'm very practical.
I agree with you, sir. The other thing is when this whole session is about care continuum and other things, the previous session also, when we miss the bus in the initial 3 years, 6 years, whatever, we still see them later. I mean, they may not have had any issue as a child. It becomes obvious in adolescence, when they become young adults. How are we going to actually integrate them at that level? How are we going to intervene them at that level? That's a very important field, I feel.
For sure, but I don't want to take away the significance of what has just been presented. This is just discussing with Dr. Arun Singh, this becomes a very important research question that we need to pursue a little further. And maybe it will offer us insights that we can apply simply.
Yeah. So I know this. The child need to go through the lot of other procedures and all those things. To start up, maybe once discharged, when the child come back, after some time, if we found that what is the chances of developing the child, if you do on an outpatient basis, if you can able to understand that the vulnerability, you start doing that, then slowly once the team is equipped using the tool is a part of this approach, then maybe this can be taken to the, first, the next level is then post-op to understand certain basic parameters of the brain. Then in the final stage, you can integrate on the post-op. The in operation theater, the neurophysiological monitoring. It's a big task. Thank you.
So I had a question.
Yes.
So as Sir mentioned, apart from it being very resource induced, are there any other limitations to neurofeedback that you're currently doing? Any other limitations?
The limitation one is the technology. Technology, that is the one thing. Another thing, neurofeedback cannot be seen the result 1 or 2 sessions. At least you need 10 to 15 sessions. At the same time, you need to monitor and also integrate with whatever as usual approach we have in psychology training and all those things. Addition to that, if you can add it, then it gives excellent result. Yeah. Other thing is one is the technology. Other thing is the training. As I mentioned, that is a new approach. This need to be used effectively, customized, based on the child profile. Yeah. I'm there during the tea
during
break,
the tea you can talk to sir.
Discuss with me. Thank you.
We have tea we have a panel now. Right after the panel, we'll have the tea. So can we place the chairs, please? Thank you so much, sir.
Thank you for that insightful session, sir. We've explored interventions and how we can actively support development and improve outcomes. But as we move forward, we pause to ask a deeper question. What do these outcomes really mean in a person's life? How do children grow into adolescents and adults beyond reports, beyond interventions, and how do identity, acceptance, and society shape this journey? This next segment is titled Beyond Outcomes, Voices Across the Lifespan. Now, this is a very special session that brings together multiple lived experiences, each offering a unique perspective on what it means to grow, adapt, and navigate life beyond a diagnosis. Because while science helps us understand, it is lived experience that helps us truly see. Now we welcome Ms. Kasturba, Research Fellow, ICMR Project, Department of Pediatric Cardiology, AIMS, KOCHI. She works closely with children and families navigating a rare and complex genetic condition. Ms. Nivedya, a student in bachelor's, Mr. Vaishak, and Mr. Siddhant Rathi, who is joining us through Zoom. To guide this conversation, we have with us Dr. Bindu Menon. Dr. Bindu Menon, Professor and Head of the Department of Psychiatry, AMRITA Hospitals, Kochi. is a psychiatrist at AMRITA Hospital with extensive experience in working across a range of mental health concerns, with a particular sensitivity to the emotional and psychosocial aspects of health and illness. Her work brings together clinical expertise and a deep understanding of the human experience, helping individuals and families navigate not just diagnosis but the emotional journey that comes with it. In settings involving chronic medical conditions, her perspectives become especially valuable as she looks at how identity, relationships, coping, and acceptance evolve over time. This makes her uniquely suited to guide today's session, which focuses on lived experiences, identity, and acceptance across the lifespan. We are truly glad to have her with us today.
Good afternoon, everybody. I'm so happy to be here, and I'm happy to see all these bright young people. I think this is a very important session because we are dealing with what happens to these children after having undergone, when we are medical professions, we are talking about the outcome of the surgery, the outcome of the procedure, but what happens in the individual's life, that is something we would like to understand from the perspective of the person who has undergone the life experience as very complex medical issues, and what happens to them and how they have tackled very successfully, as I can see here, the complex issues that lead to, it makes a lot of change in your life. You're not the same. You're not like other children. So I'm sure many of you have a lot of experiences to share. So you might have felt different. You might have felt a lot of problems while growing up. A lot of restrictions might have been there. So we would like to hear from you as to what has happened in your life. For example, we have somebody joining us from Siddhant, I think, joining us from Indore. So welcome, Siddhant, also. I think I will hand over the mic to, my mic to people who want to talk about it. First, I would like to know from the panel, what was it like for you as kids when we were growing up? I think we can start with Siddhant. If it's, can you explain, Siddhant, how did you understand your illness as a child? And what were when did you first realize that you had a problem? And how did it affect your life at that point? And how much did you understand of what it implies? Can we have
Yes.
Yeah.
I mean, for a large part of my childhood, I had the idea that it was not really what you call a congenital heart disease, but more like something like asthma or so. So during sports and activities as such, I could feel, right, that I cannot run or maybe participate as energetically as others there. But I think that was about it. I didn't really knew about what impact it would have going forward, or how serious the situation was, or things like that. I think I got to know about it when I was in my mid-teens, around maybe 14, 15, when I realized, okay, it's not something like asthma, it's something more complex, like a congenital heart disease, and a complex one at that. And I would say understanding what it was, learning to live with it, and trying to find adaptations as to how I can live my best was something which I then focused on. So that was maybe the focus of my teens.
Thank you for that, Siddhant. That was very interesting to know. And by the way, he's an engineer, electronic engineer, right?
I have my education in electronics, but I am currently professionally working as a software or AI engineer.
Okay, AI, that is the latest. So as you can see, a very successful young man. It is heartwarming for people who have helped you in your childhood to see that how far you have progressed. Let's go on to the next person's perspective on his, the same question, but Vishak, right? Vishak, so can you also give some light on this? Like, how did you feel growing up?
മലയാളത്തിൽ പറഞ്ഞോട്ടെ?
So we have to talk in Malayalam or
If
English?
anyone talks in Malayalam, it will be nice to translate for the sake of him who's listening also and others, some of us.
Okay. So we talk in Manglish. Yeah, thank you. Yeah, വിശാഖത ഇപ്പോൾ മലയാളത്തിൽ പറഞ്ഞോളൂ, ഞാൻ ട്രാൻസ്ലേറ്റ് ചെയ്തോളാം.
ഓക്കെ മാഡം, ഞാൻ 1999 മുതൽ ഇവിടുത്തെ പേഷ്യൻ്റാണ്. എനിക്ക് ജനിച്ച അന്ന് മുതൽ തന്നെ ഹാർട്ടിന് അസുഖം ഉണ്ടെന്ന് കണ്ടുപിടിച്ചിട്ടുണ്ടായിരുന്നു. അന്ന് മുതൽ പല ഹോസ്പിറ്റലുകളിലേക്കും പോയിട്ടുണ്ടായിരുന്നു. അവസാനം പറ്റാണ്ടാണ് അന്ന് അമൃത തുടങ്ങിയ സമയമായിരുന്നു ഇവിടേക്ക് വന്നത്. കൃഷ്ണകുമാർ സാറിന് ഓർമ്മയുണ്ടോ എന്ന് അറിയില്ല, സാറായിരുന്നു എന്നെ ഫസ്റ്റ് ട്രീറ്റ് ചെയ്തിട്ടുണ്ടായിരുന്നത്. സുരേഷ് ജി റാവു സാർ എന്ന് പറഞ്ഞാൽ ഫസ്റ്റ് സർജനായിരുന്നു എന്നെ സർജറി ചെയ്തിട്ടുണ്ടായിരുന്നത്. അതിനുശേഷം എന്താ പറയുക, എനിക്ക് കുഴപ്പങ്ങളൊന്നും ഇല്ലാതെ ഞാൻ ചെക്കപ്പിനും കാര്യങ്ങൾക്കെല്ലാം വരുന്നുണ്ടായിരുന്നു. പിന്നീട് 11 വർഷങ്ങൾക്ക് ശേഷം വീണ്ടും എനിക്ക് ഇതുപോലൊരു സർജറി ആവശ്യം വന്നു. അതും ഇവിടെ തന്നെയാണ് ചെയ്തിട്ടുണ്ടായിരുന്നത്. അന്ന് മഹേഡ് സാറായിരുന്നു അന്ന് മുതൽ ഇപ്പോൾ വരെ എന്നെ ട്രീറ്റ് ചെയ്യുന്നത്. ഇപ്പോഴും അന്നത്തെ അസിസ്റ്റൻ്റ് ആയിരുന്ന സുനിൽ സാറാണ് ഇപ്പോൾ എൻ്റെ മെയിൻ സർജറി ചെയ്തത്. അതിനുശേഷം എല്ലാ വട്ടവും ഫോളോ അപ്പിന് വരാറുണ്ട്. ഡോക്ടേഴ്സ് പറയുന്ന രീതിയിൽ ചെയ്തു പോകുന്നു. അതുകൊണ്ട് ഇപ്പോൾ നല്ല ഹെൽത്തി ആയിട്ട് ഇരിക്കാൻ സാധിക്കുന്നു.
Okay, the gist of what Vishak said was that he has been a patient from the time that AMRITA was started in existence, and Dr. Krishna Kumar was a person to see him first, and Suresh Rao sir was his surgeon, and he has explained his medical journey. But what I want to know, അതെങ്ങനെയാണ് നമ്മളെ ബാധിച്ച് നമ്മുടെ ചൈൽഡ്ഹുഡിനെ മറ്റുള്ളൊരു കുട്ടികളെ മാതിരി എന്താണ് ഡിഫറൻസ് നമ്മൾ ഫീൽ ചെയ്തത്? നമുക്ക് എന്തെങ്കിലും തോന്നിയിരുന്നോ? ഫീൽ ചെയ്തില്ലേ? നമുക്കിങ്ങനെ ഒരു അസുഖം ഉണ്ട് എന്ന് അറിഞ്ഞപ്പോൾ എന്തായിരുന്നു നമ്മുടെ ലൈഫിൽ, അതായത് കുട്ടിക്കാലത്ത് നമുക്കിങ്ങനെ ഒരു അസുഖമുണ്ട് എന്നറിഞ്ഞപ്പോൾ നമുക്കുണ്ടായ ലൈഫിലുള്ള വ്യത്യാസങ്ങൾ എന്തെങ്കിലും ഉണ്ടായിരുന്നോ, അതോ എല്ലാം നോർമലായിരുന്നോ?
വ്യത്യാസം ഉണ്ടായിരുന്നു വെച്ചാൽ എല്ലാത്തിനും ഒരു പേടി ഉണ്ടായിരുന്നു കാര്യങ്ങൾക്കെല്ലാതും. കാരണം
എപ്പോഴാണ് മനസ്സിലാവുന്നത് നമുക്കിങ്ങനെ
മനസ്സിലായിട്ട് ചെറുപ്പത്തിലായ കാരണം എനിക്ക് കൂടുതൽ അറിവുണ്ടായിരുന്നില്ല. പിന്നീട് സർജറി എല്ലാം കഴിഞ്ഞ് വന്നതിന് ശേഷമാണ് ഇവിടുത്തെ ഈ ഹാർട്ട് നെഞ്ചത്തിലുള്ള പാടമൊക്കെ കാണുമ്പോഴായിരുന്നു ചെറിയൊരു പേടി ഉണ്ടായിരുന്നത്. പിന്നീട് എന്ത് കാര്യങ്ങൾക്ക് പോകുമ്പോഴും ഫാമിലി ആയാലും അതുപോലെ റിലേറ്റീവ്സ് ആയാലും എല്ലാവരും പറയും വയ്യാത്ത കുട്ടിയാണ്, എല്ലാ കാര്യങ്ങൾക്കും പോകരുത്. അപ്പോൾ അങ്ങനെ തന്നെ എല്ലാവരും പറഞ്ഞ് ഒരിതാണ് വന്നിട്ടുണ്ടായിരുന്നത്.
നമ്മളൊരു രോഗി മനോഭാവം
അതെ, എല്ലാവരും അങ്ങനെയാണ് ചെയ്ത് കൊണ്ടുവന്നത്.
അത് നമ്മളെ ബാധിച്ചിട്ടുണ്ടോ? നമ്മൾ ഒരു രോഗിയാണെന്നുള്ളൊരു ഐഡന്റിറ്റി നമുക്ക്
ബാധിച്ചിട്ടില്ല. കാരണം എന്താ വെച്ച് കഴിഞ്ഞാൽ എൻ്റെ ഇപ്പം എനിക്ക് പഠിക്കാനായാലും ശരി, ഇപ്പോൾ ജോലിക്ക് പോകാനായാലും ശരി, അങ്ങനത്തെ കാര്യങ്ങളിലൊന്നും ഇത് എഫക്റ്റ് വന്നിട്ടില്ല. പിന്നെ എല്ലാവരും നല്ല സപ്പോർട്ടബിൾ ആയിരുന്നു.
Okay. So Vishak was saying that he had initially not much of an idea what he has, but then when the surgery was done, the scar and everything, and people telling him that he's not supposed to exert himself, so all that did make an impact in his childhood. But he has overcome all those hurdles, and he's a very successful accountant and a GST tax practitioner in Thrissur. He has his wife and one lovely daughter, so he's very blessed. So we are very happy for him. Yeah, okay. സാധാരണ ഈ ഒരു ഹാർട്ട് ഡിസീസ്, ഞാൻ അടുത്ത ക്വസ്റ്റ്യൻ ഞാനൊന്ന് കസ്തൂർബയോട് ചോദിച്ചോട്ടെ. കസ്തൂർബ റൈറ്റ്? കസ്തൂർബ ഇപ്പോൾ നമ്മുടെ തന്നെ ഒരു ഇവിടെ തന്നെ ഇപ്പോൾ വർക്ക് ചെയ്യണല്ലേ, ICMR ഫണ്ടഡ് പ്രോജക്റ്റ്. നിവേദ്യ is also our student, right? So we have two people. Sorry? Okay.
You can speak in English.
Right, okay. Fine. Here everybody in the audience understands Malayalam?
Not everyone. There's few people.
Okay. So, okay, then a dual language translation in there. So, Kasturba, എന്താ തോന്നിയിരുന്നത്? ഇതൊരു വലിയ രോഗമാണ് അങ്ങനെയൊക്കെയുള്ളൊരു ഫീലിംഗ് ഉണ്ടായിരുന്നോ? അതെങ്ങനെയാണ് ആൾക്കാരുടെ ഒരു കാഴ്ചപ്പാട് എങ്ങനെയായിരുന്നു? അയ്യോ കുട്ടി, പാവം കുട്ടി, ഹാർട്ട് ഡിസീസ് ഉള്ള കുട്ടി, അങ്ങനെയൊക്കെ ഉണ്ടായിരുന്നോ?
Yes, ma'am. People are seeing me as different person because of my condition, not because of they are seeing who I am as I am child, but they are seeing me with my condition. So I face the same problem what others face, because we know about our society, stigma. Sure, as a CHD patient, I've been isolated and people treat me like that. But I know, I know this is not who I am. I know this is my condition. So my parents also treat me like that. They are never treat me with this condition. With this condition, they are not never give me the restriction to anything. But people are doing that. The society, especially society and the children who study with me, they are seeing me different way, and they are like, yeah, they are thinking that the condition is who I am.
Okay, your identity was your condition.
Yes, they are thinking like that.
Nivedya, parents കുറച്ച് ഓവർ പ്രൊട്ടക്റ്റീവ് ആയിട്ട് ബിഹേവ് ചെയ്തിരുന്നു. കാരണം സാധാരണ പേരൻസ് ആണ്, അയ്യോ കുട്ടിക്ക് എന്തെങ്കിലും പറ്റുമോ, ഷുഡ് ഷി ബി ഗോയിങ് അറൗണ്ട് പ്ലേയിങ് ലൈക്ക് ദിസ്, ഡോണ്ട് ഗെറ്റ് എക്സ്പോസ് ടു, ഇവിടെ പോരുത് അവിടെ പോരുത്, അങ്ങനത്തെ വല്ല ഫീലിങ്സോ അങ്ങനെ വല്ല എക്സ്പീരിയൻസസ് ഉണ്ടായിരുന്നു പേരൻസോ റിലേറ്റീവ്സോ ഗ്രാൻഡ് പേരൻസോ?
Yes, ma'am. Obviously, my parents were very protective in my case because I am a single child. Also, I was diagnosed with tetralogy of Fallot, and I had 2 surgeries. So, they were very protective in my case. But they don't usually discuss these conditions with me in my home and all. We don't usually have these conversations. But they used to always say that if you have any discomfort, please let them know immediately, or any. So also they didn't sometimes they usually don't allow me to go to excursions and all as other children, because they were very worried about if any discomfort happened during that time, I may not be able to manage it. And also they restricted me from participating in dance performance and all, because I may not be able to cope up with other children while practicing and all. So there were so many restrictions in my case.
So did you rebel? Did you say, no, I'm going to do this? It often happens, no? Like there is a peer, acceptance from peers is very important at a certain age. So you might want to look or feel normal and be accepted as part of the mainstream. So many a time children don't like to accept the restrictions that are put on them. So did that have a issue? Anybody can answer. This is a common question. How did you get through that? Or did you feel that way, that you know they're being very unreasonable, parents are being unreasonable, I'm all right? Because children don't really understand many times that what they can and cannot do.
Ma'am, to parents, to us, they are kids. We are their kids. So definitely they love us. Their love and care, their protect being changed to a restriction. So I want to say that.
So you were not angry?
So I'm not angry because
I'm
not angry because they are. I am their child. So, but they don't know my. I want to tell every parents, if you have this CHD patients or children in your home, please understand who they are and their talent, their identity, and stay with them or stay with behind them or not stay with in front of them and controlling them, because that make feel themselves okay, I'm not able to do anything, I'm not being here. So that's bring them back. So every parents should be treat children's not being like this. So to understand and give them what they want.
വിശാഖന് എന്തെങ്കിലും പറയാനുണ്ടോ? നമുക്ക് അങ്ങനെ തോന്നിയിട്ടുണ്ടോ ചില സമയത്തൊക്കെ ഒരു അൺറീസണബിൾ ഒരു റെസ്ട്രിക്ഷൻ വെക്കുന്നുണ്ടോന്ന്?
തോന്നിയിട്ടുണ്ട്. കാരണം കളിക്കാനൊന്നും പോകാൻ വിടാറില്ല. കാരണം ഇപ്പോൾ ക്രിക്കറ്റ് കളിക്കാൻ പോയി കഴിഞ്ഞാൽ ബോൾ നെഞ്ചത്ത് കൊള്ളുമെന്ന് പേടി, പിന്നെ ഫുട്ബോൾ കളിക്കാൻ പോയി ഓടുമ്പോൾ കതപ്പ് വരുമെന്നുള്ള പേടി ഉണ്ടായിരുന്നു. ഇല്ലാണ് വിടാറില്ല, വളരെ കുറവായിരുന്നു വിടാറുണ്ടായിരുന്നത്. പിന്നെ എല്ലാവരും ജീവിതത്തിലുണ്ടാവും 10ാം ക്ലാസ്സിൽ പഠിക്കുമ്പോൾ ഒരു ടൂർ പോകുക എന്നുള്ളത്, അതും നടന്നില്ല. കാരണം ഇതൊക്കെ തന്നെയായിരുന്നു അതിലുള്ള റെസ്ട്രിക്ഷൻസ് വരുന്നുണ്ടായിരുന്നത്.
So we have to be realistic and understand that there were some restrictions. So, and that is sometimes necessary also.
Yeah.
Okay. Did it affect your academics in any way, all of you? How do you feel that all these many times you have to lots of visits to the hospital, lots of visits to hospital, and this identity, as you mentioned, as always having to follow up, and which other kids don't have to do. Padaka, did it affect your academic performance?
ഇല്ല, അക്കാദമിക് പെർഫോമൻസിലൊന്നും ഇത് എഫക്റ്റ് ചെയ്തിട്ടില്ല. കാരണം വർഷത്തിലൊരിക്കലും ഇല്ല, അങ്ങനത്തെ കേസ് വന്നിട്ടില്ല. എൻ്റെ രണ്ടാമത്തെ സർജറി വന്നത് +2 കഴിഞ്ഞതിന് ശേഷമായിരുന്നു, ആ വെക്കേഷൻ പീരീഡിലായിരുന്നു. എന്നിട്ട് ഡിഗ്രി ജോയിൻ ചെയ്യാൻ പറഞ്ഞത് തന്നെ ഇവിടുത്തെ ഡോക്ടറായ മഹേഷ് സാറ് പറഞ്ഞിട്ടാണ്. സാറാണ് പറഞ്ഞത്, നിർബന്ധിച്ച് ജോയിൻ ചെയ്യിപ്പിച്ചത്. നീ വെറുതെ ഒരു വർഷം കളയണ്ട, ജോയിൻ ചെയ്യുമെന്ന് പറഞ്ഞിട്ടാണ് ഞാൻ പ്രൈവറ്റായിട്ട് ഡിഗ്രിക്ക് ജോയിൻ ചെയ്തത്. എന്നിട്ട് ഒരു വർഷം വീട്ടിലായിരുന്നു പഠിച്ചത്. ഫസ്റ്റ് ഇയറിൽ എക്സാം എഴുതിയില്ല, കാരണം ലോങ് ആയിരുന്നു സെൻറ്റർ കിട്ടിയത്. അതുകൊണ്ട് എഴുതാൻ പറ്റിയില്ല. പിന്നത്തെ വർഷത്തിലാണത് രണ്ടും കൂടി ബാലൻസ് ചെയ്തത്.
Okay. So as we have very successful people here, so we don't have to ask that question.
He has some challenges, so it will be nice to hear his perspective.
Yeah, Siddhant, can you just elaborate on, did it affect your academics, all these problems? How did they impact on your academics?
I think for the most part, they did not eventually I kind of learned to live with day-to-day symptoms or maybe some participating. That is all okay. I think especially after maybe high school or so, there were a few big incidents which for me it had a setback in terms of academics, but I think they also made me realize that maybe what I'm doing academically is not as important as my health as well. So maybe it helped me carve out a different approach towards academics or how I'm designing my career. So I would say it changed the trajectory of what I wanted to be maybe.
I'll just add one thing. So, I mean, I'm actually, it's true that they've had a good life, considering that they all have been challenged in their infancy and with heart disease. But what we've seen is that it's surprising. I just was in my outreach clinic yesterday in Calicut, and I had a child who has had a Fontan operation after multiple periods of really difficult. And this child has broken multiple Guinness and Limca Book of Records in general knowledge, in academic performance, although he's lived with a resting saturation of 60 to 80%. So there's something in these children, if their level of inner determination and their feistiness or their overall grit, actually they can help overcome a lot of their actual physiological limitations. So this is something I've seen. That's something that we must need to nurture, the point that you were making on the positive side of their resilience. And how do we tap into that? Because I think all of them, I know Kasturba well, I know they were all challenged. It's not as if they've had easy lives, but they've found a way. And that's the inspiration we must seek.
Well said. That is really inspiring that all of you are here and you've overcome so many challenges. But it must not have been easy. So definitely a lot of credit goes to you. You cannot just say that, okay, they've somehow managed. It is that they have really overcome a lot of odds to get where they are. What was the attitude of your teachers towards you? Like, was it, again, overprotective? Your peer group, how did they treat you? Did they, okay, this person is not really healthy, so how did you get, what kind of attitude did you get from teachers and your peers?
Fortunately, I had a very strong supporting system in my school, and also and only some people in my school actually knew about this condition of mine, because I preferred not to share it with so many. And the people who actually knew about it, they were really protective, and they handled every situation so well without making it to a big issue and all. And my friends also in that age, they were very thoughtful, and even if I started feeling tired after running and all, I remember they used to be there for me, and they will wait for me they never made me feel judged, or it's like they never made me feel low as compared to others. So I was not really that no difference was there between me and others.
So you felt the same as everybody else. എല്ലാവരും ഒരുപോലെ തന്നെയാണ്. വിശാഖിനും അങ്ങനെ ഒന്നും ഒരു bad experience. Siddhant, did you have any kind of differences? Do you feel that you were treated differently by your teachers or your peer group?
I would say is that belonging has always been a problem. Yeah, teachers were kind of sometimes, when they came to know, they were a bit overprotective, over-indulging. On the other hand, we had PT teachers who maybe kind of had some sadistic pleasure in making me run. But yeah, there were things like that.
Okay.
Yeah.
Right. Are there any apprehensions that you have, like Siddhant, about your future, about maybe, are you married?
I'm not.
Okay. So like regarding marriage, regarding your future, are there any apprehensions that you have and would like to share?
I think I had a lot of apprehension maybe a few years back, and I've tried to take approach to what those, getting the root of what those worries, apprehensions, and everything are, and trying to understand what best I can do. I think currently, in terms of apprehensions, it is just that there is a kind of a rough prognosis, but I don't really know, right, how much time I have. And I think this kind of uncertainty makes it difficult for me to design rest of my life. Like let's say if it's 10 years, maybe I would do something more ambitious. If it's maybe 5 years, I would do something less ambitious, things like that. But yeah, other than that, I think fortunately currently I am at a good stage where a lot of these worries or apprehensions are something I have resolved, at least at my own personal level.
How did you manage to get over these things? Did you have any formal help, or did you get over it by some, mentoring, by people around you? How did you manage that?
Oh, I wouldn't say there's a single strategy. I think the major theme was to understand the world around me and then understand myself, like what is the root cause of the issues or apprehensions I'm having or my behavior, and then trying to dig into that why. And yeah, there were some points I did seek professional help with certain physiotherapists. Oh, no, sorry, not physiotherapists, psychotherapists. Yeah.
Okay.
And I think that was about it.
Vishagane, you are married with a kid. So ആ ഒരു മാരേജിൻ്റെ സമയത്ത് ഇപ്പോൾ മോസ്റ്റ്ലി നമ്മുടെ എല്ലാം അങ്ങനത്തെ എന്തെങ്കിലും ഒരു ക്രോണിക് ഇൽനെസ് ഉണ്ടെങ്കിൽ അതൊരു വലിയൊരു മൈനസ് പോയിന്റ് ആയിട്ടാണല്ലോ എല്ലാവരും കാണുന്നത്. അപ്പോൾ അങ്ങനെ എന്തെങ്കിലും ബുദ്ധിമുട്ടുകൾ അല്ലെങ്കിൽ ഒരു ടെൻഷനോ ആങ്സൈറ്റീസോ ആ സമയത്ത് ഉണ്ടായിരുന്നോ ഒരു കല്യാണ സമയമൊക്കെ വരുമ്പോൾ?
വിവാഹം കഴിക്കാൻ എനിക്ക് ആദ്യം താല്പര്യം ഉണ്ടായിരുന്നില്ല. പിന്നെ അച്ഛൻ്റെ അമ്മയുടെ ഒക്കെ നിർബന്ധം കൊണ്ടാണ് ഞാൻ വിവാഹം ചെയ്തത്. അപ്പോൾ ചെയ്യുന്നതിനേക്കാൾ മുമ്പ് ആ കുട്ടിയോട് സംസാരിച്ചിരുന്നു. ഇങ്ങനെ ഹാർട്ടിന് സർജറി കഴിഞ്ഞിട്ടുള്ളതാണ്, ഇങ്ങനെ മരുന്ന് കഴിക്കുന്നുണ്ട്, വർഷങ്ങളിൽ പോയിട്ട് തന്നെ ചെയ്യുന്നുണ്ടെന്നൊക്കെ പറഞ്ഞ് അവരോട് പറഞ്ഞിട്ടുണ്ടായിരുന്നു. അങ്ങനെ 1-2 പേർക്കൊന്നും അത് ആക്സെപ്റ്റ് ആയെന്ന് തോന്നിയിട്ടില്ല. കുറേ പേരൊക്കെ അത് റിജക്റ്റ് ചെയ്തിരുന്നു. പിന്നീടാണ് ഇപ്പോൾ വൈഫിനെ കിട്ടിയത്.
അപ്പോൾ അതൊരു കുറച്ച് ആങ്സൈറ്റി ഉള്ളൊരു ജേണി ആയിരുന്നു ആ ഒരു കാലഘട്ടത്തിൽ, അല്ലേ?
അല്ല, എനിക്ക് സത്യത്തിൽ അത് താല്പര്യമില്ലാത്ത
താല്പര്യമില്ലാന്ന് പറയാൻ
തോന്നിയിരുന്നില്ല.
താല്പര്യമില്ല എന്ന് പറയാൻ കാരണം നമ്മുടെ ഒരു അസുഖം വെച്ചിട്ടാണോ അതോ അതല്ലാതെ തന്നെ
അസുഖം വെച്ചിട്ടാണ്? മാത്രമല്ല അച്ഛനമ്മയ്ക്കായിരുന്നു നിർബന്ധം ഉണ്ടായിരുന്നത്. അവർ വയ്യാത്തവരാണ്, അപ്പോൾ അവർക്ക് എന്തെങ്കിലും പറ്റി കഴിഞ്ഞ് കഴിഞ്ഞാൽ നിനക്കാരും ഇല്ല എന്നുള്ളൊരു
അങ്ങനെ ഒരു ആറ്റിറ്റ്യൂഡ് ഉണ്ടായിരുന്നു അല്ലേ?
അവർക്ക് അതായിരുന്നു ആറ്റിറ്റ്യൂഡ് കൂടുതൽ.
നോക്കാൻ
ഒരാളെന്നുള്ളതായിരുന്നു അവർക്കുണ്ടായിരുന്നത്.
പക്ഷേ എനിക്ക് തോന്നുന്നില്ല വിശാഖനെ നോക്കേണ്ട ആവശ്യമൊന്നുമില്ല എന്നാണ് എനിക്ക് തോന്നുന്നത്. യു ആർ ക്വൈറ്റ് എ ബോൾഡ് കോൺഫിഡൻറ്റ് യങ് മാൻ. കസ്തൂർബ, എന്താണ്, what are your apprehensions in anger? Because all said and done, it's not all gung ho, I know that. So there are always these feelings inside, isn't it, that എന്തായിരിക്കും ഇനി ഭാവിയിൽ, what will happen to me, like, yeah. So again, that same question I'd like to ask you. Did you have any issues, problems, anxieties?
I haven't, ma'am, because in my community, every girls are married in 15-year-old or 18-year-old. In my case, I saw my condition as a blessing. because of that, I come this far. Yeah. Because of that, as I'm successful, I'm studied. Because of that, I come this far. Because I married in my 26 age. I'm married. I haven't any worry, but my parents have, and my family have. Lot of people say that she haven't get anyone to marry like that, but actually, I prove it. We can live like normal life like others. So, it's been good.
Of course. You have proved that everybody can live a normal and not only normal, a very successful life is
Yes,
what I
not
can see from
only
the young
normal,
people
because
here.
we are normal. This is our condition.
It is like you're achievers. Yeah. നിവേദ്യ പഠിക്കുകയാണല്ലോ ഇപ്പം. അപ്പോൾ ഞാൻ അതിനെക്കുറിച്ച് പക്ഷേ നെവർദലെസ് ഈ സിദ്ധാന്ത് പറഞ്ഞ മാതിരി നമുക്കൊരു എക്സിസ്റ്റൻഷ്യൽ ആങ്സൈറ്റി ഉണ്ടോ? എന്തായിരിക്കും നമ്മുടെ ലൈഫിൽ എത്ര കാലം ജീവിക്കുക, അങ്ങനെ വല്ല പേടികളുണ്ടോ? Do you have that kind of fear, like what is going to happen to me tomorrow? It's a serious problem, isn't it? All of us have a serious problem, so we are always thinking about, Siddhant, I think, was gone to feeling that how long do I have, 10 years, 15 years? That kind of question, has it come to you?
I actually didn't have all those kind of anxiety.
I hope I have not put in some questions. God forbid.
Actually, I have a very different perspective on CHT now. Because
yes, please tell us.
Because when I came to know about my condition, surprisingly I became more curious than getting worried. And now my current passion is to do research in cardiovascular health and to make a bigger impact in the lives of children like me, so that it can create a huge impact. I think that's why God has made me.
So you found a mission in your life.
Yeah, I turned
Great,
that
wonderful.
into
Good to know that. A big hand.
It has created a sense of purpose.
Yeah, that is what happens to some people. Some people sit and brood. Some people then take it up as a mission in life to do something to change the course of this problem. Or opportunity, I should say, not a problem.
Big opportunity.
Yes. Okay. So would you like to say what you would like, what are your plans for the future? Siddhant can start, I think. You have any plans for, is it
I mean, no plans as such currently, but I usually try to do it like maybe 2-3 month plans rather than long-term plans, seeing the uncertainty. So I think for me, the immediate goal is maybe to volunteer at some kind of a local school for disabled kids as a teacher, because I think that is something I can do well.
That's great. That's wonderful. Yeah, so like each day is a blessing. Is that how you feel?
Not really. I
Not
mean,
that
each day is a day, but yeah, it's good to be alive, kind of.
Yes. Okay. Any message that any of you would like to give, all of you, and one by one, you could just tell, give us a message as to the kids out there who are, in the same state or process as you are. Would you like to start, Siddhant? What message would you like to give?
I mean, so if it is for other people with CHD, I would just say to them, like, enjoy your life and maybe try to learn about what condition you have, try to educate for yourself.
Okay.
That's about it.
വിശാഖ്, എന്തെങ്കിലും പറയാനുണ്ടോ? ഇതേമാതിരത്തെ നമ്മൾ അനുഭവിച്ച മാതിരിയുള്ള അസുഖമുള്ള കുട്ടികൾക്ക് എന്തെങ്കിലും ഒരു മെസ്സേജ്?
ഞാൻ തന്നെയാണ് ഏറ്റവും വലിയ ഉദാഹരണം. കാരണം എന്താ വെച്ച് കഴിഞ്ഞാൽ, ഞാൻ ജനിച്ച് കുറച്ച് ദിവസത്തിനുള്ളിൽ മരിക്കുന്നു പറഞ്ഞ ഒരു വ്യക്തിയായിരുന്നു. എനിക്ക് 32 വയസ്സായി. ഞാൻ അതുവരെ ജീവിച്ചിരിക്കണത് ഈ ഹോസ്പിറ്റലും ഇവിടുത്തെ ഡോക്ടർമാരുടെയും കഴിവുകൊണ്ട് തന്നെയാണ്. അപ്പോൾ നമുക്ക് അസുഖം വന്നു കഴിഞ്ഞാൽ കൃത്യമായ സ്ഥലത്ത് കൃത്യമായ ആളുടെ കയ്യിൽ നിന്ന് കൃത്യമായ ചികിത്സ ലഭിച്ചു കഴിഞ്ഞ് കഴിഞ്ഞാൽ അതിനൊരു ഉദാഹരണം തന്നെയാണ് ഞാൻ. അത് തന്നെയാണ് എനിക്ക് പറയാനുള്ളത്.
Any of you want to share something? What is your message to kids?
To kids, I want to tell them this is the beginning of your life. So no matter who you are, your condition, people always judge you. If you have CHD or not, they are going to judge you, and they are try to stop you. So that's not a matter. So please understand your identity, your strength, your talent, and grow up with that. And please, to parents, give them support, what they want, what they need. And also, I recently shared with Sonam, and I really like their department, new department, because it's needed. It's really needed for us, because when I already tell her, because when I came here like 1999, my first doctor is KK sir. After that, Mahesh sir. I started to consultation to Mahesh sir. So that time I saw that she give this assessment to kids. I really think that it should be get me. I will be more successful than this maybe. So I really like that. I want tell thanks to them to bring this department here. So this is very wonderful. I like it, and thanks for Manu sir and KK sir and Sonam to this opportunity to our kids.
Wonderful.
CHT is just a part of your life. It can't define you. So it should not be an excuse to achieve your dreams. And I have immense gratitude to each and everyone in my life, like parents, doctors. Krishna Kumar doctor was one of my first doctor, and then Mahesh doctor came. And I actually loved visiting this hospital because Mahesh doctor has treated me in such a way that he was so compassionate. He was more than a doctor for me. So that's why actually I started pursuing cardiovascular research. I wanted to be like them.
Very nice. Okay, I think we are running out of time, right? Yeah, okay, so let me wind up this session. We have had some wonderful experiences that have been shared, and what we know is that from them is that the illness does not define you. You can overcome this and you can create something out of this. This was given to you for a reason, and you have a mission to accomplish. That is what the message that we have got from these young, bright people over here. Thank you so much, and thanks for the opportunity once again.
Thanks, Siddhant. Siddhant, it's been a privilege to have you here, and we would like to interact more often because you're so articulate and so thoughtful. And of course, everybody else in the panel, but I wanted to say, because you're from far, you're speaking from Indore. So all of you, wonderful, thank you so much. Thank you, madam, for the wonderful moderation as well.
Thanks so much.
Small request to you all, have a cup of tea and come. We have one interesting session and we have one more interaction. So the quickest tea of your lives, please.
Don't run away.
They will come back. They will come back. Maybe 5 minutes.
I hope everyone have had their tea. It was so lovely and heartwarming to hear directly from you all. Thank you, everyone. And that session really fulfilled our hearts, and so happy, all the very best for your everyone's future. And now we invite someone whose contribution to pediatrics in India is truly extraordinary, a name that has shaped thinking, practice, and generations of clinicians. It's my privilege to introduce Dr. M.K.C. Nair. Dr. Nair is one of the most respected figures in Indian pediatrics, a clinician, academician, author, and mentor whose work has left a lasting impact on child health and development in this country. Over the years, he has been associated with several firsts in pediatric care and has played a significant role in shaping the direction of pediatric practice and developmental thinking in India. He has authored and edited numerous books and academic works in pediatrics, contributing immensely to knowledge, training, and capacity building across the country. Generations of pediatricians and child health professionals have been influenced by his work, both directly and indirectly. And truly, whatever we say about him today will still fall short of capturing the depth and impact of his contributions. While he is not with us in person today, we are deeply grateful that he has taken the time to share his thoughts with us through a special message. It's an honor to hear from his as we bring this seminar to a close, to a final. So may I now request that we play the video message from Dr. M.K.C.
You all, I'm sure you had a wonderful day today discussing various aspects of congenital heart disease, surgery, outcome, etc., etc. I'm proud to say that Dr. Krishnakumar and his team has created a stable, cohesive unit in AMRITA for cardiology, not only for children but for adults also. When you look at the issue of cardiac surgery, particularly for congenital heart disease, what we need to look at is mostly we must focus on the outcome. Output is immediate one, whether baby has survived, has he got any complication, has he gone home, all that is important. But ultimately what is more important is the long-term outcome. So a summary statement I would make that the long-term outcome is excellent. Actually, most children survive into adulthood without much problem. They have good normal intelligence. Many of them are able to go to school, or most of them are able to go to school, except for rare serious congenital heart diseases. Having said that, we also should look at their coping skills, their improvement in academics, are they getting job, etc., etc., etc. The problems are, on the other side, the problems are there are a lot of learning disabilities that we should take care of. Many of these children appear normal, but when they go to school, there are a lot of learning disabilities. They may have high incidence of anxiety, depression, and some behavior problems. That is a weaker side, that is the negative side they have, and we need to follow it up. The opportunities that we get to do for them are many. I will discuss one by one. But more than that, let's look at the challenges. What are the challenges that they have? They have reduced physical activities, school participation, job participation, etc. Not that every child has, but when compared to normal children, they may have reduced activities. And there is a huge problem about transition difficulties. That is from childhood to adolescent to adult. How do we get over all this? We can get over all this by actually doing what is called the pediatric surgeon or the team that is doing the surgery. Continue to look after them till 18 or 24. Don't transfer to a new team because somehow that doesn't work out well. Now what we can do, what are the opportunities that we can do? We said they can have school problems, they can have developmental delays, they can have mild cognitive problems, they may have learning disabilities. How do you prevent all this? That is where the concept of habilitation comes. Habilitation means the impairment should not go into a disability. The impairment may be because of the intrauterine cause that produce the congenital heart. It may be because lack of oxygen in the intrauterine period or immediate postnatal period, or it may be some problems after the surgery. But whatever it is, there is an impairment, and that impairment has to be addressed. How do you address? And the way we address is what is called bio-psycho-socio-spiritual. Bio-psycho-socio-spiritual. The biology part is the surgery and all that, and the medication. The psychosocial part is looking after their psychological health. And there has to be a spiritual element, because without the spiritual element, and particularly when a patient goes from AMRITA, the spiritual element has to be definitely there. What we can do is can be summarized in one new word. It is called developmental habilitation intervention. Okay, I have spent 45 years doing early child development, proving early intervention is effective, proving early language stimulation is effective. So many things have been proved. Even now we have just proved autism intervention is effective. Putting all this together in one single word, it is called developmental habilitation intervention. Instead of waiting for disability to happen and then going for preventing handicap, we can do it early. There are many aspects to it, one or two I will just mention. And the most important one is the early stimulation for high-risk babies, especially those who have some cardiac problem. No overstimulation, but early stimulation. You can have early intervention program. Intervention is anything that you do early. In the younger age group, it may be by a development therapist or developmental interventionist. At a bigger age group, it may be by occupational therapists, speech therapists, physiotherapists. All they come, the whole team come into. Small babies all need to be done only by the development therapists. Then what we can do is neurodevelopmental follow-up. If you have a child, it is just like if you are doing surgery for cochlear implant. Suppose you are doing cochlear implant. Before and after you need to do speech therapy. Similarly, if a child is going for cardiac surgery, the assessment should be done early, and continued neurodevelopmental follow-up and early stimulation is important. Once you do all this, what happens is the parent is on your side. That is the parent education part. Most of the time, these children face a lot of problems. They are discriminated, they are isolated, they don't feel part of the school. And partly is because the parents don't let them do anything what they would have done for the normal children. So what we need to do is encourage the child to excel and teach the parents what are the realities of life and let them enjoy life like any other child. Thank you so much.
Thank you, Dr. M.K.C. Nair, sir. It was really a wonderful, insightful section. As we move toward the final part of our program, we shift our focus from individual journeys to systems, structures, and the future. Because the question now is not just what we understand, but what we build from here. So the final segment is titled, Shaping the Future, Building Systems, Registries, and Pathways. If we are to truly support children with congenital heart disease, neurodevelopmental care cannot remain isolated or fragmented. It needs to be integrated into national programs, supported through registries, and sustained through structured frameworks. And this is where policy and public health systems play a critical role. If we look at India today, we already have a powerful platform in space. The Rashtriya Bala Swasthya Karyakram, or RBSK, a national program designed to screen and support children across the country, covering what we know as the 4 Ds: defects, deficiencies, diseases, and developmental delays. So it has created an incredible reach from Anganwadis to schools, bringing early identification to the forefront of child health. But as we have discussed throughout the day, identification is only the beginning. The next challenge is, how do we strengthen follow-up? How do we track development over time? And how do we integrate specialized care, especially for children with conditions like CHD? And this exactly where today's session becomes crucial. So, because the future lies not just in creating new systems, but in strengthening and integrating the ones we already have. To help us understand this, we have with us Dr. Arun Singh. Dr. Arun Singh is a senior pediatrician and a key national leader associated with the Rashtriya Bala Swasthya Karyakram, RBSK, under the National Health Mission. Dr. Arun Singh has been closely involved in the design, implementation, and strengthening of this program, working at the intersection of clinical care and public health systems. His work focuses not just on identification, but on building pathways for early intervention, referral systems, and service delivery through district early intervention centers, that is DIAs. What makes this perspective especially important for us today is this: as we have discussed throughout the seminar, identification is only the first step. The next frontier lies in long-term developmental follow-up, integration of specialized care, and building structured pathways for children with complex conditions like congenital heart disease. And this is where national programs like RBSK has immense potential to evolve from screening platforms into comprehensive developmental care systems. Today, Dr. Arun Singh will help us understand how this vision can be realized and what the future of RBSK could look like in the context of developmental care. May I invite Dr. Arun Singh to take the stage. Please, sir.
So time is very less, and I know you have still a session to go. So I'm going to talk of future of RBSK, but I'm still not clear. I started this journey in 2012 when Government of India called me to start a program for children from birth to 18 years. Whether we have understood the philosophy of RBSK. So India is a vast country with its local cultures, public health. And whenever you are designing a program, it cannot be sitting in Delhi alone. So I think I was blessed because I could travel and get a lot of inputs from all of you. Not that I could utilize everything. Now, just to tell you, we have about 2.6 crore children born every year. That is much more than the population of entire Australia or New Zealand. So, population is not a burden. If you think that each child has 100 billion neurons, and you just heard that people with congenital heart disease are aiming to achieve things which even people with normal heart are not able to do so. So that's the challenge they have taken, because each one of them are blessed with 100 billion neurons. So if I multiply 100 billion neurons into 26 million newborns, that's the kind of cognitive capital we are generating. Now, roughly developmental delay is about 10%. There are various studies, I will not go into it. Just you heard Dr. M.K. Nair, he did a study from 0 to 2 years, it is 11.9%. Now this is cutting across all diseases. This is a developmental delay. Now, one of the philosophies was, when RBSK was trying to develop, was whatever may be the condition, ultimately cognition is the final answer. If you are not doing enough to help the child's cognitive, because for every mother a child is a dream and they want their children to achieve something. So RBSK is not only about child health, screening and early intervention services, but initially it was planned with science and equity. It didn't want any paper. So the first line I wrote that whenever you ask paper for below poverty line, etc., the poorest person will have no paper. So if it just comes to your hospital, he may belong to Karnataka coming to Tamil Nadu or Tamil Nadu, because these are bordering areas. He just needs to come. Whether he is a son of Ambani or he is a son of a rickshawala, I don't care. As a child, being a citizen, this is assured health. So do not miss the last child standing in the queue. The other thing was that in almost every OPD, and I remember telling this to Madam Anita Saxena when I visited her in one of the cardiac OPDs which she was seeing. I was saying, Madam, what are you seeing? You are only seeing the heart. The child, it's a government hospital, huge queue. Can we train a non-medical person to see the entire child? It will not take away your time. So instead of asking the question in your OPD, what is your problem? Because the answer you are going to get depends upon the mother's cognitive level. And often her priorities may change. She has come to you for heart, she will forget to tell every other thing because she thinks if heart is put it into order, everything else will be okay. That's not the situation. So I said, don't ask a single question. Do head to toe examination. So whole book was written without asking a single question, and get this done by anybody, a nursing staff, even we said a car driver. Children are waiting in the queue. Someone can go to them, examine them from head to toe and write it. Okay, you are focusing on cardiology. What about the rest? At least examination has happened. So the first question we ask is, why have you come? An organ-specific approach. Then we should remember critical periods of brain development. This has already been talked about, and that is why in RBSK we wrote two things which are very important, which I believe that a lot of you are not using. One is, please go through this book released by Government of India, Journey of First 1000 Days. I think every parent, and it should be translated in the local language, this is free of cost, it can be downloaded, because as a pediatrician, the parents bring the baby only when they think they are sick. There is no book on pediatrics which tells you how to rear up a child. So that is one thing. Second thing is, the screenings are done with a different purpose, not to ask, do you have a problem? You just see them from head to toe, including the developmental by the. So I think this could be practiced in every medical college where you have hardly 5 to 10 minutes. I'm not asking the doctors to waste their time. You can train someone who is in your system, can see the child. So you know that you are going to focus on heart, but someone has seen the entire child. So about 40 disorders, now it has gone to 60, were selected in this. And I am very happy to tell you, in the beginning itself, Dr. Krishna Kumar was one of the key members to guide us. And that is how congenital heart disease, and I still remember when congenital heart disease was included, the first remark from the WHO was, a country which cannot take care of diarrhea and pneumonia, why should it think of congenital heart disease? And the answer I had was, if stomachs go without food, still the sky over the land goes with satellites. So if you have money to fly satellites, you jolly well have the money to treat congenital heart disease. So, this cannot be excuse of it. Now, I will not go into this, okay. Now, just one thing, please do not confuse developmental delay with developmental deviation. Delay is where you can wait. You are waiting on the station, a train is coming, it is delayed. What if the train is already derailed? Then someone has to put it. So the derailed is something different, that is deviation, and you should not even wait for a day. Supposing I have cataract, why should you want to wait? A child is born with a cortical thumb. A child is born blue. These are this is not developmental delay. So, one of the things which we did was, I would ask you that please follow this card. Even when I was teaching DM to my students, I said, this is a card which has been translated in all languages. I know it by heart because I did it. India is a country where language translation becomes very difficult. So the green portion is what the mother sees for, let's say, 2 to 3 months. And what she has to do is written in violet. So even if there is a delay, even if you operate on it, the blue ones is what are the things which you have to do, which will help the child. And the red one is, if any one of them is positive, this is not delay, this is deviation. This has been validated by Maulana Azad Medical College. But what I will tell you, this pictorial tool doesn't have the photographs of any one part of the country. When I was making it, I made it very sure they represent the entire country. This is up to 3 years. This, please use it. All you have to do is tell the mother that she should, what are age group. All you have to see is the red flag sign which your nurse can do. This can be very simple. It will not take more than 3-4 minutes because it is color. So you don't have to even ask questions. My another message is, please train everyone. 37 weeks is not term. Even if you have a CHD, don't terminate at 37 weeks. 37 weeks was based on lung maturity, not brain maturity. So this is March of Dimes, and it has come from a very famous study that people who have lived from 39 to 41 weeks, if they come out, they do much better in the life in terms of cognition than to those who come out from 37 to 39 weeks. So if full term is 39 to 41 weeks, 37 to 39 weeks should not be called term, it should be called half term or quarter term. So this is late preterm, early term story. Now try to understand that this 23 weeks and 40 weeks is the sulci-syri. The body should get time to make the 100 billion neurons because it is 250,000 neurons per minute. Now, I have a request with Dr. Balu. Supposing you have done an antenatal scan and the mother knows that she has a child with a congenital heart disease, but she wants to keep the child. She doesn't want to abort it. Now, how are you going to take place that stress which is added now will produce an IUGR? It is not the nutrition, it is the stress during the pregnancy. So I always say don't quarrel with a pregnant woman even if she makes a mistake. So some kind of a mechanism by which when you are telling and they don't want to abort the child, how to bring down their stress. Even screening produces a stress. And nowadays I see that the number of investigations and screening are increasing, which is good in one way, but is it adding stress? So that I'm just raising the question how it should be addressed. You might have an answer. The next thing is, when we became doctors, the usual sign was that it will change your economic condition. But there was someone, if you ever tend to know, I am a great fan of Virkov, and Virkov said the physicians are the natural advocates of the poor and the social problem largely falls within their steps. Yeah, I know the bell has ring, and I just want to tell you that the intrauterine period has to be understood. Tomorrow we may understand why there are birth defects and some things which you can take it if it can help you. This is the sound. So this, Dr. Krishna Kumar has seen it when I was a HOD there. We got this sound level. Whenever there is a sound, it becomes red. So the level of sound goes down. In children with apnea, we tried this 3 level of support. And to my utter surprise, I could come out with this simple thing instead of using CPAP, etc., or even ventilation. This was one of our nursing staff's baby, and we did a lot of things. I'll just run this small video. This is an ICU. We made 2 ICUs. One where the sickest baby will be the mother, right from day one. And we started measuring the head circumference. So you can say we had 2 ICUs, one in which mother could come and go, give KMC, the other, the mother's bed has to be next to bed. My residents did not agree, but we found that the head circumference grew much better. Initially the nursing staffs were slightly irritated, but they found that the mother is actually a pair of hands. Only 2 things: mother is not allowed to eat inside and all her belongings are kept outside. So she has to be. Now, even if the baby is on a ventilator, so the other thing which I don't know, we were told that don't give a bath to a preterm child. I found that I was doing skin cultures. This story may be true in North America, but here. So we studied the composition of the amniotic fluid. The composition is like ringer lactate. So we started this, so even with preterms, so this bath is with ringer lactate at the same temperature as with the amniotic fluid. And believe me, the children loved it because this is what they were doing in the mother's womb. The only thing is, this was a child who was not walking. Anything. She's also from Kerala. So when she was visiting, I said, leave her on a rough surface. Believe me, this is the first video she sent me. The child started walking. So maybe our floats are too smooth. They don't encourage the child to walk. So these are all, you can see but this is not water, and you give the same buoyancy to them, the same feeling. Now, these are too early. I don't want you to adopt tomorrow, but we did it with successful. More evidence have to be created. This is a child who used to go on to apnea, and we didn't want to give caffeine. Very high dose caffeine was being given. So the support system helped us a lot. So I will, this child was declared as deaf from AIMS New Delhi. This child was from Calcutta, a doctor's child. She was given hearing aid. The mother refused to take it. So I said, do one thing. Take, those days small tape recorders were there. I said, tape your voice and make the child hear it. Surprisingly, just like amblyopia fugax, the hearing improved. Today this child is in the college without. So I discussed this with Dr. Bhutani and other people. There is neuroplasticity even here. So lot of things which we really do not know have to be. I'm not saying in all cases, but there would be some cases in which you will be there. So this was all RBSK, the screening. This is the Beraphone. And I will just take 2-4 minutes because this is very important. So I would say, now you just see it. Okay, can we go back? Is there any way of going back? Can someone help me? Can we go back? Just go back, go back. Go back, go back, go back. Just go back. Just one more. Yeah. So I would tell you that every department, and I would request that even your cardiology should get to develop a early intervention center. This is how it would run. It will be all group. I'll just keep on showing you the waiting room, the out, this is in a government sector, the optometrists, audiologist, the dental room. It has been designed like a car. We found in preterm children there is huge caries, and you can understand a child with congenital heart disease. And this caries was 60% among the children of doctors, those who are faculty members. We did this study. So it seems that our behavior. So I will just run it quickly and we will end this. So even for plasters, we designed a swimming pool, a pool. So plasters will come out by itself. You don't have to cut it. The EEG, the EMG, everything was done there. The bathing, the 3-layer. We developed the human milk bank, and this was the screening. So thank you very much.
Thank you, Dr. Arun Singh, for that insightful session. You have helped us understand how large-scale national programs like RBSK can play a pivotal role in shaping the future of development care in India. As we come to the final segment of today's program, we take a moment to reflect on the journey we have had. From survival to vulnerability to development to school to interventions to identity and lived experience, and now to systems and policy. This brings us to our final summarizing panel discussion, Building India's Neurodevelopmental Pathway After CHD, Policies, Registries, and Long-Term Care. This panel brings together diverse expertise, clinical, developmental, and policy perspectives to reflect on key questions. How do we bring all of this together? How do we move from individual efforts to structured, scalable, and sustainable systems of care? How do we ensure that we have discussed today translate into real change for children and families? So we have Mrs. Veeralakshmi ma'am here. Mrs. Veeralakshmi Rajshekhar is the country director for Children's Heart Link, a US-based non-profit organization dedicated to improving access to pediatric cardiac care in LMICs. Since 2023, she also has the additional responsibility of managing the Children's Heart Link Indian Foundation as the honorary ex-director. For 14 years, she has supported several initiatives and partnerships to strengthen the quality of pediatric heart care in the country and worked closely with some select pediatric heart programs to help enhance their clinical capacity with emphasis on patient-centric care. She has fostered several collaborative partnerships with diverse stakeholders ranging from governments, healthcare institutions, professional bodies, and parent-patient support groups to advocate for equitable, high-quality, lifelong care for children with heart diseases. She's a trained psychiatric social worker from Nimhans with over 30 years of experience in social work, education, practice, and NGO management. Her expertise includes working with multidisciplinary teams, program development and evaluation, strategic planning, operations, and donor engagement. We are truly glad to have her moderate this important session. And joining her on the dais, we have an esteemed panel of experts who have been part of this journey throughout the day. Dr. Krishna Kumar, Dr. Manuraj, Dr. Deepa Bhaskaran, Ms. Bindu R, Dr. Arun Singh, Dr. Brijesh, and Dr. Balu Vaidyanathan. Each of them brings deep expertise across clinical care, development, education, and public health. Sorry, sir. Okay, I invite everyone on the stage. Thank you.
So we don't have Dr. Deepa here. She had to leave. We do have Dr. Kirsten Verity. She's joining us again from Edinburgh.
So, thank you, Sonam and Team AMRITA, for inviting me over for this national seminar. I think we've had a very insightful day today. I mean, there's so much that I learned today, not only from the expert panel sharing from their evidences and their studies, but also from the lived-in experiences from parents and families. It was so heartwarming to listen to that conversation, and there's a lesson from that, lesson or two for all of us from that. Today's concluding session, this is going to be a summarizing panel on building neurodevelopmental pathways for CHD and what are the gaps and what is the way forward. I think 3 decades of pediatric cardiac care in India, we've seen several advancements. The most significant among them that we've talked today is about improvement in survival, right? When we are talking about improvement in survival, we go beyond survival after cardiac surgery. We look at cognitive outcomes, emotional outcomes, and neurodevelopmental outcomes. So we're talking about long-term care, we're talking about lifelong care, we're talking about quality of care. So we're talking about how we create an environment where we sustain and where we are enabling the child to thrive beyond survival. So when we talk about that, we've also listened to the sessions today and understood that there are plenty of significant gaps that are pervasive across the way that we render this care to a child in our country. So in this panel discussion, we will kind of address questions to the panel experts and try to understand from them what are the gaps in delivering long-term care for children with congenital heart diseases post-surgery. We'll also look at opportunities where there is scope for multidisciplinary collaboration, because in a routine clinical follow-up, it is not possible to pick up any kind of neurodevelopmental vulnerabilities or learning difficulties or any kind of emotional kind of problems in a child or a family stress. Right? It's not possible. You just look at the cardiac picture, but here is where we talk about going beyond the cardiac picture, looking at the child holistically. And we'll also try to understand how it is possible to get clinicians collaborate at various levels, not just the cardiac team, but also developmental pediatricians, also clinical psychologists, social workers. And is it possible to go beyond the hospital, looking at caregivers, looking at advocacy groups, looking at the health systems to see if we can generate collaboration there also, because these are multiple stakeholders working towards a single cause. So let me address the first question to probably to Dr. Bindu. I think Dr. Bindu is here. Ma'am, from your perspective, what are the biggest gaps today in neurodevelopment follow-up of children with congenital heart disease? Yes.
Hello? Yeah.
Yeah.
It's okay.
What are the gaps, and also, are we missing any opportunities?
Yeah, the thing is, what I feel is there is no screening, for the CHD children. There is no compulsory screening of these children when they come to the clinic as such, and also the follow-ups. And during the follow-ups, there are a lot of other psychosocial factors also, which are not, carried out properly. That's what I feel. Only we focus on the medical management, like the surgical, post-surgical life and all. So a lot of other psychosocial factors are left like that only. So there should be a teamwork, a collaborative work in each, I feel, in each hospitals. There should be a multidisciplinary team which take care of these aspects. Yeah.
Thank you. I believe Dr. Kristen Verite is here with us, and so I'm glad Dr. Bindu brought up that thing about lack of screening here in India. So Sonam was asking me, like, this would be a question for you, like, how do you screen for neurodevelopmental post-congenital heart defects in your post-congenital heart surgeries in your center, and then how do you also integrate that, with a multidisciplinary follow-up in your system?
Thank you so much for asking me that. Firstly, I would just like to say I've heard so much inspiring, innovative thinking. You're truly leading this whole, you're leading the world in how CHD is managed, I think, and thinking about those long-term outcomes and systems to address the problems. I think we're going to be following you. And I would say, I do not see, and I talked to Dr. Manu about this as well, in Edinburgh, in Scotland, I don't think that we do have the care pathways and the thinking that you have. The closest that I can give you, though, to think about how to identify the vulnerable individuals within a very vulnerable cohort from a kind of psychological perspective, the closest that I can come to is thinking about the developments that we've made in Scotland and particularly in Edinburgh with regard to the epilepsy population, who are also extremely vulnerable to neurodevelopmental issues, emotional issues, and identifying this population has been a big part of what we've been building on for the past 10 years. And what we have is a system now which allows us to screen for neurodevelopmental very, very quickly, to screen for neurodevelopmental features and emotional difficulties, classroom learning, home impact, peer relations impact, using a web-based questionnaire that we've developed, which is based on the Strengths and Difficulties questionnaire, which I'm sure that you'll be familiar with, and I'm sure that there'll be an available version of for yourselves in India. And basically what we have with this is a online questionnaire that we send out to families and is completed by the family in advance of any review appointment. It could also be done at local clinics, and you could have the information sent to you. It's scored at the time, and the information is communicated in a kind of traffic light format, as well as a full breakdown of all the answers that have been given by the family about the child's profile. And this occurs at every epilepsy review appointment. So the clinician has this data available to them at each appointment. You can chart the individual progress of the child over a number of years, and you can see whether or not interventions that you're putting into place are effective in a very broad sense. And this is a system that we call psychology adding value. And initially it was PAVES, psychology adding value epilepsy screening. Now it's psychology adding value early intervention system, because it allows us to find out what the needs are early and think about what interventions we can put in place and monitor how that's working. It also gives you a large amount of information automatically without any additional clinician time required, that can then go onto a big database and allow you to look at the cohort as a whole or changes over time with a population. So we found it really useful in Edinburgh. It was then adopted by NHS England, and we're now thinking about a national rollout for epilepsy. We're also piloting it with kids with diabetes. So again, I wonder if there's any validity in looking at this model, even if you don't want to use PAVES, just thinking about some sort of model And again, it would depend potentially on things like accessibility and internet access, but potentially it could be used by, on an iPad in a hospital, in a community, rather than people having to come to you, or they could do it remotely from home, or it could be triggered by parents who are concerned, could send you the information, and it gives the beginning of a conversation that sort of structures that dialogue, cuts to the chase for the clinician who's reviewing the child.
Thank you, Dr. Kirsten. Dr. Manu, let me ask this question to you. Like, we've talked again about pediatric survival post-surgery. So when there is so much of improvement in outcomes, is the community geared enough to kind of give continued continued neurodevelopmental care in India?
I think the community expects the government to take up the lead. The problem is we have DICs. It's more generic. So if you look at our children with congenital heart disease after operation, they have a particular kind of signature. I mean, it's okay to get general care, but I would say a dedicated clinic like this is resource intensive, but we are okay because we have that many number of patients happening here. Small centers, this is not going to be a scaling up thing. So today morning somebody was mentioning, I think KOCHI was mentioning, like we have to have places where these people can gather for short things, because in India ultimately everything boils down to the economics of it. Such a clinic need not happen for 30 days in a place, but once a month if it happens in 12 medical colleges, that's 12 regions covered. I mean, I'm giving you an idea, sir. If we can have weekly or monthly clinics like this across this country in a phased manner, we're going to see the lives of these children change into different horizons. I've seen, because initially I was very reluctant with the interventions when she used to give us ideas. I was like, show me evidence. And each time the baby is coming, the task is changing. I saw evidence in front of my eyes. And now I'm convinced, and the biggest problem, along with that, we pediatricians have a feeling we know developmental pediatrics. We actually don't know it. We are not taught this in med school. The book of Illingworth never happens in MD pediatrics. I mean, Balu will certify to that. It's there in the library. My first copy came after this one landed in our department. So we started looking at that, and we would say that from the medical education part, there is a gross deficiency of developmental pediatrics, and suddenly we reappear as developmental pediatricians. That's not be the case. We should know what is happening. You ask this question to 100 MD students, nobody will have an answer to the developmental signature of post-cardiac surgery, 100%. Because nobody is taught, nobody is trained, and if the pediatrician is not seeing, it's going blind, right? So we need to train the pediatricians. We need to have this kind of clinics in medical colleges, and government needs to invest at least some bit of money there. Just doing surgery is fine, but invest something beyond that also. I think KK sir would have a different view on it.
Yeah. Different, I'm in agreement, but the thing is, sorry, can I just, we have a problem. Our entire, and I think Kirsten needs to listen to this as well. I think we have a real problem in this country as far as medicine, reimbursement in medicine goes. The way the government looks at it, the way care providers look at it, and the way doctors look at it. Our medicine is procedure-based, not procedure-centered, not patient-centered. So everything that's, you do a surgery, you do a procedure, you're compensated generously. You set up a system to change the developmental trajectory of patients, that is just not compensated. That doesn't come under the ambit, doesn't come under the thinking of the whole collective fraternity. Despite no matter what RBSK has said, everybody is just out to do a procedure and say goodbye. Nobody is looking at the child. So we have to change that entire set of metrics and the paradigm. Only then we can actually give importance to this kind of an effort. And that is unfortunately, the trend is quite well established now. We are intensely procedure driven. So I don't know how that can happen, that change.
Sure. Move on to Dr. Brijesh. Dr. Brijesh, like in a routine clinical follow-up that you do of your patients and families in the OPD, how difficult is it to integrate neurodevelopmental, follow-up into your routine follow-up? And what would you suggest as an alternative for that?
Actually, it's not difficult because of the fact that, see, if you see, if a parent comes with the child after surgery for follow-up, the first thing they would be looking at is how the surgery is there, how his heart is performing. And once you do the primary evaluation with an echo and clinical evaluation, everything, and you say that everything is doing fine, then the next question which invariably comes is, how is the child going to be in future? How is the child's development is going to be, whether the performance, that invariably comes in. And the general, prior to the era, if you look at some couple of decades prior, even when our training period, the general thing is child will do fine. That's what all you say, and the parents take it and go back. There is hardly any follow-up. And the other problem is, whom do you refer? That's one big problem. See, when they are going back, what you say is you just go to a pediatrician, and the pediatrician would invariably say you just go back to the cardiologist, and they don't have a place. And the other major issue which we face is, if you see the syndromic children, the incidence of congenital heart disease is very high in them. So these children definitely has a developmental delay, and neurodevelopment delay becomes very important there. And then again, for these patients to go back, if they have a cardiac issue, they invariably get shunted between. So to have a dedicated neuro, it's actually making a change, because now when they are coming to our OPD or we see them in the periphery, we have a place to refer them. And then we find that parents really want it and like it. So it's not at all difficult.
So now you're able to integrate it within your own system. Because I think that is what is important, other than, referring them outside the system. So Dr. Balu, should developmental follow-up become a standard component of CHD care protocols? And as a fetal cardiologist, when should that vulnerability kind of assessment kind of start?
I will answer the first question. I think developmental follow-up is mandatory. It's a part of any child's follow-up, whether it's a normal child or a child with the CHD. It should be done for every single child. But the problem, as Manu said, pediatricians very often they don't do it, because we are not. I am also a pediatrician, so we conveniently avoid. We just ask some very basic questions, but we don't go into the details. So I think, as we discuss whole day today, parents only observe and they bring it to our attention, and then we try to do something. But I think it should be a part of every single case. Whenever a pediatrician sees a child who has undergone CHD surgery, and a developmental assessment is absolutely mandatory. And if there is any delay, such patients should be referred to the experts. Now, regarding prenatal period offers a great opportunity for screening, because we do have absolutely solid protocols now. Every screening starts from first trimester, where we do the nuchal translucency and the first trimester genetic screen. I believe this is perhaps the most significant, healthcare policy implementation which can be done, because at this stage you can actually pick up quite a lot of abnormal cases, especially multi-system problems. Now genetic tests are available, and as we discussed in the morning, whether parents should know, I think most of the parents prefer to know. They are better off with the information. So as just now Dr. Brajesh said, it's more challenging for a child with a genetic problem, because in such cases neurodevelopmental problems are clearly almost inevitable. So we have an opportunity to screen, number one. Second thing is, of course, interventions in utero, nobody has studied. There is data suggesting that there is a reduced brain volume in patients with CHD, altered cerebral blood flow. There is some data from Boston saying that these could be innate and perhaps less modifiable. I would not use the word non-modifiable, but we don't have large-scale data. Ideal study would look at prenatal brain and follow them up longitudinally after birth and try to see how much it impacts long-term neurodevelopment. Only if we actually try to identify the problem, we can look at interventions. I don't know interventions, as Dr. Arun said, reducing maternal stress. There is a lot of studies on placental physiology now, whether we can try to improve maternal nutrition with an aim to improve the placental physiology. Those are all highly theoretical, no clear evidences. But I guess we may have lots of windows of opportunities.
I'll just add one small thing to what Balu said. It's we're making recommendations that everybody should have. It's not practical. I think we should risk stratify. Every single child with congenital heart disease need not undergo a developmental. A child with a small VSD need not be subjected to a developmental assessment. That would overwhelm the system. We have data. Our study now has 2,000 or 500 patients. We know who's most vulnerable. Let's mandate for those vulnerable children a comprehensive developmental assessment. For those children where they're really low risk, I think we need not go too far. So even within the operated subset, it's very clear, the post-op VSDs, the post-op ASDs, the beyond infancy surgeries. There is a large list of conditions where children are doing relatively well. I'm not saying they should be taken away from the ambit. We could have a more easier screening system for them, more rapid screening, but a thorough evaluation for the ones we know are going to be more vulnerable. That way we can make it rational. And in fact, the data that we have collected can inform a national policy for these patients, and every center can adopt that.
I completely agree. I think the focus should at least begin with those who are palliated, where you have still residual problems, maybe like complex univentricular hearts, those with genetic conditions. These clearly should go through a proper protocol. For the others which are like totally corrected, it should be like just like a general population. We don't need to put them through a strict protocol. I completely agree.
On the question of policies, Dr. KK, I'll ask this question to you. I think there is, how do you think India can maintain like multi-center registries to track neurodevelopmental outcomes, and what kind of data from that would be useful to kind of advocate for policy?
I think we've just done that. We finished multi-center registry. It's not difficult at all, because with today's technology, with very small level of investment, we were able to collect very comprehensive data on 5 centers for all children, infants operated with CHD. So it's possible. We could again simplify that registry based on our experience and collect what we think matters rather than collect every data. It's not very difficult. It can be converted into an app, and it can be then centralized, and it can be anonymized. It can respect patient confidentiality. Everything is possible. So that process is actually very easy and inexpensive. We can definitely do it for a host of conditions today.
I think Dr. Kirsten wanted to say something.
Yeah.
Can I jump in, because I absolutely hear what you're saying about being able to identify risky cohorts by what you know has happened to them physically. But at the same time, I was also hearing today that, sometimes some children do really well despite, and we saw people speaking, about children who've done really well despite being high risk. And then, other children, I'm sure that you as clinicians would have children where you would presume that they would be fine, and actually their outcome isn't so good. And I guess that it sounds as if a stratified approach is what Dr. KK was talking about, but maybe along with knowing your risky cohorts, there's something about having universal resources, which I think you were speaking about yourself, Madam, in schools and so on, just identifying this as a at-risk group, and these are the sorts of resources that are useful for them, but also having some sort of very basic, non-arduous screening process that allows you to see that within your cohorts, who is high risk, who is suddenly looking like they're showing difficulties, in which case they might be taken off to have additional assessment. But your low risk group, at least you might have a profile with them that would allow you to have a slightly more targeted approach to what local resources would be most useful, what might be additional information you would like shared with the families or the schools. And again, not necessarily a full assessment by psychology, or having 6 sessions of therapy, or having an educational psychologist or therapy, but just being aware when problems are emerging and having stratified and stepped interventions. And that's something that we do have within PAVES, and it's all fairly cheap. And I think that's the other thing we were talking about, is this requirement to be able to make a health economic argument, which is what really has changed the way that we're being funded for our particular project, is saying, if you spend, then you will save down the line. You know, if you get the right intervention to your population at the right time, and you are able to identify the most at-risk children and families and put in intervention, you can turn their lives around. And that can make a huge difference down the line into successful individuals who are able to contribute to their communities, contribute to the economy, versus, you know, the alternative. So I think maybe that, I hope that that is useful to put that in at this point. Thank you for coming to me.
Thank you, Dr. Kirsten. Dr. Arun Singh, could you let us know, like, I mean, you already alluded to that in your presentation, how, like, national programs such as RBSK could integrate CHD neurodevelopment into their implementation?
See, I think anything which you make doctor-centric will fail. No, because see, just imagine, each one of the pediatric cardiologists here have to see 50 patients. This is in a sector where people are coming, they have to pay. Now imagine, so I believe doctors are not trained for screening. The word is screening by a generalist, management by a specialist. So the screening, the entire development should be screened by whom? And there are plenty of people. You have not trained them. RBSK is not failing because you don't have developmental pediatrician. You don't have pediatric optometrist who can see a small child. You don't have pediatric speech therapist. You don't have pediatric clinical psychologist who can use the tools. So why don't you give them the leadership? Why do we think that doctors are the ultimate leaders? This can go with sensory gardens, etc., and they will do a wonderful job. So I think we unnecessarily try to make that, okay, this will be run by a doctor. Now, doctors are more trained to perform other things. This is more of a routine. Yes, if there is a problem, a pediatrician must be a part of the team. He can be a leader, but the whole job of screening, my idea is DIC failed because the manpower, the money is there, instruments we have designed. Where is the training? Which optometry school teaches you to see a small child? Which speech therapist teaches you to see? So you see, the whole idea is, if institutions like AMRITA can turn out a manpower of what you call now the allied sciences, they are so critical. If I had enough people, I would keep a psychiatrist or a psychologist, not a psychiatrist, a psychologist there. So when I interviewed psychologists, believe me, at AIMS Jodhpur, I could not get anyone who already knows it. So because the psychology institutions are run outside the medical ambit, they are run in all other universities. So just the point I'm trying to make is two things. Number one, institutions like AMRITA, which have taken the leadership, now should think of training people in the art and science of this. And secondly, it should be not doctor-centric. Doctor can be a leader. It should be centric to the people, and only cognition. Don't mind, ma'am. I mean, for short, actually I had brought the video. A child had been diagnosed from USA, the Indian, as autistic. The child is carrying all the features. They came to me and I said, get your optometry vision testing done. The child had a vision problem. The moment you give the specs, the child gave a social smile to the mother. So you see, sensory organs are windows to the brain. And you have to evaluate all the sensory organs before you give a diagnosis. So I think that kind of thing, if you can develop, the most important thing in India is manpower. If you can develop such manpower who are trained how to take care of small children, it will succeed.
Thank you, Dr. Aronson. So I think we've kind of asked the questions that we need. So in order to sum up, I'll just ask each one of the panelists to take a minute to talk about, in just one sentence or one word, in the next 5 years, what is the one concrete step that you think we should take in order to strengthen the neurodevelopmental care after congenital heart disease surgery in India? Just one concrete step, if each one of you can just pass the mic around. What do you think is the most important one step?
Surgeon also to be integrated into this program. Be aware what is available so that we know how to get integrated. It will actually improve our practice also.
I would say the message I got from the children who were suffering from, that ultimately we are our brain. So long, whether we have CHDs or no CHDs, we are the god of ourselves. If we can utilize the 100 billion neurons, this country will be far more richer than all the wealth we can think of.
I would put my money in training clinical psychologists in the very small children, because we have been interviewing clinical psychologists. Some of them are already here, and I would say the knowledge they have in dealing with small children is deficient. They are all good with adult patients. The pediatric part is deficient. I would put all my money in saying that, okay, these are there is epilepsy, there is CHD, you train them, they take care of a good portion of the job. So in our clinic, I would say 10% or 20% is what our involvement is. The rest is done by 2 psychologists, perfectly fine. But there are very few of them who have got the exposure. So I would ask clinical psychology training programs to have a special focus on very small children, all their problems, developmental delay, their behavioral issues, learning, everything. Have some emphasis. There should be a surge of pediatric clinical psychologists in this country. This will be taken care of that.
Oh, you got one.
In my opinion, I would like to say sensitizing the population, like what CHD is. And also, sir was mentioning about manpower. That is very important. And also training. A person who has trained well in this field should come forward and join the team. That's another important thing. We have very less people who are trained professionally. That is one of the drawback here. Yeah.
For me, I think what we can do is at our level, tertiary pediatric cardiac care, once the surgery is done, we can try to triage patients then and there and try to identify the high-risk groups, which will definitely benefit by specialized care. So I think that is something we should probably do. And then when the child goes back to their pediatrician who's going to look after the child on an everyday basis, some kind of a message should go to the pediatrician that, look, this child is perhaps more vulnerable than the others, and maybe such patients you should keep a close track, and then the entire other armamentarium which we have been discussing perhaps should focus on such patients. That way we can actually, there are too many patients and too few of personnel, so whatever available resources can be more efficiently utilized towards care of those who really need it.
I'm going to be very, very practical. I don't think I can speak for the nation. What we can do is in our own center. Okay. So what we've got data on 2,500 children. We've got 6-month follow-up. Now we've completed 1 or 2 year follow-up. We will identify the high-risk cohort, suggest interventions, develop a tailored plan for them, develop a plan for the low, so what we think is low-risk category, make some good recommendations, maybe convert it into an implementation science project and see if we can apply it to much larger numbers of children operated at other centers through ICMR. So that's a potential area where they would fund, and then make recommendations to the government. translating these recommendations into policy, we all know, it may or may not work, and it may be just a wishful thought, but that's the best we can do.
Dr. Kirsten, would you want to go on one recommendation? Yeah, exactly.
Please, please. I have to say, I feel like in the next 5 years, I suspect that India is going to lead the world in terms of developing systems that integrate some ways of identifying and meeting the needs, particularly neurodevelopmental, mental health, educational needs for the young people surviving CHD and their families, because I think this is a wider systemic situation. And I think that you will be showing us how to get the best possible outcomes for these very vulnerable kids.
Thank you, Dr. Krishnan. So just to sum up and just to kind of look at the way forward, I think we all have agreed that congenital heart disease is a lifelong kind of a care requiring kind of a defect, and it's important to look at a child holistically. And when you talk about looking at the child holistically, it is what has been discussed today in the panel. It's important to give a patient-centered, family-centered kind of a care. There is a need for early intervention. At the same time, like Dr. KK has said, risk stratification has already been made. So look at vulnerable children and start working from there. But at the same time, maximize resources, like how Dr. Balu has said, utilize the pediatricians in the community to kind of engage them to follow up and keeping an eye on developmental outcomes. At the same time, I think there is a need for multi-sectorial, multidisciplinary care to get engaged. And I think the team should comprise of not just the cardiac team, it should also comprise of pediatricians, developmental pediatricians, clinical psychologists, social workers, and whoever else, as the need may come, being involved into this team. And this is important for a kind of a collaborative and cohesive effort for a continuous and comprehensive care for children with neurodevelopmental delays because of congenital heart surgery. And policy level discussions, I think they've already talked about registries and how it is important to use the data therein to kind of work on policies, so work advocacy frameworks and so on. I think. Sonam?
We'll wind up and then what of thanks.
Sorry. I'm Dr. Aparna from Speech Pathology Department. I should begin with thanking the whole team who have conducted this because I see that the team has already put their heart into the developmental aspects of children with childhood heart deficits. I'm so happy that this is being highlighted, the developmental aspects, and while this cardiology team understand the importance of developmental aspect, there are also many other disorders who all, like many other surgeries or many other medical conditions who are also at developmental risk. So as an SLP, I'm also concerned about other kids. So there are also many conditions in which parents come to us with a delay in speech and language, and they tell us, and we do ask, like, have you ever been to a pediatrician or have you ever been to a doctor? And they were like, no, the child didn't had any issues, so we haven't went. Or if they have went, then they will be like, that's okay, they will speak. So I do understand the responsibility of creating awareness from our side, but also I'm just curious, kindly correct me if I'm wrong, but if just curious, like till 1 year of age, as parents take the importance, till 1 year, I'm not sure, like they take the importance to get the vaccination done, the developmental chart to be followed and all. Till 6 years, can there be a developmental follow-up, either with a developmental therapist or someone like that, on a yearly basis or something like that? So like as at a national level, for everyone, like so that everything can be detected. I initially thought of like having a research wherein a checklist for screening can be initiated at a school level. And then I searched and I found RBSK already a checklist is there, which tracks all the kind of development, like motor, cognitive, everything, speech and everything. So that is already there. Then I was thinking, like, then why are we missing? Can it be like a 6-month follow-up or a 1 year follow-up to a developmental therapist until 6 years? a national program, like something awareness to everyone, so that at some point someone will seek a professional help and get improved.
Okay, it's very ambitious, very nice, but it's not going to be easy. I'll give you one example. We work in cardiovascular. We had recent screening for fatty liver in school children. 300 children were identified to have at risk of fatty liver. We offered free blood test and everything. 15 people came. So it is what the parent perceives as important. Fatty liver is not important for an adolescent. All of these children will go into become diabetics by the 25, 30 years, heart disease, everything is there. And of the 20 people came, 9 already have fatty liver at various stages. We have identified problems in half of them who came. That means 150 children are at school who has a problem, who are going to be having at a high risk thing. This is the attitude which has to change. That is because there is no awareness. So your idea will work if there is awareness. Second, if it's scalable, like Sir said, if it's away from the doctor kind of thinking, it can be done at a very basic level, like people who are there in plenty, and they should also be trained for that. I mean, it will happen, but a lot of factors need to play into line.
We have one more question, is that okay? Last question.
Hello. Yes, thank you for this opportunity. Since from the morning, I'm starting from myself, Deepu Gopal, and I'm along with my colleagues. We 3 are development therapists. Actually, we are working as development therapists since from the last 2 to 3 years, and we are from NAPMR, Thrissur. Okay, so for the last whole day, when you are hearing about the trained professionals, when I don't think Sir told about we need people who are trained for some particular level of assessment. Development therapists and early interventionists are the whole core role for them is to do the same thing. Because yesterday we had a camp on Bailey scale assessment. So Bailey scale is done usually for the assessment from the child who is from the 16 days onwards. 16 days onwards to the 42 months. Which means the child can be assessed from the 16th day to till the 3rd year. So, I don't know how many people have heard of a term called development therapy and development therapist. So I will just taking 2 minutes. Development therapist is someone who works. The term I would like to more focus on that, but the one who works on holistically, which incorporate speech aspect, expressive and receptive, then gross motor, fine motor, psychological aspects, and play, sensory, everything will be addressed on a basic level. When we are looking at a vast point of sight, just like in a hospital, we'll be having lots of specialists. They'll be having a cardiologist or ophthalmologist. They'll be having lots of specialists, but we have also a physician also. Just like, it's a thing like, when we have a specialist for each kind of domains and modalities, we should be someone to integrate also. So development therapy is someone integrate, like a transdisciplinary approach. We are following upon a multi-dimensional approach. Multidisciplinary approach is what we are focusing right now since a long period of time. And for around last 20 years, it's slightly change is happening. Interdisciplinary have started. And the last 5 years more, it is up to transdisciplinary approach is what is happening, which means at one point a person will be more integrating with other colleagues also and having the information from them, and he will be the one, or he or she, that particular professional will be taking in charge to orient the parent for the same thing. Actually, any parents will be easily, they won't be ready to purchase the same thing which they are seeing in the almara or cupboard of a particular speech therapist or any therapist, but they will be able to do the same kind of therapist in their home if they are more empowered on that. That is what a development therapist and early intervention does do that. So I would like to tell that in Trivandrum CDC, they are doing the same thing for the last 10 to 15 years, and I don't know exactly the range period, but there are people coming over there. And I'm from Chennai, not from Chennai. I've completed my early intervention of PG diploma in early intervention from NAPMR. This is what we are doing of the same. So if just sir told me that there are around 2,500 students, I mean already children which already gone for that, development therapists can be a part of that, sir, so that we can do the same thing. And why? Because there are screening which can be done within 25 minutes. The Denver can be done, TDSC, Tripartite Development Scale, can be done within 15 to 20 minutes, sir. So it can be easily accessible for that. If we are having a 3 months, we can do all the assessment for this all 2,500 students.
So we'll come and work together on this area in terms of how we can translate the results of what we have seen in our project to ground level implementation for all future patients through the government. Again, we'll have to work through the government if it's possible to integrate it into Hridayam, recognizing all the challenges we are facing right now. But that is something that actually we were on the threshold of. Just want to tell you, Dr. Srihari, at the time when Hridayam was at its peak, we had already drafted the plan for this to be done, exactly using you guys, and that was the plan. Unfortunately, at this point, Hridayam is faced with a lot of financial challenges. As a result, we're just waiting for the government to change, or not necessarily the government to change in parties, but at least the health ministry to become active on this area again. And then we will implement it.
So if the government should be looking back to us, they'll be having some kind of pilot study, no? Can we do that?
Not required. Pilot study we've already done. We've got data. We know who is at risk. What we have to do is to develop a package for intervention.
That is what is called the therapy.
That,
sir.
yes,
exactly,
that
sir.
we will do it through an implementation science study. It would be a pilot initially,
Exactly, sir.
then would be implemented across the whole state, which we had already planned. Unfortunately, we are not in a position to execute it right now. We just have to be a little patient for a couple of months.
Sure. If resource is which blocking right now, we can say that 3 people are already here, sir.
Resource is not going to be an issue. Thank you for volunteering, but resource is not going to be an issue. Because this part is a very low-hanging fruit. It's not expensive. The surgery is expensive. But what I was saying just now, we have become too procedure-centered. We are not patient-centered enough. The whole Hridayam, everything has been, everybody, all doctors, everybody has been talking about doing the surgery, not enough about what should be done with the patients thereafter. So it's all within it's there. The whole thinking is there. We just hope that the environment changes, that we can revive the whole thing.
Sorry, it all got delayed by a bit. It was a wonderful day of activity. I mean, we've been planning this for like 3 months, and it was nice to see a very serious crowd. And I could see fatigue only towards the end of that, because 80% of the crowd was static. That means something useful was being discussed all throughout this one. My job is to say word of thanks in a minute. So, I mean, the blessings of Amma and this institute, I mean, this is a golden place to learn and practice. That's the first message. I have to thank the institution first. Then my mentor is sitting there, KK sir. I mean, I still remember the first time I came with that gainer paper and he said, Manu, write a 1 page, we'll send it to ICMR. It was in the fridge for some 17 or 18 months. Then one fine morning we had a call, we had 5 centers, and now we are at 2,500 people from 5 centers, and we are looking at the next stage. It was wonderful, sir, and he saw the opportunity the very first time I showed him that paper. That's vision. So thank you, sir. That's a start. Then, and their department has been working very closely with this. Balu has been completely active today for this one. Shine was there. And all these kids are operated, Brijesh and his team. I mean, we have a very good surgical team, and that also helps us a lot. Because, you know, ultimately, the output of the surgery decides their attitude towards us. They come back because they had a wonderful surgical experience there. They have good medical setup there. Thank you, Brijesh. And I'm seeing Arun Singh sir for the first time, but he has opened a lot of ideas and he has told a lot of holes exist in the way we think. So we are going to plug all those holes, sir. Thank you for all the advice. Dr. Bindu, I'm very thankful for your support out there. Veera, You've done a wonderful job. She was here all throughout, and she has been a constant support for this entire program. And nothing goes without saying thanks to my own team. The backbone is standing there quietly, very humble. Sonam is the lead of this one. Ardi is there. Ardi is the second backbone. And then we have our Kuti interns there. We have Abhish who has just left. We have Parvati who has been taking care of everything. Where is Parvati? I mean, our team is fantastic. I'm not saying biased. They are fantastic. They have been working up and down for the last 2 weeks. Give a big round of applause for those teams. That's fantastic. And we have our patients, we have our parents, we have the lived experiences, our audio-visual team. Everybody has done a good job. I'm so happy. I'm going home with a lot of satisfaction. Thank you all. This is just a start. We will meet again. Guys from Trishur, we are going to talk to you guys. Everybody, you will see us again and again, and you will come here, we will learn, and we'll do something. And like Kirsten said, sorry Kirsten, a big thank you for you, because we discussed this idea back in Edinburgh like a year and something back, and she said this will work out. She was so confident that we get funding. We got funding later. We had a query for that. Thank you, a big thank you for. I'm sorry that you were on screen. I missed you out there. And thank you all. See you soon, and God bless all of us. Thank you.